контракция верхней. С момента оператора хирурга идет, а ассистент у нас, он натягивает кишку, вот видно краниально в сторону диафрагмы. Также продолжается у нас мобилизация по передней стенке прямой кишки. Все это делается, отмечу, хуком. Не использовался у нас ультразвуковой диссектор, потому что из-за фиброза тут и так газы скапливаются, и если использовать ультразвуковой диссектор, очень много стенка прямой кишки. Может быть, Здесь уже у нас заворачивается кверху, у нас прямая кишка. Задняя стенка у нас не полностью у нас была мобилизована между гастральной. Стенку. Тут, так как уже пространство меньше, запотевание камеры больше, и приходится чаще его сложности сталкивается хирург, что запотевает у нас камера. У нас нету специального входа, который бы убирал газ, только ассистент второй свой левый мезогастрий может открыть пятерку 5-миллиметровую, чтобы воздух выходил. Вот, хирург своими двумя инструментами работает, создает сам себе тракцию. Ассистент второй снова натягивает ободочную кишку, краниальный. Продолжается у нас диссекция по правой стенке мезоректума. Вот снова запотевание. Тут у нас согревается камера. Вот такой. Мезоректуму не выражены, либо тракцию создать тяжело. Тут хирург сам оттягивает кишку краниально, ассистент тоже помогает, создает контракцию. И по правому верхнему стенке у нас идет мобилизация мезоректума. Монополярным хукером также. Ну и хукером как бы быстрее будет, наверное, операция по сравнению с ультразвуковым диссектором, либо тем же другими инструментами, биполярным коагулятором. У нас вот фасцию тут хорошо видно, прям по ней работает хирург. Мезоректум у нас хорошо отходит, без проблем. Так как опухоль у нас никуда не порастает, также это в нашу пользу это работает. Ну, тут, в принципе, как мезоректум 60 миллиметров и
Спасибо большое. Куда вы ушли? Рустем, вы как самый опытный колопроктолог.
Ну,
только,
я могу сказать,
не только
что...
среди нас, но и среди...
Нет, я не считаю, но я просто хочу сказать, я вот сижу, думаю, смотрю, когда вот сидишь и видишь хорошую, красивую операцию, хочется вот завтра пойти в операционную. Вот у меня сижу, мне в операционную хочется скорее попасть, потому что...
чувства были.
Да, поэтому я поздравляю, прекрасная операция. Единственное, что вот я, не знаю, вот во время наложения анастомоза низкого мы для себя сделали какой вывод? То есть мы стараемся сейчас не натягивать, да, во время, потому что там идет натяжение тканей. Мы всегда стараемся уже при соединении головки чуть-чуть затягивать аппарат на себя. И это дает то, что снижается напряжение на ткани. И иногда уши, особенно если это культя чуть подлиннее, уши сами уходят. Мы потом нашли статью итальянских авторов о том, что это вот их предложение, то есть забирать, натягивать. Но в целом, я хочу сказать, очень красиво, очень достойно, мне очень понравилось. Спасибо.
А у меня мысли были такие. Спасибо Амжаду. Все это вот
Да.
откуда-то оттуда. Да?
Я
вот.
хочу сказать, да,
Другим людям, которые вот это
настолько
Алексей,
все
да,
стандартизировано, настолько что
Один
высокий
вопрос
стандарт.
у меня был. Вы вот фантастический хук. Мне захотелось хуком начать оперировать, потому что я не настолько талантлив. Я старался, у меня не получалось, я все это делаю вот обычными девайсами. У меня один вопрос. Как вы обработали мезолектум в конце? Вот я просто ждал этого момента, а он у вас обрезан.
Ну,
То
там,
есть
в принципе,
это
в конце,
тоже хуком или
да,
все-таки?
нет, это все хуком проводится.
Все хуком,
Там,
то
да,
есть вообще не используется.
да.
Наверное, ваш работодатель счастлив, потому что вы вообще не тратите денег во время этой
В
операции.
каких моментах, да, приходится там.
Спасибо большое, очень
Спасибо.
классно. Спасибо. Следующий доклад у нас это торакоскопическая редукция пищевода, очень интересно. Нуртас Айдагарлиевич. Нуртас, слушаем вас.
Доброе утро, уважаемые коллеги. Добро пожаловать в Казахстан. Добро пожаловать в наш центр. Всех рад приветствовать. У нас время ограничено, из-за этого я сразу начну с видео, потому что там несколько.
Нет, это все он.
Спасибо. Арман, можем видео включить? Ну, пациент 57 лет, диагноз рак нижнегрудного отдела пищевода, по ФГД 30 сантиметров от торцов, по КТ тоже нижняя треть пищевода, в 4 степени. И первым этапом мы провели лапароскопическую гастростомию, вторым этапом химиолучевая терапия. После химиолучевой терапии он пришел к нам на операцию. Мы здесь установили, пациент лежит при наклоном вперед. Обычно мы начинаем с верхнего отдела пищевода, потому что то есть, новыми силами, и начинаем сверху. Наши ориентиры здесь трахея, вена азигус, потом повредить. Сейчас выделяем вот, между трахеей и пищеводом. Здесь надо быть очень осторожным, потому что имеется мембранозная часть трахеи. И четыре порта, три порта, один порт по передней аксиллярной линии, это 5-й межреберье, потом 8-й межреберье, задняя аксиллярная линия, и средняя аксиллярная линия в 3-й межреберье. Это 10-миллиметровый, и 4-й порт для стента это 5-й межреберье, 5-миллиметровый порт. Ну, пищевод выделять сперва мы начинаем спереди, от трахеи, сверху вагуса проводится, скрывается плевра. Далее мы сзади скрываем плевру. Здесь у нас удаляются лимфоузлы 106 группы. Мы здесь должны увидеть возвратный нерв. здесь техника тоже контртракция, пищевод. Если мы спереди работаем, тогда тянем вверх. Если сзади работаем, то тянем вниз.
А не легче тут сейчас вот как-то пищевод попробовать взять на держалку, так не пробовали вы?
Ну, мы пытаемся, мы хотим перейти в ту сторону, чтобы взять держалку.
Все.
Да.
Как давно вы стали оперировать скопический пищевод?
Ну, скопический работает недавно. Вот это у нас 6-й случай. А до этого мы делали по Льюиса. Вот это у нас гортань нерв.
И какие чувства при этом переходе у вас? Вот, что ощущается?
Ну, если честно, это все видно, все понятно. До этого мы даже некоторые мелкие элементы даже не обращали внимания. Ну, вот как мы на скопию перешли, то есть как будто, например, нерв, там, когда открыто делаем, это все мелко и прям сильно не увидишь. А здесь прям большой сосуд, как будто...
Абдоминальный этап предшествует скопическому этапу или сначала скопический, потом абдоминально, потом на шею? Вот это поясните, пожалуйста. Просто
мы сперва начинаем с копии с грудной клетки, полностью выделяем пищевод, с пищевода, то есть здесь делаем резекс, потом переходим на абдоминальный этап. Абдоминальный этап у нас тоже скопический, тоже выделяется желудок, потом делается
выбор, или при переходе на торакоскопию вы считаете, что это безопаснее?
Уже когда мы перешли на торакоскопию, то уже начали, что это безопасно, потому что
на само средостение всегда как бы...
Да, у нас было несколько случаев, когда мы открыто оперировали несостоятельности, лимфореи, то есть это потом мы начали переходить уже. Переходим вниз, тогда мы уже начинаем работать лигашуром или гармоником. Ну, можно...
В открытой хирургии мы знаем, здесь оно тоже спущено, им сложнее как-то? Или
нет,
ваша коммуникация как-то изменилась?
Нет, в принципе, не изменился. Анестезиологи всегда с нами на позитиве. Вот какую тактику выбираем, они прям поддерживают. Ну, мы здесь коллапс легкого создаем дополнительно углекислым газом, то есть здесь постоянно подается, и нам удобно, и легкое пожатое.
Какие вот 6 операций, я уверен, что скоро будет много десятков, вот с одной стороны энтузиазм, и вы осваиваете что-то новое, увидели, ну как и все мы, кто переходит на скопическую хирургию, видит анатомию другим глазом. Какие сложности? Вот первые 6 операций, вот что вы посоветуете тем, кто вот завтра, у меня пищеводов очень мало, водку у нас не пьют, и чай горячий тоже, и не обжигаются так часто. Но вот захотят завтра люди вот начать это, что вы им посоветуете? Вот пройдя вот этот вот маленький, ну не маленький, но вот этот путь, вот на что надо заострить внимание? Какие вот моменты, которые вы уже со следующей операции симплементировали, изменили, почувствовали?
Ну, да, сейчас мы пересекались, но мы начинаем сперва с положения пациента, да. Иногда бывает, потому что легкое всегда падает, и нам то есть визуализация затрудняет, да. Можно в пром позиции делать, тоже очень легко получается. Во второй момент установка портов. Это тоже играет большую роль, потому что грудной клетки работает, это все ограничивает движение, и эти ребра все...
Межреберная артерия, видимо, да?
Бронхиальная.
Бронхиальная. От межреберной отходящей. Как нас Михаил Иванович учил от второй межреберной артерии. Она же, да? Это место.
А кривое обучение сколько случаев должно быть по литературе?
Ну, я думаю, очень много должно быть.
Нет, да, определенное количество? 20-30. Например, у нас при лапароскопическом ПДР разные авторы по-другому говорят. От 25 до 50. У вас есть определенный, например, 20 случаев сделал, после этого ты спокойно уже переходишь, свободно делать. Сказать, что я умею это делать.
Ну, это тоже зависит от навыка хирурга, потому что если хирург опытный, уже начал работать, то есть, давно, он скопически, я думаю, за 5, за 10 операций может это все научиться и все делать.
А у вас сколько всего пищеводов в год в центре?
В год мы в центре делаем 24-25 пищеводов.
Это чистый пищевод или рак желудка с переходом на пищевод тоже?
Нет, это чисто пищевод.
А если, допустим, это кардиоэзофагиальный рак, вы скопически оперируете таких пациентов? И как? Ну, допустим, Зивер-2 классический.
Ну, пока мы делаем только открыто. Да.
Сейчас расскажите, пожалуйста, где вы
Сейчас мы
работаете,
делаем
интересно.
диссекцию. У нас вот, под куком находится правый главный бронх. Это лимфоузлы 108 группы. Здесь тоже опасность повредить правый главный бронх, и должен быть тракция. Здесь, кстати, мы уже камеру поставили с другого порта, из-за этого у нас видно, как будто, то есть снизу, с нижнего порта, как будто посмотрим.
То есть камеру в разные порты? То
Да,
есть...
разные порты тоже меняем, да. Ну, бифуркационные лимфоузлы, стараемся все полностью удалить ее одним блоком.
Когда вот лимфодиссекцию делаете, вы используете ультрасвет, получается?
Да, потому что в грудной клетке лимфоузлы, они такие...
Из-за кровотечения.
10-й группы инфекционных кислот. В таком случае была конверсия. И вот, по несостоятельности именно гастрорезофагоанастомоза не было, была структура, связано то, что вначале мы шили 45-кой, но была структура, мы ее забужировали, в принципе нормально было. Были осложнения в виде панкреатиты с последующим морозильным кровотечением. И
Спасибо большое. Большое спасибо.
Спасибо.
Отличная презентация, классная операция. Спасибо. Оксана Долгоевич, ваша очередь.
Да, моя очередь.
Да. Расскажите нам, пожалуйста, про лапароскопические ПДР. Вообще, ПДРы ну, в нашем в регионе 10, 15, 20 лет назад это был пик хирургии. А вот лапароскопический ПДР это космос какой-то. Ну, во всяком случае, для нас уже. То есть перейти на этот левел. Слушаем вас.
Да, я бы хотел бы в первую очередь поздравить коллеги из Национального центра онкологии и трансплантации с новым зданием. Я думаю, что конференция будет именно посвященной новым зданию. Я думаю, у меня сидят здесь очень много учителей. Я обучался именно в студенческие годы в Астане 7 лет. В следующем уехал в Алмату. В настоящее время работаю в Алмате. Мне честь выступить здесь, в вашей конференции. Спасибо большое за то, что пригласили организаторам. Ирам Аскарыч, он предложил. Вначале был дебат о том, что побольше, полчаса или час видео подключить и обсуждать. Я говорю, это будет очень скучновато, 15 минут максимум. Потому что смотреть долго тоже хочется. Разрешите остановиться на моем докладе лапароскопической панкреатобилиарной резекции. Хотелось бы остановиться история, как мы это начали. Мы первое начали лапароскопической гепатопанкреатобилиарной анастомозой. У нас в отделении много пациентов, которые поступают с рубцовыми структурами после лапароскопических, после открытых операций на желчных пузырях, желчных протоках. Поэтому мы первые 10 операций по лапароскопическому гепатопанкреатобилиарному анастомозу и последующем уже в 2018 году мы были в конференции в Корее. Там был около 6 часов смотрели видео. Одна операция шла роботическим хирургией и одна операция лапароскопическим. И после этого мы приехали, в течение 2 недель пациентов подготовили и сделали первую операцию. И с этого начался наш опыт. Первый лапароскопический панкреатобилиарной резекции. Первая операция длилась более 12 часов. Ну, пациент выписался в удовлетворительном состоянии. Это дало нам пульс. Дальше, несмотря на длительность операции, несмотря на все сложности, которые мы встречали, в последующем буду говорить дальше. Изначально я спрашивал кривое обучение. Это кривое обучение очень важный показатель для обучения специалистов, обучения персонала, все. Для кривого обучения надо определенных пациентов надо оперировать. Поэтому показания для лапароскопических ПДР у нас было отсутствие ранее перенесенных операций, индекс массы тела до 25 и панкреатический проток более 3 мм, потому что мы всегда стараемся делать анастомоз с протоком и без сосудистой инвазии. Относительные противопоказания — это когда индекс массы тела больше 40, когда имеется сосудистая инвазия и наличие сопутствующей патологии. И последние 6 лет у нас было выполнено 272 панкреатодуоденальной резекции. Из них стандартная панкреатодуоденальная резекция была выполнена 206 случаев. Резекция воротной вены было 34 случаев. В последние годы мы практически не выполняем, отправляем на неоадъювант, после этого оперируем. Вот таких пациентов год по течению приходит, мы направляем, например, 10 пациентов, из них только 2-3 приходят на ПДР с резекцией вен, ну, с положительным эффектом. Остальные 80% не возвращаются. Тотальной панкреатоктомии было 7 случаев, и лапароскопический ПДР было выполнено 25 случаев. Вот в течение по годам у нас после ковида резко увеличился, в районе 50 случаев в год выполняем. В этом году уже за 4 месяца выполнено 22 панкреатодуоденальной резекции, из них 5 лапароскопических. Как я до этого говорил, мы изначально начали операции на желчный проток лапароскопических гепатопанкреатомозов. Также у нас имеется опыт объемной операции гепатопанкреатобилиарной хирургии, резекции печени лапароскопическим способом более 100 в настоящее время за последние 8 лет. Лапароскопический ПДР и дистальный лапароскопический панкреатоктомия 44 случая. Общая характеристика. В основном мы здесь хочу остановиться, потому что мы брали пациентов, которые меньше 3 сантиметров опухолей, когда не прорастало сосудов. В основном пациенты были опухолями большого дуоденального сосочка. Вот тракарная позиция, расположение бригады. Мобилизация. Здесь у нас мы устанавливаем 5 тракаров. Всегда основной, который камера устанавливаем ниже пупка, чтобы мобилизовать кишку, мобилизовать связка троицы, чтобы удобно было. В основном резекционный этап выполняется, хирург стоит между ног пациентов. Периодически, если мобилизация по хопперу 12-перстной кишки, если будет сложности, хирург переходит справа на пациента, получается, вместо второго ассистента. Это мы смотрели у корейцев, они всегда резекционный этап делается справа от пациента. Вместо очень это для нас было сложно, поэтому периодически используем вот этот метод. По анастомозам, панкреатовидный анастомоз накладываем вот как резекционный этап, между ног стоит хирург, а гепатопанкреатомный анастомоз перехожу на место первого ассистента. Оттуда накладывается очень удобно. Первый этап мы всегда перевязываем гастродуоденальную артерию и дополнительно клипируем. Почему перевязываем? Потому что несколько случаев было. Мы использовали гемолог, в последующем получили эрозивное кровотечение. И после этого мы перестали использовать гемолог, потому что гемолог тоже повреждает интимы сосудов. И также перевязка очень хорошо помогает при лимфодиссекции, при тракции. Вот именно общепеченочная артерия, собственная печеночная артерия. Сейчас в последующем видео будет показано. Первый этап мы с этого начинаем. Следующий этап мы мобилизуем 12-перстную кишку. Самый здесь много сил забирать, потому что есть нюансы, надо очень аккуратно работать, чтобы не получить повреждение 12-перстную кишку. И всегда стараюсь использовать ультразвуковые ножницы, ультрасижну. При мобилизации крючковидного отростка стараюсь в последнее время использую лигашура. Очень хороший аппарат. Маленькие сосуды полностью можно обрабатывать с лигашуром. Два разных пациентов. Один был худой, здесь пациент с индексом массы тела чуть больше 25. И мобилизация перешейк поджелудочной железы. Вот здесь тоже обрабатываем легочную. Хотел бы сказать о том, что длительность операции больше 6 часов. Мы стараемся, у нас часто используем при трансплантации печени от живого донора, перерыв делать через 3-4 часа. В этой операции мы после резекционного этапа где-то около 40 минут или 30 минут на перерыв. И после этого начинаем реконструктивный этап.
Такой деликатный момент. Вот вы магистральные сосуды сейчас обрабатываете. Были ли кровотечения? Когда
Да, в одном случае был, да.
Как останавливали? Как к этому быть готовым? Какие навыки должен иметь хирург, который вот планирует ПДР делать?
Вот деликатный момент. Я вот лимфодиссекцию после этого случая мы оставляем в конце операции. Ну, не в конце операции, после последний этап реконструкции, это самый деликатный этап, когда мы вот с одного пациента брали, индекс массы тела было там больше 30. Большой, но опухоль маленький был. Панкреатический проток был почти 8 мм. Ну, из-за того, что там очень жирный пациент был, кровотечение мы остановили, но как мне показалось, что там сузился воротные вены. Поэтому пришлось сделать конверсию. И в одном случае был при мобилизации крючковидного отростка повредился панкреатопанкреатобилиарной. Ушили. Здесь техника лапароскопических шовных навыков должно быть на высшем уровне, чтобы вовремя остановить, вовремя поставить, держать и сразу. Если таких нету, то можно получить грозное осложнение. Вот, как я говорю, что лимфодиссекцию мы оставляем в последнюю очередь, что очень удобно. Вначале все мешает, 12-перстная кишка мешает, вот это все. А когда вот уже последний, уже все на виду видно, что там комплекса нет, и все спокойно, аккуратно делать.
То есть вы полностью удаляете?
Единственное, вот сзади ПДР более 30 случаев в год делает центр. Спасибо за внимание.
Пожалуйста.
Вариант вот не делаем, ну, когда протока нет, то только тогда только делаем. У нас еще дополнительно мы не только взрослых оперируем, у нас еще есть пациенты, которые в детском возрасте. Когда проток вообще не видно, то инновационно.
Еще предоперационная диагностика. Сколько процентов диагноз рака ставит?
100%.
100%.
Наши ТТшники обучались, в принципе, они...
Нет, морфологической диагностики имеется.
Морфологическая диагностика, если БДС, 70% ставится.
Спасибо.
А по данным КТ, и потом мы сравниваем этот онкомаркеры, все, и у нас, в принципе, совпадает.
Вы сами онколог или хирург?
Я гепатопанкреатобилиарный хирург.
Не онколог.
И дополнительно онколог. Именно онкологически занимаюсь именно гепатопанкреатобилиарной зоной. Поэтому кишкой, желудком я не занимаюсь. Именно вот направлено к гепатопанкреатобилиарной зоне.
С точки зрения технической обеспечения вот этих операций на таком хорошем уровне. Спасибо. И касательно выживаемости, вы собирательно определяете пятилетие выживаемости. По какой методике? Лайфтейбл, Котель Редер. Ну, понятно, чисто как хирург.
Большое спасибо за выступление. У меня один вопрос. Вот смотрите, мне кажется, что вы подходите очень деликатно и очень вдумчиво к селекции больных. На 24 операции в этом году было 5-6 эндоскопических. И я так думаю, что вы стараетесь выбирать на ПДР пациентов с твердым на этот критерий. И вариантная сосудистая анатомия, может быть, на что-то влияет. Митчелсы. Вот мне интересно, ваша команда как подбирает пациентов? Это первый вопрос. И второй вопрос. Планируете ли вы больше делать скопических операций? Все-таки из 24 5 это около 15-20%. Но я думаю, что, скорее всего, со временем вы их будете делать больше.
Ну, в этом году планируем больше 10 делать. Мы за 4 месяца сделали уже 5. Я думаю, до конца года больше 10 будем делать. Да, очень тщательно у нас идет отбор. Когда панкреатический проток, стараемся больше 5. Там я показал это литообзор, мы больше 5 берем, чтобы было удобно накладывать панкреатический анастоноз и не получить грозное осложнение от фистулы, панкреатических фистул. И, возможно, сейчас мы пройдем около 50 пациентов при лапароскопическом ПДР, возможно, после этого будем расширять критерии. Индекс массы тела, когда больше 30, вот мы, в одном случае я сделал, но очень сложно, поэтому, возможно, мы будем делать это в последующем.
Большое спасибо, нам надо двигаться дальше. Я благодарю вас за...
So thank you so much. We have to move forward. Thank you for being such courageous and that you are implementing such intestinal organs and also in the lab HPV in containers or in the environment of our region deserves the specific precising. Thank you so much. Let's move on to the next chapter. Dr. Valiyev Amir. He is our guest. He's from Kazan, Tatarstan. The laparoscopic metastasis and the resection of the metastasis in the liver. Good day, distinguished colleagues. Before starting, I would like to express my gratitude. I would say that in the part of our speech, and also in a laparoscopic, we will discuss one of them. And also, I would like to tell our undoubtedly
from our center that lots of activities were going on, and despite of this, and we are testing all the possible solutions. So you can see over here, right? There are lots of patients with the different types of exposures. There are approximately 25% of cases, and also 30% of cases which possible the radical surgery intervention, which allows to achieve 5 years survival. And analyzing the various studies, we decided to take only one solution, the meta-analysis, and that's the laparoscopic in open simultaneous intervention under the metastatic KPP. So there were the 13 comparative studies, which included 425 laparoscopic and 756 open interventions. And however, during our activities, there also were some consequences or the worsening of the situation of the patient. And also, we tried the approach of the traditional, and we after that started our conservative therapy, and also there are other. And after that, we conducted the chemotherapy after surgery in the liver. When we conduct or where we do not conduct the chemotherapy at the first stage, and so when we take a look at this slide, and we can realize how the difference is big between these kind of approaches and between the traditional and open surgery and the laparoscopic surgery. And also we conducted that to the patient, and here she has cancer in her and also in so the patient had a good and after that she had a good resorption, and here we can see that she had a rectal cancer, and we conducted a strategy of which it way. And however, by the end of the chemotherapy, after 3 months, there were the progressing, and the patient experienced it in the same segment, the metastasis in her liver. During the study of her rectal, there were some differences, but there were no any morphological changes, and but there was a sufficient tumor, and we decided to conduct a surgery. So this is how we installed our ports, and this is the setup of the resection of the liver, and in a subsequent stage we start the resection of the colon, and we have this kind of shape. So in this situation, the liver was located in a non-standard position. And we can launch the video so you can see everything. Can we start the video? Okay. So, according to routine, we conduct this kind of surgery to all the patients. We conduct also the ultrasound investigation. When we conduct the surgery on the right side of the liver, we mobilize this kind of part is resected, and the right triangle part is partially resected. This provides some mobility to the liver, and we are mobilizing this surface of this liver. Actually, it doesn't take a long time, but after that we can conduct our manipulations, surgeries very easily. And the next stage is, if there is an expansion based on computer data of this part, then we conduct a lymphodectomy. And we didn't conduct a lymphodectomy here. For the isolation of the right part of the liver, we do this, and there are the gate vessels, and in order to in ischemia conditions, and this is the right side of the liver, the lobular part. So these are the bull parts, and we can see that there are the demarcation. In this kind of condition, it provides some safety of the liver. So permanently we do not use it. We use the methodology. We delineate the veins and conduct a resection of the liver part. Do you use ultracision? So do you use the selective approach? How long do you resect? Does it conduct it continuously or stage it? No, we do that all the way till the end. Here in this case, we spent 15 minutes. For instance, something went wrong, or so sometimes we hold the patient for 40 minutes, and after that, the liver stops immediately. The resection of the colon. This is the mobilization stage. That's the regular process. We usually use the scalp. Yes, scalpel. Sorry. So this is the surrounding artery veins. And how do you have this kind of simultaneous surgeries? 15. So the only nuance that we have, we are resecting the colon, and we conducted the small laparoscopy and extracted the substance, and then at this moment we installed a drainage tube over there. As you can see, there are the drainage tube. So conventionally, this is how we do. So we are connecting it to the U2, and here we got our suture, and we have to strengthen the connection, and with the periodization of and there are no any routine, and we conducted the tests. If we have some uncertainty, then we apply. We had an analysis, and 11% of this kind of condition required the application of this kind of suture, and so fistulas are usually covered. Do you usually install? But you are leaving the drainage over there. So if some kind of fistula, so you are sure that the drainage is activated. and we conducted the active aspiration. This allows us to buy some time, and this is the post-surgery condition. This is what I wanted to tell. This is very interesting technology. We can use that for the treatment of the patient with the static colorectal cancer. Thank you so much. Would you please tell, so why you are starting from the liver, or that's the principal position? This is the easiest way or the comfortable way to so the substance is extracted after a while. So this is the contaminated surgery. What kind of simultaneous surgeries you conducted before? The lung cancer. We had one patient where we conducted the resection of the segments 6 and 7, and we resected the left part of the lung. And another question. So that's Saman Zaurovich Mabediyev. He is telling everyone that he is needing or puts the suture over there only to minimize the risks of the perithonet. So we can observe that that person is active smoker. He had a bad life, but you do not apply any. When you are apply, and in what level, there is a two type of the suture. So there is the frontal, the lower part is not installed. If that's the female who has an anastomosis, and if everything is drained and closed, sutured, we have couple days to think how to move forward. And there is a systematic inflammation or the introduction of or receipt of the patient at the early stage. Then we can recover that there is a defect, or we start working on day 4 or 5, or some kind of ischemic. We call that the ischemic activities. It doesn't require the stomy. So you are mostly based on quality of life and evaluate how she is good. And the perithonates, we didn't have such situations. So our colleague has. Thank you very much for your presentation. I have 3 questions. So the efficiency of the new adjuvant therapy, maybe you will share, and the new adjuvant chemotherapy, doesn't it worsen the condition of the patient, or for the search of the metastasis using the ultrasound investigation? So new adjuvant is practically with the colon cancer. They are receiving the new adjuvant chemotherapy, and usually we apply the chemoradiology, and we had several cases with the left part of the intestines, and we conducted the surgery. So the volume of the surgery, the part of the resection of the liver, increases the consequences of the damages to the body. And we conducted the hemogepectomy of the intestines. Then we conducted so it all affects to the cure or treatment of the patient. to conduct the safe surgery, so the patient had a next stage of the treatment. So what was the second question? On the search of the metastasis, it is clear that all the patients are passing the magnetic resonance therapy and computer tomography, and also there is a laparoscopic transmitter. We conducted our studies. We are not looking at the metastasis, but also search for the boundaries of this metastasis if there are any changes. Thank you. Abdul Karimovich, thank you so much. This was very interesting presentation. Colleagues, so the last presentation this is the last presentation of the left part of the gammaglobulinemia with the intracorporeal. Traditionally, I would like to say thank you to the organizers, our Republical Oncology Dispensary. We conduct 1,000 resections to the colon, and 80% of them are laparoscopics, and annually there are 100 and 160 hematumoly on the right side, or 170 is conducted in our department, and 150 of them are the laparoscopic with the intracorporeal ostoma. To realize that the intracorporeal anastomas, this is not all the anastomas, this is the preparation. That's first of everything. We prepare the patient, and the patient should lay with a certain angle of his length, so to speak, to 30 degrees, to the axis of the y-axis, and then we are turning him to the lateral position, and also we unfold or dilate his legs, and making sure that we make sure that that person has a good lying posture. This is the surgeon crew, and we are staying on the left side of the patient. The medic is located, the nurse is located on the left side. This is the regular position, so she could provide her assistance to move the posture of the patient, and in general the location of the thoracal. So the patient was turned to the lateral position to provide to conduct the surgery. And when we are draw the line between these parts, and we installed the 5 millimeter thoracar. I prefer to install the 3 centimeter diameter thoracar because we find it very comfortable for the cameraman. This is very convenient position, and also it is also very comfortable for drainage, as you can see here. So in general, can we switch to the next slide? We can't. Okay, so move back. Okay, one more time. Here you can see that so I think that the laparoscopic chemotherapy is the standard procedure, and we try to move to the upper part to create more visual space. And here, this is the surgeon, which is conducted by our young resident, and we conducted the 12-fingered colon, duodenum, and this is a standard procedure on removal of or creation of the entrance to the embryonal layer on resection of the of the below located vessels, and we can conduct any type of the. We apply all the utilities here, and mostly they depend on the preference of the surgeon, his mood, and to select certain type of the tool, and they can utilize any type of equipment. I'm not going to tell about them in detail. So there should be the resection of the duodenum, but the principles of conduction of the laparoscopic hemicolectomy is the standard. We do the same here, and I'm trying to demonstrate the same procedure with the monomicum, the same manipulations. I'm not going to take too much of your time. Rustam, please explain us. In this conference room, there are lots of specialists and subject matter experts, and they would like to know all the details. This is the ordinary procedure for us, and when we conduct the hemicolectomy, the duration depends on the crew, because for the assistants we have that the doctors that we practically start their career from the scratch. For their the continuous interaction, we conducted this surgery with 2 crews. We have 3 instead of the 3 personnel. We have 2 surgeons, the assistant and cameraman, and on our surgery in general takes 2 hours.
Идет выполнение.
And I'll repeat myself. 160 surgeons per year. For us, it's a daily routine. The most important thing is to visualize the surgery, because there might be some mistakes in during the resection. We can, if a surgeon did a mistake, sometimes it's possible to harm some vessels, and unfortunately, there were 2 of such cases in our department, but thanks God, it was possible to fix that. We fixed the vein. It's gone without additional complications. Now, visualization of vessels. We use the towels. In the 2 lymph resection, since we have this towel, we can work and do not fear that we can accidentally cut a duodenum. In terms of the question, do we always need to do D2? But we believe that 3D dissection is necessary. However, it's a highly discussed issue. Me and Alexei Mikhailovich, we used a trio called Trio, and we discussed whether it's necessary to do 3D dissection. In my practice, I use just 1 clips, and I do not use clips in the gone part, because it's always under control, and the tools are quite reliable. And the same can be done in the 3D dissection. The principles are very similar. As a rule, if a clips is reliable, manufactured by reliable producers, here we can see double clips. So generally, I believe 1 clips is enough. And using a scalpel, it's possible to cut the veins, small veins, without the additional clipping. I will repeat myself. Yes, sometimes there might be some issues when there might be bleedings. However, we can stop the bleeding. Now about the features with intercorporal anastomosis, because in such type of surgeons the cuts are done differently. We done resection in a different part, and it's all done under video, with a video control. First, we process the mantle of the colon before resection, and I'll repeat, this equipment some surgeons use. I mean, Leonid Cherniakovsky, my colleague, he very likes to use monopolar, and each vessel in the mesentery. So I believe that if it's possible to not use clip, then we should do that. We cut the mesentery, then we switch to the next mesentery, and demarcation line is formed near the colon, and then we cross the mesentery of the ileum, and after that we cross the small intestine of ileum. It's all done in the right angle in relation to the ileum, mesentery. Then we cross transverse ileum. The 3 lymphodissection, I repeat. And then we cross the transverse colon. Usually we use 60th cassette. If we see that in the borderline there is some bleeding, we can use we can do manual stitches when the apparatus is localized in the right part. Then we use stemosis. It's all standard procedures. We open the lumen, and unfortunately one of our surgeons, there was such a case when the opposite wall was harmed, was burned. Therefore it's all be done very accurately. We formulate this anastomose, and then we get it stitched. The first stitch is applied in the serous muscle, upper module of the technological hole. After that we stitch it starting from the bottom. We use 2 line stitches. We do not use 1 line stitches, only 2 double. We use polyfilametal or single filametal stitches depending on the preferences of surgeons. The anastomose application itself it takes about 20 minutes in total. Generally, I believe that galectomy it doesn't take much time, because the major part of all the surgeon takes for applying stitches. Here we would like to show how we do the stitches. We using the stapler notes. Some time ago we tried to use other approaches for stitches, but it turned out that it's more expensive, and we decided to use manual stitches, not automatic. If you have some questions for stitches, so we can potentially get stitches automatically using the equipment without manual stitches. Here on the screen you can see the clips in small intestine. A lot of surgeons are afraid. Just this year we had such a case, very young and experienced anesthesiologist. However, there was a failure. He didn't track the relaxation of and before the applying ostomy. As a result, there was a contamination, as you can see on the screen. In such a case, it's very important to get the ostomy up. And after the stenation, we successfully completed the stitches, and eventually, of course, the abdomen was drainaged. Of course, in other cases, usually we do not drainage the abdomen. In this case, it was necessary. One more problem that we discussed with Ilya is the issue of, for example, we had a cassette from new producers from China, and unfortunately the cassette got stuck. And it wasn't possible to stitch it in full, and thanks God, it just got stuck. And as a result, we just cut the part that where it's stuck. And after that, we used more high quality cassette. Unfortunately, as a result, the hole was much bigger. But yeah, fortunately, the surgery went successfully. 3 days after the conservative procedures to stop bleeding, our endoscopists, they take away the blood clot. And 3 days after ostomy applying, we do endoscopic examination. So ostomy is fully reliable. In order to check that ostomy is fully reliable and there are no additional complications. One more interesting case is when the ostomy was irrelevant for a patient. Perotonite is quite widespread, but yet we decided to do perforation, to stitch perforation, and a patient, female patient, he was successfully discharged from the hospital without laparotomy. So practically, I would like to repeat that now all the practical complications, if we see undercompensation and the patients are in good conditions, we try to successfully conclude laparoscopic procedures. Thank you very much, Rustam. Very interesting presentation. Colleagues, do you have questions for our one of the most experienced experts? Now we do not prepare patients for right side colectomy. You mean intracorporal? We started in 2023 and 550 laparoscopic gelectomy was conducted. 475 out them was done using these procedures. We have 7 doctors, and all of them know this, got trained. And this methodology, this invasion of this methodology, introduction of this methodology was quite difficult. There were 3 leader surgeons who were capable to provide these procedures. So the first 70 surgeries were done by them. But now, this year, I believe there were no extracorporeal stenosis. Even those who were against or were afraid to do this surgery, now they understood that generally it's doable. In intracorporeal ostomy stomosis, there is nothing so difficult. Here you showed beautiful videos before how you stitch difficult stomosis, but I would like to mention that the amount of surgeries, of course, is incomparable. That's why for us it's important to ensure that each surgeon in our department know and apply this methodology. That's why, one more time, 500 surgeries in 3 years and 3 months, it's an indicator that the majority of our doctors know this methodology. We use intracorporal stomosis, and it allows us to get out the apparatus. So it decreases the following complications, and in our opinion it's beautiful. It provides beautiful access, and we use it in both cases in resection of the resections of the rectal, intestine, and colon. But usually we use phalansteal. Very useful report. We believe that it's one of the best procedures in Russia. But I would have a question. Some authors using the 3 interdissection in right side galactotomy, they cancel the 7th group of lymph nodes. How do you believe, in your opinion? Is it relevant? To be honest, I'm not a radical. I'm not extremist, I would say. That's why I believe that the surgery in oncology is a very complicated branch. It will never be developed enough. It will never be an invasive surgery. We are talking about the standards. 90% of all the surgeries in oncology, in the rectal colon cancer, 90% of all the surgeries are standard and should be provided by all the surgeons. I repeat that 3D interdissections, their effectiveness is not proved yet. That's why its expansion in some colon cancer, I believe that it's not always relevant. We are waiting for the following results. One more question. The situation that you have mentioned when there was contamination in abdomen due to the failure of a surgeon, I believe it's not only a fault of anesthesiologist. No? No, I don't believe that it's fully the anesthesiologist was fully guilty. Probably the abdomen was not prepared enough for other reasons. I have a question. Do you have any techniques for applying the clips before ostomy when you see that, for example, the intestine, the colon is full of some liquids, and when you understand that there is a high danger that the abdomen can be contaminated, do you use some techniques? Usually we do not apply additional clips in planned surgery. It's emergency. The situation that I have mentioned and demonstrated, it's emergency, just to mention that such cases are possible and we should not be afraid of them. And if it's under control, of course there will be a small contamination, it's inevitable, but for me, I draw lessons that in decompensated cases, I wouldn't use this technique. I believe that the methodology that I present is relevant only in planned surgeries. And I believe you would also not use resection in irrelevant cases. Thank you very much. Yes, please. Miram. Thank you. As we all know, right side cancer colon cancer is accompanied by toxic complications, and if you have a patient with toxic syndrome, low protein, low hemoglobin, do you provide some additional measures? Thank you very much for a question. Next day I'm going to have an additional report. In Bashkortostan Republic, we based our presentation on Kazakhstan experience, and now majority of our patients are first or second stage of cancer. That's why usually we prepare our patients for 1-2 weeks. It's a nutritive support. We use early, even if you use ostomy, our patients are not in the emergency department. Just after surgery, they are in ordinary, under ordinary conditions, and the second day after surgery, we start to feed them. And 1.5% is the frequency of intracorporeal ostomy, and 1/3 is extracorporeal ostomosis. Thank you very much, Rustam. Colleagues, unfortunately, our section has ended. I believe that it was all very good. In the center of the hall we have Mira Maskarevich. He organized this section. Let's thank them. Thank you very much, Mira. He's a good friend of us. I have one more question. We have a doctor, Vadim Gushin. He works in America, Baltimore, expert. He's a abdominal surgeon, oncologist. The abdominal surgeons, they're not just ordinary surgeons. They are not craftsmen, they are scientists as well. And in Vadim's clinic, we know each other for 10 years. He told me that there are 5 robots in their department. And as a concluding remark, I would like to ask him, Vadim, please, I would like to give the floor to you. Just a couple of words about our technical procedures, surgeon-related procedures discussed during this session. You are a person from other planet. Please provide your vision.
So I thought that our conversation will be between us, but nevertheless, we have a long debates with Ilya related to the terminological advancement of this kind of surgery. My point of view is that neither laparoscopy nor the robotic surgery would not impact oncological results, and they never had any results prior to purchasing the robots or the high expensive brackets. And it is always good to prepare the safe surgery cabinet, so to speak, the working conditions. If you don't have any ability to conduct the round-the-clock CT, and if you don't have any ability to order the radiologist to drainage the abscess any time of the day, then for this kind of department, not to purchase such expensive equipment. This is my idea. I personally, with a great pleasure, working on the robots, so the colons and the livers, and never done with the robotic manipulations, but it's always interesting. All the surgeons, we all like work with our hands, and this is undoubtedly, so it seems like the progress or advancement. I would also I always pay attention for the resolution of the common surgical issues that I told before moving to other highly expensive technological solutions. It is always better to prepare the work conditions. Is that what you wanted to hear? Yeah, anyway, okay. Thank you so much, Vadim, colleagues. maybe we can finalize this session. If you give the floor, I would like to say thank you to the organizers. So we are behind the schedule, but thank you so much for the invitation and for your interest that you express it to our speakers. I hope our further cooperation. I wish you success. I think you have a huge potential. Right from the first presentation, they all were interesting. Thank you. And I would like to say thank you for the hosts and for their presentation. Thank you. And I would like to say I'm truly inspired. Anyway, this is, yes, we all realize that we are from the common access, we're narrowing our access. We have to conduct a high quality and adequate volume of surgery. And as a rule, surgery got changed. Just 20, 30 years ago, we were showing off ourselves how we are cleaning out the lobotomic, the substance, and we were showing the vessels, and we were arguing what kind of nodes to be removed. But now we are switching over to another surface, and we know that depend on the biology of the tumor, not from the magic hands of the surgeon. So we can call that the post-Soviet Union period, and due to financial issues, due to the psychological or mental issues or local issues, any type of the surgical methodologies are introduced with some complexities. Just 10 years ago, we were talking about whether it is possible to conduct the lymphodissect with the laparoscopy, and my teachers, that generation, and they were skeptic for the things that we can enter using the scope, and now there are no questions, and our colleagues from Kazakhstan, they were showing their presentations, and they were demonstrating their experience, and showed the video how they are doing that, and they were showing how it is developed in their region. I think that the next stage of development of the surgeon, I think that would be the implementation of an expansion of the communication in MDT board. And I think that that in this country there are the developments, and all the things happened right under my eyes, and such changes, and today's presentations are the good experience of our colleagues. It justifies that the direction of the development. I'm not going to differentiate to the super proper part and today's development we've seen today. And thank you so much for our colleagues who arrived here at 8 a.m. And I think that all the presentations were excellent. Distinguished colleagues, we are moving to the second session on the simultaneous treatment of the intestine cancer. We are inviting the Gushin Vadim, the director of the HIPEC and the Gastrointestinal Oncology at Mercy Medical Center, Baltimore, Maryland State, USA. Stepanin Artem Vysyachelovich, the PhD, the associate professor on the oncological department and of the National Institute of the Health, and the deputy manager of the medical center, Yerevan, Armenia. And Aruzhanov Daurian Tursunkolovich, doctor of PhD, the associate professor, the director of the oncology center in Taldykorgan. doctors and coach, we are waiting for you. Good morning, distinguished colleagues. We are moving to our next section, really dedicated to the high-tech and high-pack. So the first presentation, Miguel Alberto, the clinical of the Charité. If there is a way for the colon cancer, the floor is yours. Welcome.
Thank you.
Thank you.
Yes, so to begin with, thank you very much for the invitation to the organization Community for Everyone. Thank you for having us here. I work in Berlin in Charité, the biggest hospital in Europe, and we have our Center for Malignant Tumors of the Peritoneum, which is directed by Professor Rau, and of course our director, Professor Platschke. For me, I personally come from Venezuela. I've been working in Germany for the last 7 to 8 years, also doing research, PhD, etc. But it is personal, if I may, for the next couple of seconds. It is a very personal and significant experience for myself, also coming from a developing country like Venezuela, to see how a center of this magnitude can be built and such conferences can take place to bring our colleagues and bring our patients better care. So again, congratulations, and I wish in my name and in the name of Professor Rau and everyone in Berlin the best and greatest of successes. So I'm going to go ahead and try to make the case for serous and HIPEC in gastric cancer. Let me see how this is working. I have no conflicts of interest to disclose. Can we maybe go to the next one? Okay. Yeah. Go to the next, it's fine. Yeah. Yeah, you can just leave it there, agenda. So we'll get it worked out. Just go to the slide that says agenda. Can I just for myself, yeah, thank you. Just for myself, can I see maybe a show of hands how many surgical colleagues are in the room right now? Okay, and how many oncologists? Thank you. Nurses? Okay. And medical students or residents? Okay, good. Thank you very much. So it's going to be a little bit hard. Of course, as a surgeon, we like to operate. We want to take everything out. Usually during the tumor boards, we have to convince our oncologists that our surgery makes sense, that what we're trying to do is in the best interest of the patients. And to do that, we have to convince our oncologists, because the patients that we see in our tumor conference that are candidates for serous and HIPEC are, the decision that we make has to be personalized, right? It's very difficult to just go in cold and say we are going to do the serous and HIPEC for a patient that has, for example, not seen any neoadjuvant chemotherapy. That is no longer the case. All our patients see neoadjuvant chemotherapy, and then the question is, should we continue neoadjuvant chemotherapy when the patient has a good response, or should we go ahead and operate? So that is the discussion that we have every day. Okay, so I have my slides. Thank you very much. A little bit of the uncomfortable truth, and of course, well, we can't see it very well, but we'll get it worked out. But basically what I wanted to show you there is that this is not something that a foreigner has to tell you. You have 20 million inhabitants, you have a median life expectancy of around 74 years and a median age of around 30 years. So you're actually a very young population. In comparison, for example, to Germany, we have a life expectancy of around 81, 82 years old, and is one of the lowest in the European Union. And the median age in Germany is about 45 years old. And we don't have these growing curves that you have here in Kazakhstan. So yesterday, one of our colleagues who picked me up in the airport, he was saying, you know, families here have 3 or 4 children. That is not something that we're seeing in Europe. So that is something that this is why these centers make sense. Let's take a little bit of a look into the epidemiology. In Asia, you see stomach cancer is the 4th. We see that in Kazakhstan, that is also the case. Now, these are all data from the WHO and the UN. This might be a little bit different from your national data. But nevertheless, in Kazakhstan, even though the incidence of stomach cancer is in number 4, the mortality is actually number 2. So I guess this is the uncomfortable truth, right? 2/3 of our patients are dying from stomach cancer, and there's, I mean, we know it's a difficult disease to treat, but the thing is, can we do better? What are the current standards right now? So, as you all know, we have guidelines that we have to adhere to. Depending on where we are in the world, the guidelines are going to be a little bit different. In the United States, for example, for Dr. Agushin, they might look a little bit different from us in Europe, and definitely a little bit different in the Asian room. But nevertheless, we all agree on this. In patients with advanced metastatic unresectable gastric cancer, the first line of treatment is going to be a platinum and a fluoropyrimidine doublet, so FLUT, and depending on molecular profiling, we're going to have trastuzumab for HER2 positive tumors, or we're going to have nivolumab for PD-L1 positive tumors. This is something that we saw in TOGA and CheckMate. Again, I'm a surgeon, not an oncologist, but even for us surgeons, pretty easy to see that patients that got immunotherapy had a better overall survival, so approximately 14 months versus 11 months. And then patients who had a good response, we could offer surgery in very highly selected patients. That is right now the current standard. Last year, thanks to Spotlight trial, we now know that those tumors that are claudin 18.2 positive now get zolbetuximab, and again, they will also be candidates for surgery if they respond. So what we have now are 3 relative big trials that are, you know, according to the molecular profile, we're going to have better response. Histology signal, if there's signet signet ring cell histology, we know nothing about that. For example, in the TOGA trial or in the Spotlight trial, HER2 positive for TOGA, of course, all of them, but we don't know nothing about HER2 in CheckMate or Spotlight. For PD-L1, very little patients had PD-L1 expression. Microsatellite stability, and as you can see on the right side, 20% of the patients actually got the treatment that they were supposed to get in these trials. 20% in the TOGA that were HER2 positive that actually got the immune therapy. 60% in CheckMate, 20% in Spotlight. So that means there are a lot of patients that we're not treating because they don't have the molecular profile that we want them to have, so to speak, right? We know that these are metastatic disease in all of them, some more multi-site, some a little bit less. Do we have information about metastasis to the peritoneum? No, We don't know. And either it wasn't reported or it was just not present. So we have a big question mark behind what do we do with peritoneal metastasis. The morbidity and mortality relatively the same across the board, except for the spotlight. We see that it is with, 87% morbidity is a lot of complications, and the median overall survival around 14 to 18 months, with progression-free survival around 6 to 10 months. So the prognosis is pretty bad for these patients, right? So what do we know right now? So kind of like the first things that we can say after these couple of slides. We have, for all of our patients that are not peritoneal metastasized, we have staging and restaging with RECIST criteria, which leaves the population of patients that have peritoneal metastasis pretty much out. I cannot diagnose correctly peritoneal metastasis only with RECIST criteria, right? We're getting better at it, using MRI and different diffusion weightings and using CT scans, but we're not good at it, yeah? For example, liver metastasis, we can use a Primovis MRI and then we can see the lesion pretty well. That does not happen with peritoneal metastasis. Only a number of selected patients with special molecular profile are actually benefiting. We have no stratification by metastatic site. We just know that they metastasize, but if it's the liver, the lung, peritoneum, it's kind of all in the same packets, in the same bundle. And the recommendation, nevertheless, is to give palliative treatment according to molecular profiling and surgery only after response to treatment. So number 4 would be the recommendation. Okay. What about surgery? Can we offer these patients surgery? So we know, this is pretty basic. We have biopsy. So for the medical students in the back, our workup is to have a biopsy of the tumor. Do we have signal ring cell histology? Yes or no? This is going to be very prognostic for the patient. What does the molecular pathology say? Microsatellite stability. We talked already about HER2, PD-L1, and now Claudine. With radiology, CT and MRI, of course, we're going to stage the patient. Tumor markers we use them to know after chemotherapy if we have had some good response. Of course, in patients that always had low tumor markers, then they don't help us very much. But then here is the case, especially for us surgeons, laparoscopy. So this is our way to beat the RECIST criteria. We have to always do laparoscopy before and after chemotherapy. This is the only way we can ensure that we catch patients that have synchronous peritoneal metastatic gastric cancer, which is going to be approximately in 30% of the patients. And metachronically, up to 50% of the patients might have peritoneal metastasis. 50%. That is the reason why each patient has to be staged laparoscopically. Okay? So, let's look a little bit into the data of why we do what we do. In Germany, and this was presented at ASCO 2024, we have the Renaissance trial, where it was ideal, or the idea behind it was to have patients that had histological confirmed limited metastatic gastric cancer, whatever limited means. There was no real definition. Medical and technical operability of the primary, okay. These metastatic lesions should be resectable or have to be controlled by local ablative procedure, but again, very wide range of options there, and no prior chemotherapy, no prior tumor resection. They were going to get preoperatively neoadjuvant therapy with 4 cycles of FLOT, and they were going to be randomized, and they were randomized to surgery and then adjuvant chemo or continue with FLOT, right? I mean, in theory, it is exactly the trial that we're looking for, right? This should have given us the answer to, should we operate on peritoneal metastatic gastric cancer patients. When we look at the data, of course, at the beginning we were kind of shook that basically no, they say that the median survival without surgery is actually larger with 23 months versus 18. So there was also a crossing of the curve. So if you only look at this data, you would say, no, there's no place for surgery in gastric cancer. But nevertheless, let's have a deeper look into it. So patients who did get surgery, right? You're going to see at the beginning, a lot of them died earlier, but those who did survive, they survived, or more patients survived at the end. So one of the reasons for that, I'll come back to that, but I think it's going to be pretty obvious. The second thing is they did a subgroup analysis for peritoneal metastasis, right? Only peritoneal metastatic patients without liver, without everything. And again, you could say, well, these patients, I mean, the blue line again is those who had surgery. You shouldn't be operating on these patients. But then if you take a look a little bit deeper, you'll see that patients who should have had surgery, 90% of those had surgery, but a lot of them had only positive cytology instead of peritoneal metastasis, for example. 20% of the patients who shouldn't have gotten surgery got surgery. And post-op systemic chemotherapy, for the patients who did get surgery, only 2/3 of them got post-operative flood. So it just wasn't, I mean, the idea was good, but it wasn't carried out in a proper way. And this is a very good point where I want to come back to. Only some centers were certified for cytoreductive surgery. From the 44 centers at the time that were carrying out this surgery, only a couple, and if I'm not mistaken, only Charité was actually certified Europa-wide to carry out cytoreductive surgery. So this is not doing anything patients should be coming that are peritoneal metastasized, for example, or liver or lung. This is where we should be handling our patients so that here you have the experience enough to handle these patients. Now I'm going to show you how I know that. And Professor Rausch, she did she took a look into the German registry. So we have in Germany, it's a federal state, so we don't have a central democratic republic. We have a federal state. Each state kind of makes a little bit of their own rules. But one thing that we do pretty well is epidemiology. So we have a lot of data, and Professor Rau went through all of the states, and she took a look at all the patients that were peritoneal metastasized and had gastric cancer. And as you can see there, she sub-stratified there by PCI. So PCI is the peritoneal cancer index. For those who don't know, it's fine. It's just kind of a way to objectify how much peritoneal metastasis there is. 39 is the highest, a lot of metastasis. 0 is, I hope, probably all of us here, no metastasis at all. Okay? So one of the main questions is how much is too much, how little is too little, and then that's how we have this sub-stratification. PCI is over 16, 7 to 15, and under 6. And you can see there that the patients that have low PCIs are those patients that do the best. And the cutoff is under 6, which is the lowest cutoff of all PSN for optimal candidates for surgery. So colorectal cancer, for example, you can operate on someone with a 25, PCI 23 if you're confident that you can get a complete cytoreduction. Okay? In this case, complete cytoreduction did not play the same role as in colorectal cancer with Prodige 7, for example. So patients that got complete cytoreduction or CCR of 1 to 3 there was no statistical difference. But, and this is a big but, also in the German registry, only a quarter of the hospitals had an expert surgeon doing cytoreductive surgery, and only 50% of the patients were treated in optimal settings. So if we took out all this together, now we see the blue curve right there. In those centers where more than 20 cases were operated, the patients did better. In those centers where there were low volume of patients did worse. And that's where complete cytoreduction and HIPEC and experience is what we need to aim for. That is why we need the experience in our centers. So, can we talk about surgery in peritoneal metastatic gastric cancer? Maybe. We'll get there in a second. The first thing is that certification for cytoreductive surgery is of paramount of importance. We have to be good at surgery. We have to achieve complete cytoreduction, period. That is, we cannot be discussing that. If you are able to do it, or if you think you are able to do it, then you should get trained and certified for that. Up till now, we have no clear certification by metastatic site, and thus information available does not ideally suit peritoneal metastasis. We have a lot more information, for example, colorectal liver metastasis, but not enough for peritoneal metastasis. Okay. And can we recommend surgery knowing what we know? Probably. We'll get there. What about HIPEC? And HIPEC, as you know, heated intraperitoneal chemotherapy, right? So the idea behind HIPEC, again, maybe for the students in the back, with cytoreductive surgery, we are able to remove macroscopic tumor. So we will take the primary tumor out. We will take, for example, we would do wide extensive peritonectomies. We will take the omentum. We will take, if needed, the spleen, cholecystectomy, appendectomy per principle. So again, 8, 9, 10 hours of surgery, anastomosis, and then chemotherapy. And the idea of HIPEC is to kill all those cells that we didn't get to see, right? That are swimming around the peritoneum. And so the question is, okay, we know that surgery works. Now, does HIPEC also work? Professor Rao at the Charité, she carried out the gastric peg trial. Again, a trial that was aiming the answer that we wanted, or the question, sorry, that we wanted answered was, does HIPEC bring better overall survival for our patients? And the answer is, according to GastriPEC, no. It is formally, it is a negative study, as you can see there. HIPEC or no HIPEC brings no statistical difference. But, and this is, I see that this, it's full of buts, right? Yeah, I'm sorry, but yes, but if you see progression-free survival, so let's say symptom control or disease control, then HIPEC becomes significant. Yeah. If you see distant metastasis-free survival, so any other type of metastasis, doesn't matter which, then HIPEC does make a sense. So, do the patients live longer? Probably not. But do they have a better quality of life during that period of life that they will be leaving at the end of their life? Then probably yes, right? And this I wanted to come again to. So now we know that cytoreductive surgery is important. Is it also important in the sense of with or without HIPEC? Well, yes, but with an asterisk, right? So again, if you have every factor, if you have good selected patients that had the proper neoadjuvant chemotherapy, if you have an expert center, if you have the right surgeon, then CRS and HIPEC for gastric cancer makes sense. So let's add GastriPEC now to the table we saw before. And now we have a little bit of more information. We now know that in our GastriPEC trial, 70% had signal ring cell histology, 70%. Really bad prognosis. All were metastasized, all were peritoneal metastatic patients. So in this trial, we saw the worst of the worst patients. The worst, we treated neoadjuvantly and then we operated on the worst possible patients. And nonetheless, we still get the same median overall survival and progression-free survival as chemotherapy alone. And we get better disease control and symptom control. So what happens to those patients that are maybe not the worst of the worst? So those patients are probably not signet ring cell, those patients that have a positive, or not a positive, but are PD-L1 or HER2, they get benefit on top, right? Or at least that's what we want to believe. So if we see a summary here, we have of the different studies that we've looked into, we see at the end that maybe because of time I can kind of skip this, but the point is here, neoadjuvant chemotherapy, surgery, HIPEC, and then adjuvant chemotherapy brings us about the same time as only neoadjuvant chemotherapy or only chemotherapy and immunotherapy in those patients that have that molecular profiling. Yeah. Now, if we see at the bottom, FLOT5, are the ones that got surgery. Let's not forget, they lived less, but 60% of patients were not treated as they were supposed to be treated. So that's a very big caveat there, right? In the gastric trial, it ended prematurely. There was a 50% dropout rate because of tumor progression and irresectability. And that was because for the trial, it was not powered or did not take into account that patients over PCI 13 are not supposed to be operated. We know that now. Patients with too high a PCI were brought into the trial. That now we know that the cutoff should be 6 to 8 probably, right? We still know that palliative treatment should be according to molecular profile, and of course we're not debating that. And surgery, yes, but in certified centers with very strict patient selection with response to chemo and immunotherapy and achievable CCR0. I promise I'm almost done. What about other types of intraperitoneal chemotherapy that are not HIPEC? And this is where it gets interesting. We ourselves were not there yet, but we're actually trying to get there now. We're going to start this year with NIPS. And NIPS is neoadjuvant intraperitoneal plus systemic chemotherapy. And this is something that the Japanese, Koreans, Chinese do very well. And they know how to do it. And I mean, let's be honest, you're a lot closer to them as we are. And then maybe I think it's a good option for you to explore. What is the case for NIPS? So what we know so far for NIPS is that the conversion surgery rates is very high. 40 to 78% is something that we haven't seen in our trials. The R0 resection rate is again high, 50, 70%. And the post-op median survival times are something that we can only dream of, with up to 43 months. The idea of NIPS is basically you give the patient intraperitoneal neoadjuvant therapy and also systemic. And right now we have a phase 3 trial, well, not we, the colleagues in China are running this trial, Dragon 01, and we're very excited to see the results, but it's not been published yet. But Professor Rao was able to get her hands on these slides, and that's why I can bring them here to you now. And so the idea is to have oral S1 and IV and IP paclitaxel as a NIPS regime. And the other arm of the randomization is IV paclitaxel and oral S1. So the first thing to say is that in Europe, we are not allowed to use S1. It's not approved. I don't know if in the US maybe also not approved, but you know, I think you are in the middle. Maybe you can get it approved. It's showing some promising results. And what we know so far, and this is what Dr. Jan showed last year in ASCO. Look at the yellow line here. Extremely significant 19-month overall survival versus 13, so it's a 6-month delta. And I know it's difficult to read, so I put it on the side there. 1 year overall survival, 70%. 70%. And 5-year overall survivor, 10 or 11%. Right? I mean, these are astonishing numbers that we don't see in Europe, to be quite honest. Hazard ratio for death on your left side, NIPS is better. On the right side, only systemic therapy is better. It doesn't matter what subgroup, NIPS does better every time. I mean, that's this is something that, again, we are very much interested in beginning this year, and I can only encourage you to do so as well. Okay, and so, yeah, for NIPS, it's a limitation for Western countries because it is primarily done in the Asian population, but we are in Kazakhstan, so that's a great point for you. We still don't have any information regarding molecular profiling because, you know, it hasn't been published yet, but it's probably going to make sense. And the general recommendation is for young patients with great overall status. It doesn't matter. It doesn't matter the amount of PCI. They have patients with PCI from 39. So remember the highest amount of PCI. Again, they get a port catheter. Just like our patients get for chemotherapy, they get it intraperitoneally, and they just do this neoadjuvant IP, and with ascites under 300 milliliters. So I guess it's a good case. And when we add that to our summary, then we see, you know, 20 months overall survival with NIPS with the PCIs from 39. It's the best results we have so far. What happens if we can't operate? And I promise you this is, if not one of my last slides. What happens if we can't operate? Then we all agree across the whole world, second-line treatment, no surgery. If there's something that we know is that hands off, if patients do not respond to first-line therapy, then there's nothing for us surgeons to do. In the second line, there's no local treatments included. Like I said, hands off. There's no information regarding M1 in the peritoneum. And we know that the median overall survival is 12 months and progression-free survival is 6 months in some selected patients. So these are my take-home messages, and this is my last slide. Systemic chemotherapy has to be done according to molecular profile. This is not new. This is something that we know. Is NIPS an option? Yes. Serous and HIPEC, like I said before, selected patients in special centers. Post-operative systemic chemotherapy is extremely important. Patients cannot get lost to follow-up. And maybe, you know, these are some new data that's coming that maybe, you know, we can do some maintenance with NIPS. It's just an idea. And for the second-line treatment, then palliative chemotherapy according to a molecular profile. Could we maybe use NIPS instead of serous and HIPEC for these patients? HIPEC I'm not going to touch because we're going to talk about it in a second. Maybe some sequential palliative systemic chemotherapy, and let's not forget best supportive care at the end. It's what it's about sometimes, right? I thank you again for your valuable attention, and if there are any questions, then I'm happy to take them.
All right, thank you very much for your presentation. It's data rich presentation. Thank you. And My question is, when you see a patient with peritoneal disease, gastric cancer, what your conversation looks like with him or her?
Yeah. It's a great question. It's a two-part answer. Number one, in my center, we're very lucky in the sense that all patients have been seen from either another surgeon or the oncologist already before being presented to us in the, let's say, national center in Chete. So they already know what to expect, right? And actually, a lot of them, if not all of them, come very hopeful, thinking that, you know, we are the answer to their prayers and that we can cure them. But most of them, you know, being Germans, they are very, let's say, sober and say, okay, I know that this is my last chance, and so that's why I'm here. Now, I have had some of the other patients, right, that just come to us, or that we do a diagnostic laparoscopy and we see the metastasis for the first time. And of course, our conversation is the diagnosis is dire, especially for peritoneal metastatic cancer patients. We do everything we can regarding studies, neoadjuvant chemotherapy, but I think we're very honest with them, very, very honest with them, and in the sense that we will try to do serous and HIPEC if it's possible, if we can keep down the PCI, and if not, we will try to get them into a PPAC program, which we do PPACs with systemic chemotherapy interchangeably. But if that doesn't work, then that's supportive care.
Yeah, thank you, Miguel.
Yep.
Being a panelist, I want to be a bit critical to you.
Please.
So my question is, you reported that the patients, very selected patients in the reference center, have maybe the same survival, but they live the same time, but they have a better progression-free survival, so they live. We can judge that they lived a better life, but the same period of time. Okay, do you have data of toxicity of medical treatment or morbidity of surgery in this cohort of patients?
Yeah.
Comparing to those who didn't get this kind of treatment? Thank you.
Yeah, no, excellent question, thank you. Only indirect. We don't have any running trials. It's not ethical, so we don't get approval for those kind of trials. But indirectly, yes. So, for example, in my case, I am kind of in charge of all complications in our group, right? So I
Poor guy.
Exactly. I know exactly what our complications are, how many, and everything. And I can tell you from our experience is this. Almost 80% of patients that are in PPAC, for example, right? So these are patients that have a PCI from 25, that we cannot do serous and HIPEC. But we do PPAC, or they get systemic chemotherapy. 2 weeks after they come to us, they get PPAC. 2 weeks after, they're back at the oncologist to get chemotherapy. And they do that 3 times, okay? Almost 80% of them are happy to be with us at the hospital because they say, I'm getting treatment, I know it's PPAC, and at the second day I'm home, I don't feel nauseous, I have no secondary effects from the chemotherapy. They're actually very, very glad that they get this break from chemotherapy. And really only in 10 or 20% of the patients, they say, I hate surgery, I don't like it, I prefer having my IV drip. The problem is that some patients, and you're completely right, some patients have SSIs, so surgical site infections, and that delays treatment, and that is a problem.
Thank you, Miguel.
Yeah. Okay.
Thank you very much, Miguel. Maybe some colleagues have questions. В зале есть вопросы для Мигеля?
Are there any questions to Miguel?
Я думаю, перейдем к следующему.
I think we can move on to the next slide on PIPEC, on treatment of the gut cancer. Distinguished Presidium, distinguished colleagues, thank you for giving me such opportunity to deliver my presentation in this conference dedicated to the opening of our new corpus. The subject of my presentation is about the intraperitoneal aerosol chemotherapy for gastric cancer, and also are there any ways for the prevention. As for the epidemiology of our statistics in our country, cancer in our country, according to this data, the gastric cancer is in the leading positions, and according to the 2024 report, the gastric cancer ranks second place after the breast cancer, after colon rectal cancer and the lung cancer. And as for the mortality, it ranks 3 after the lung cancer. As for the metastasis in the peritoneal gastric cancer, as you know that if there is a peritoneal metastasis, it complicates the treatment strategy of the patient and also worsens the forecast of the disease. The frequency of this cancer upon the initial inspection or examination, we can reveal that from 10 or 30% of the patients. So there is if there is an invasion of the tumor, the frequency of the increase ramps up to 60%. When there is the recidives of the recurrence of the disease, the frequency is increased to 50%. So risk factors are the diffusive type of cancer. Then on the cirrhosis part of the part, and there is a positive cytology of the and also the deterioration of the lymph nodes, and the total survival and the median rate. And if we do not take any actions on treatment, my previous the previous speaker has already told what kind of options do we have for the treatment. We have the local chemotherapy. There's a systemic chemotherapy with a target immunotherapy, the various types of the abdominal therapy, and the cytoreductive therapy. As for the types of the abdominal therapy, we can include the HIPEC, the EPIC treatment, NIPS, which is the neoadjuvant therapy in intra-abdominal, and also the PIPEC and the intra-abdominal chemotherapy. My presentation will be dedicated of the types of the abdominal therapy with the PIPEC. That's the pressurized intraperitoneal aerosol chemotherapy. So the concept of this procedure is that there is a chemioperfusion is introduced in the form of the aerosol under the high pressure. And there are the schematic illustration of the procedure. So this procedure is conducted during the laparoscopy. and the Lapra port is injected through the Lapra vessel, and another part is injected through the nebulizer, and they use the perforizer in the form of the aerosol, and they are connecting to the high pressure air injector. Upon 250 PSI, they conducted the pipeback procedure. What kind of what are the advantages of this procedure? This is the depth of the penetration of the substance. They can use that several times, and also less invasive. For the present, pipeback is used in treatment when there is a canceromatosis. In the recent consensus of the experts, they approved the protocol of the treatment. And for the canceromatosis under the gastric cancer, it was recommended to conduct the scheme of the CD, the GC, that's the usage of the 250 milligrams of the substance. So the periodic conduction of the pipeback is the 6 to 2 weeks in combination with the chemotherapy. There are lots of studies to evaluate the safety and of pipeback, and one of these kind of studies is that the more tolerant, and they conducted 160 pipeback procedures for 42 patients. As you can see, that the maximum PCI was 32. And the pipeback procedures were conducted, so to speak, the frequency of the pipeback procedures for one patient varied from 1 to 12, and the median survival rate was 12 months or more than 12 months. And under the study, after this treatments, the pipeback, we were able to conduct the high pack after the pipeback. In our previous meta-analysis dedicated for the results of the, we considered the possibility and opportunity to use a pipeback. There were 18 studies, and the number of the patients were 440, and number of the pipebacks varied from 2 to 296, and this meta-analysis revealed that the total survival rate varied from 60 to 15 months. And 2 years survival rate reached to 40%. So what we could get from this study, as you can see, the patient who had 3 or more pipebacks, the total survival rate got increased significantly rather than those who had 2 pipeback procedures. Like I've said before, the pipeback is currently applied in treatment who had a perimetical canceromatosis. As for the preventive point of view, we have the methods of the intra-abdominal chemotherapy, which is applied for the preventive purposes, and the intra-abdominal procedures can be used in neoadjuvant modes and also in adjuvant modes. So can we use a pipeback as a preventive tool for the canceromatosis, and why don't we conduct a study the efficiency of the PIPAC for the preventive purposes. In this slide, we have shown some studies that were targeted to the study of the PIPAC procedures as part of the prevention, and one of these studies have been finished, and it was conducted to assess the safety of PIPAC, and we didn't measure the efficiency. There were several studies that we conduct right away in the various countries. That's the Dragon 6, Gaspaco, Spectra, Epicure, Casneopac. In these studies, the PIPAC was used as an adjuvant and a non-adjuvant modes in combination with the various types of the systematic chemotherapy. So this is the continuation of the previous slide. We have the illustration of the design of the treatment, so it varies. There are the initial evaluation of these studies. So most of them were done to assess the 4 or 5 year survival rate and the non-recurrence assessment of the perioinstative canceromatosis. I'm going to finalize my presentation with the words on the studies that we do in our center. That's the Casneopac trial. That's the preventive use of PIPAC in a local advanced gastric cancer. In a locally distributed gastric cancer, it is very prospective, controlled study, which is registered in the clinical trials. It has its own ID. We have the design of the study. We will study 2 groups of the patients. The group of PIPAC, which is the main group, and we included 60 patients there, and after the stage evaluation, we conducted a laparoscopy. We take the samples of the fluids, and if there is a cytology, we conducted a PIPAC procedure. After that, the patient will be directed to the neoadjuvant chemotherapy. There are the 4 courses.
And after the neoadjuvant courses, there will be restaging, the second laparoscopy, also with the sample of liquids. It's for the identification, and if there will be no further progress of disease, we will have further courses of neoadjuvant therapy. We also plan to observe the patients during the next 2 years, and our main goal is to study non-recurrence survival on canceromatosis. Comparative group is going to be a retrospective group of patients. We included 100 patients, so the patients who undergone standard treatment course. The primary endpoint, as I mentioned, is non-recurrence survival without the canceromatosis, about 12-24 months. The second endpoint is overall survival, progression-free survival, no adverse events, increase in quality of life, and other. Here you can see a small video. Here you can see laparoscopy, a huge lymphoma. In laparoscopy, we see that there is no signs of canceromatosis. We examine all the parts of abdomen, different parts of abdomen cavity. We examine them, and after that, we conduct cytological study, examination. There is a
Natrium sodium.
it takes about 20-25 minutes. Using that sodium, we take samples, and after that, it's just a standard procedure. It takes 20-25 minutes. Thank you very much. Here, using this QR code, you can scan it and then got the details about our study. That's it. Thank you very much for your attention. Thank you. It's very good that you conduct this study on the effectiveness of BiPAC. It will be very interesting to examine the results. When you decided on the sample, how do you think what the BiPAC results are going to be? What do you plan? We consider statistical data, we review different previous literature, and it indicates the development of canceromatosis in up to 60% of all the cases. Therefore, we plan our hypothesis is to decrease the frequency of canceromatosis by 15-20%. Can I ask a question about the quality of chemo agent? What medication do you use for BiPAC? For BiPAC, we use standard scheme. It was approved by consensus. It's 10.5 milligram on quadric meter and doxycycline. This solution will be distilled on 150 saline bag with the speed of 200 PCI, 0.5 milliliters per second. So you mix them instantaneously? No, separately. Does it matter what's going to be first and second? So this bistomycin is the second. Yes, one more question.
Understand how much time did you have planned, or are you carrying out the how much time between PPAC, flood, and then surgery? How much time between the three?
Thank you for questions. The period from PIPAC and neoadjuvant chemotherapy takes 1 or 2 days only. So after the PIPAC procedure, we just observe patients 1 or 2 days. If everything okay, we just send patients to neoadjuvant chemotherapy. Actually, we did 15 PIPAC procedures in that trial, and we don't observe any adverse events after PIPAC.
Exactly. Yeah, because surgical site infection would be my or wound healing.
Yes,
would be my concern, but yeah, okay, thank you.
Еще вопросы?
Большое спасибо. Я думаю, что мы...
Thank you. I think we deserve coffee break.
Коллеги, проходим в зал.
Colleagues, please take your seats.
Коллеги, приглашаемся в зал для продолжения следующей сессии. Коллеги, мы продолжаем нашу конференцию, и сейчас с небольшим опозданием мы начинаем следующую сессию, которая будет называться «Объединяя специальности, мультидисциплинарный подход в лечении рака желудочно-кишечного тракта». Часть вторая. Для модерации мы пригласили к нам руководителей клиники.
Today we have several experts. Our model, Today we have three experts that are going to hold the second session. You can see them in the presidium.
Там тоже не работает? Ни у кого не работает?
И у бахша не работает. И у бахша не работает.
Группа технической поддержки, посмотрите микрофон спикера, пожалуйста.
We have some technical issues with the mic. Just a moment.
Хорошо? Удобно, нормально? Хорошо. Вот там, да? Добрый день, уважаемые коллеги.
Good afternoon, distinguished colleagues. Please let me present the topic on how do you choose the treatment tactics for patient with gastric cancer. We have heard a lot of information about the statistics. Here you can, on the screen you can see additional statistics in our republic in 2023. The gastric cancer holds third place. And one more concern is the mortality rate in 2023, and in the previous statistics that were shown by my colleagues, it holds second place, and it's 12% out of the share is 12% out of the total cancer mortality. It means that gastric cancer is one of the key issues. It also means that gastric cancer is an aggressive disease. It's quite aggressive, and as a result, majority of the patients are diagnosed at very at the last stages. That's why early diagnostics is important to ensure early treatment. We need effective treatment course for that. Today we're talking about metastatic gastric cancer, and the main treatment is treatment therapy, and the goal is to continue and preserve the life expectancy and to preserve the life quality. In accordance with the Martin King Hospital, the more therapy lines are possible for a patient with metastatic gastric cancer, the higher life expectancy is. Here on the screen you can see that the first line therapy, the total survivability median is a bit higher than 8 months. After 3 lines of therapy, it's about more than 33 months. Patients with metastatic gastric cancer without chemotherapy has life expectancy 3-4 months. With cytostatic therapy, life expectancy can be prolonged up to 1 month. With target therapy, for example, ramucirumab, trastuzumab, immuno-oncological medications, this therapy helps to increase total life expectancy without increasing toxicity, which is also important for metastatic gastric cancer, since most of the patients at the beginning of the treatment, they already have poor life quality. So what is the first line therapy? What is our tactics to select medications for metastatic cancer? As was mentioned, we pay attention to the molecular profile of the tumor and its biological features. Probably the majority of the medical centers know that we identify HER2 status. And if HER2 positive in resectable gastric cancer, the basic therapy is going to be doublets, platinum with fluorimidines, with HER2 positive plus PDL positive, CPS more than 1. We add to standard chemotherapy platinum. With fluorimidine, we recommend trastuzumab in immuno-oncological medications. The scheme you can see on the screen. It's recommended for the first treatment line with the advanced in resectable HER2 positive adenocarcinoma of gastric of esophagus gastric junction with CPS more than 1 with double FDA. If PDL is negative tumors, so CPS is less than 1, then we add to standard chemotherapy, trastuzumab. Gastrectomy is not recommended with metastatic gastric cancer if it doesn't necessary to mitigate symptoms. Metastasis asset reduction in case of metastasis in abdomen cannot be reconducted generally, but can be considered as an additional approach in highly selected cases with oligometastatic disease and response to chemotherapy. The previous colleagues already showed the attitude towards surgery, HIPEC in metastatic gastric cancer. Metastasis resection with chemotherapy doesn't always indicate increase of survivability, and the resection of abdomen can even harm patients, as was shown by previous colleagues. A lot of things depends on degree to what extent medical centers are expert. It cannot be recommended out of the context. There might be some very few cases after system therapy and after critical discussion on the tumor, multidisciplinary tumor council in referral corresponding centers. So the high significance is played by the medical centers and the experts of the medical centers. With negative HER2 of gastric cancer, the basis is platinum duplets with fluoropyrimidines, and depending on molecular profile, our decisions are as follows on this scheme. In positive tumors CPS more than 5, it's recommended as a compulsory inhibitor points. With CPS from 1 to 4, it's possible to use immuno-oncological treatment medications. And I would like to note one more new biomarker, Claudin 18.2. Its hyperexpression, let's call it. To identify its expression, we identified in 88% of all the tumors. And yes, in such cases, we recommend romatuximab. In our country, however, we do not outline this marker. However, we plan to do so. And the main direction for us is to identify biological profile of tumors to individualize therapy for our patients. If for MSI high tumors and the interrupted DNA, we also recommend, in addition to chemotherapy, immunological medications. With negative tumors, when CPS is less than 1, in HER2 is negative, then we say that we need to add doublet cytoxin. Generally, in case of unresectable gastric cancer, we recommend platinum fluoropyrimidine duplet. In addition to oxytocin, in some separate cases for certain patients, when we want to achieve quick response. For example, in case of stenosis, obstruction, gastric obstruction, if the esophagus gastric junction is obstructed, if patients are young, without comorbidities. So yeah, there is a very small sample of patients for whom it's relevant. To sum up, first-line therapy. For first-line therapy, we recommend chemotherapy. We use platinum and fluoropyrimidines. If patients intolerate to platinum medications, then it's possible to use irinotecan and fluorouracil. In terms of platinum, I would like to clarify that it's preferable to use oxaliplatinum. Of course, you might already know that. Due to high toxicity level in identified effectiveness in line with the existing treatment schemes, it's not recommended. 3-Claudin positive for positive tumor, for HER2 negative and PDL negative tumors in first line. For PDL positive tumors, inavolisib chemotherapy is recommended for adenocarcinoma gastric cancer, for CPS more than 5. Pembrolizumab for first-line therapy with chemotherapy in case of positive PDL tumor, CPS more than 10. For HER2-positive tumors, first line, as you all know, there is a combination along with chemotherapy. We use trastuzumab and pembrolizumab, and chemotherapy is recommended for patients with HER2-positive tumors and PDL-positive, so CPS more than 1. And I will repeat myself. Gastrectomy is not usually recommended unless it's necessary to mitigate the symptoms. Resection of metastasis cannot be recommended in general, but it can be considered as an individualized approach in highly selected cases with oligometastatic disease and response to chemotherapy. Second line therapy in metastatic gastric cancer. Of course, we consider Cox status of patient. Next, if there is a progression of a disease, we see to what extent first-line therapy was effective, and when progression appeared. After finalization of the first chemotherapy line, it's preferable to use in the second therapy line. It's recommended to prescribe ramucirumab. I believe my colleagues already showed this scheme. If there is no contraindication for chemotherapy and if there is no intolerance to this treatment, it's possible to appoint ramucirumab in mono regime. And if there are contraindication to anti-androgen therapy, it's possible to appoint taxane, irinotecan in mono regime.
In mono tumors and reparation of the DNA in the second line, it is recommended to give the pembrolizumab in a mono mode in a chemo-resistive tumors for those patients who already received the pembrolizumab. It is not recommended to use them in the second line. As a recommendation, the trastuzumab and deruxtecan is used. And the third line of the therapy here, it is also important the condition of the patient and expected and anticipated life expectancy, and like in the previous chemotherapy, and the response to the previous line, and HER2 negative tumors. So we still maintain the chemotherapy. Here again, we can use the taxanes and in a mono mode, and the drug Medocil. And in the third line, it is recommended to use taraximumab and toroxucan. So as a summary, I can say that the taraximumab is recommended for the second line treatment of gastric cancer, and also monotherapy is also monorixumab can be used. And we cannot give that monotherapy if there are the contradictions. It is recommended to use the monotaxils, vatotaxils, or minitucans. For the patients who received the 2 lines of the therapy, it is recommended to use the tirorexafen. If there are the MSI tumors, so we can use a pembrolizumab. And if there are the HER2, we can use the tiraximumab and the veroxetican. And in some cases, if it's possible, it is recommended to conduct the additional biopsy, and we will monitor the condition of the patient. So I'm not going to tell this again, and it is also important when we conduct the treatment with the metastatic advancement of the resectable gastric cancer is the observance of the patient. For the presence in late stages, it is recommended to monitor the symptoms of the progression or advancement until the clinical signs are worsened. There are the recommendation to monitor the abdominal part within this every 6 or 12 months, which, so to speak, that the mandatory monitoring of the symptoms and the progression or the advancement signs in order to decide on transition or the preservation of the certain type of the therapy. So the basis for the giving of the Rama therapy in the second line, they were the studies Rainbow-RECO. Rainbow is the combination of the patotaxin or the Rama therapy for those patients who didn't receive the patotaxin before, regard as the ramucirumab in the mono mode. So ramucirumab was compared with patotaxil and with the symptomatic therapy. The main criteria was the total survivability, and we received these results, and according to the Rainbow, we obtained 9.6 months of the survival rate for those patients who were receiving the paclitaxel, and versus to those patients who were receiving the placebo with the paclitaxel, which equal to the 7.4 months. So here again, it is important here that how it is important to monitor the transition and what kind of lines of the therapies can provide more life expectancy to this patient. That way we are increasing the condition of the patient. And here we're showing when we were conducting the Rainbow study, who were receiving the paclitaxel and the ramucirumab, and we can notice that there is a full regression and a partial regression and the stabilization of the disease. So this therapy is characterized by the good tolerance, and we are controlling the level of the toxicity, and here we are showing that the side effects, that's the febrile neutropenia and the arterial hypertension, and all these manifestations were monitored properly. And this is the final slide and regarding ramucirumab. So it is not used only of the adenocarcinoma of the gut, and also in so it is also used in the colorectal cancer in the second line of the carcinoma disease, and also the lung cancer in the combination of the with the carlocytemiba. That's it from my side. Thank you very much for your attention. Thank you, Bahchana Abdrahimovna. If there are any questions? No questions. Let's move on to the next speaker. Thank you. So next speaker is Dusembiev Yirkan Gaizaev, the deputy of the chemotherapy department of the Pavlodar Oncology Dispensary, with the presentation on the clinical trials of the gastric cancer. Yirkan Gaizaev, can you hear us? Can you hear me? Yes, we are happy to see you online. I'm happy to say hello to everyone. Unfortunately, I will be delivering my speech remotely. Thank you for the opportunity for providing me to share my experience, and then I have some I'm a bit worrying when I'm delivering this presentation among such SMEs, and I'll try to make my presentation a bit brief. So today is our subject related to the gastric diseases and the treatment ways. I will provide you the clinical cases, and since we collected the materials data during the pandemic and the post-pandemic period, and the diagnostic challenges and after the condition of the patient. So the patient is 67 years old. He's registered in the dispensary since 2020 with the diagnosis of the gastric disease, the cardiac, the subtotal damage, MXML. And here we perfectly remember this period of time, and the patient had a bad condition at the moment of the reference. He had some difficulties with breathing, and moreover, he had diabetes and some difficulties with breathing. And after that, we conducted a CT, and there is a conclusion. There is a thickening of the gastric walls, and we can realize how the diagnostic system was overloaded during that period. Unfortunately, with this kind of conclusion, it was recommended to conduct endoscopy. So during the endoscopy study, we took the samples and cytology where we differentiated the adenocarcinoma of the gut. And after that, this patient was registered, and in a committee, it was decided to recommend to neoadjuvant chemotherapy. But the question was on palliative therapy, since the condition of the patient was not really good. There were associative pathology and diseases and symptoms. As you can see here, from September to December, he had 6 courses of the fluorouracil, and including the duplets. Unfortunately, the patient neither physically nor morally was ready. After every attempt to conduct the standard treatment, unfortunately, his condition, the mental condition, nor the physical condition allowed us to do that. We didn't pay attention for the drugs that we used associatively. Then we decided to use the didegramon. After the multidisciplinary committee, we conducted some investigations, and we studied however, during that period, the equipment was overloaded, and this patient was put on a table. And during the revision, we decided that this surgery had a diagnostic character, and that the tumor was not removable. It had some advancement towards other organs. So after subsequent procedure, we conducted the chemotherapy, and we conducted the psychological consultancy. We told him to pass this kind of chemotherapy. We understood that this patient had no funds for conducting that. We selected the most reasonable treatment, doxorubicin and the fluorouracil. He experienced those medication very poorly, and here again, and there were some shortness of breath, and he moved towards the COVID department, and at that point we started to diagnose additional problems. And here again, in our diseases went to the second schedule, and he required for the hospitalization to the specialized centers. In 2021, we ran the endoscopy, and we checked the profile of the patient, and we decided to repeat the chemotherapy. And we can realize from the March to the September, we were not able to maintain the September, and there were and also that patient took a break for the restoration of his condition, and during this time, we had 9 courses of the fluid medication. After that, we conducted the CT. We clearly figured that the dynamics of the disease and conducted the FGDS, and we revealed the negative and the positive dynamics. After this, the results were obtained, we decided to use the mono mode, like capecitabine. He had a bad tolerance to this medication. After 3 courses, the patient had to refer to another institution for the surgery. So after all examinations, the patient restarted the same therapy where they were using the docetaxel, and they replaced the oxytocin to the cisplatin. So we raised this question in 2022. If you remember, I was asking if it's reasonable to give cisplatin rather than oxyplatin. It was approved to use that, and we had 3 courses of the triplets, and in comparison with the capecitabine, so it's very interesting for those patients. So low positive dynamics of this patient that we revealed from the CT and the FGDS, and after that we switched to the supportive therapy. After 3 courses of the patient refused to receive the capecitabine and XLXP, and it was decided to conduct the 3 courses of the oxytocin in the 3 courses. So evaluate the dynamics of the patient from June to September. We revealed or diagnosed the advancement of the metastasis, and we had returned to our department, and he passed 4 courses of the Iranexicus and evaluated his condition, and we revealed that everything looks stable. But however, the tolerance to this medication was not really good. So we had an opportunity to take this patient to the target therapy, which shown good results with the ramotazone, with the ploxitoxin, and we conducted 3 courses after which revealed good results, and we repeated the same therapy and in a mono mode. And unfortunately, by August, the ramucirumab was not supplied, and we switched him to the trifluridine, and for the present, the present with a stable profile still receives this medication. This is what I wanted to tell. If there are any questions, I have one question to the Presidium on the reasonableness on usage of the this patient's life expectancy and tolerance to the result, and study results have shown that the most preferable medication to him, the combination of these drugs, the monotaxil, in order to switch the patient to the trifluridine and also adding the ramucirumab. Thank you very much for your attention. If you have any questions, I'm ready to answer them. Thank you very much. As for the question, I think that if everything is okay with the patient with the monotherapy in a metastatic cancer, if we don't want to harm him, I think we can leave it with this in this mode while it's still effective. This is what I usually do. I personally happy with the results, despite all this the history during the last 3 years. He had non-removable type of the disease. I'm truly happy that so the question is what happens next for this patient. I invited him. I insisted on conduction of the FGDS, which he is still refusing, and also I would like to take the biopsy and take the samples to see the condition of the gastric system. As for the restoration of the molecular therapy and ramucirumab, if it's reasonable or not. I think to your patient you can give anything and you will get the positive effect. I'm just kidding. I think that the fourth and fifth line of the therapy can be used. I've got a bit confused with your presentation, but there are no any standards. This is your creativity and your way of treatment. You can use the paclitaxel. Since we ran out this medication, we can add ramucirumab. Lansur, we're currently using the Lansur and to see how it can work. And as for the question, I would like to know that since this the case study, and this is all about the life hacks, it's not about the studies, etc. What kind of life hacks that you have already told, or tricks or methods that you use from this kind of patients you learned from the lessons, or to replacing the platinum to another type and get some effect. Maybe you were searching for the same experience or the set of the cases. What kind of conclusions have you made from this? So in this case, like I said, in 2022, with the presidium, with the distinguished Dauran Tursunkulov, discussed this. This is about switching from the oxaliplatin to the. Why won't we try this method? As for the gastric cancer, we have lots of cases for which I always insist to profile the patients. I have a big suspicion that this patient will have a MSI high grade, since that the progression is similar, and I think that the chemotherapy didn't play a great role, but that's my suspicion or guessing. So, and also in the very beginning in pictures, we couldn't figure out whether we have to conduct surgery or how it is reasonable to conduct that, and we thoroughly investigate these patients, and there are lots of the positron emission tomographs in our country, and we are not sure how they are distributed in our country. Only this one, that's the second.
Второй момент, который я как урок.
The second lesson that I learned, probably it wasn't necessary for this patient to include triplet in the second therapy line. Maybe it was better to use less toxic medicals, but I was surprised that unfortunately he was intolerant to some medication but was tolerant to triplets, surprisingly. Yes, thank you very much. Unfortunately, we are behind our initial schedule. That's why we don't have much time. Now, please, I would like to give the floor to the next speaker. Thank you very much and goodbye. The next topic is neoadjuvant chemotherapy for esophageal squamous cell carcinoma. The speaker is Inara Talgatovna Turkpenova, PhD candidate medical oncologist of the Abdominal Oncology Center of NROC. Good afternoon, distinguished colleagues in Presidium. It's a great honor for me to be a part of such a huge oncological event. Today we are going to discuss neoadjuvant chemotherapy for esophageal squamous cell carcinoma. I will not dwell on statistics and on epidemiology. It's not relevant issue only for Kazakhstan but for the whole world. As esophagus cancer is one of the top mortalities. Speaking about morphological classification, as we all know, based on the picture that you can see on the screen, you see the risk factors. Therefore, histological, you can see the histological type of the tumor, which is very significant. So, how do we diagnose squamous cell esophageal cancer? Of course, it's a routine. However, we keep up with the modern times, and that's why we need additional examinations of esophagus and to use specific for squamous cancer indicators. For example, immunohistochemistry to analyze protein and other. I will not dwell on the required score for examination, but I would like to highlight the necessity of an easy but extremely important examination method, fluoroscopy, because it answers a lot of questions. For example, using fluoroscopy, we can identify whether there is a fistula, and as you know, fistula is a significant indication. Before we 10-12 years ago, the features were typical for adenocarcinoma and for squamous cancer, but now we can see significant difference. Squamous cancer is limited by invasion, and the second stage is surgery, usually esophagectomy or resection of esophagus, for example, using Ilus or other methodologies. If the primary tumor is big, then we use preliminary chemoradiotherapy before the surgery. And any of these types of therapy requires multidisciplinary approach. And now it's very relevant to discuss what should we do for locally advanced squamous cell cancer. Should we do radiotherapy, or is it not necessary? As we all know, chemoradiotherapy is related to a lot of complications. For example, certain toxicity, high risks, high risks of fistula development, patient exhaustion, complexity of surgical treatment after CRT, and esophagitis. All these complications lead to the search for alternative treatment. For example, using DCF scheme is a standard procedure for squamous cancer. Our colleagues from China and other Asian countries use different procedures. They conducted a randomized meta-analysis, and they came to conclusion that DCF significantly improves survivability. However, it's not that commonly used nowadays. It was all conducted before ASCO 2022. Our Japanese colleagues presented randomized compiled study GSOC. It's GSOC 1109. Where they compared two chemotherapy regimen and chemoradiotherapy regimen as neoadjuvant treatment for locally advanced esophageal cancer. And they came to conclusion, as you can see on the screen, different treatment schemes. And it turned out that significant differences in treatment schemes. There were more than 200 participants in each control group, so this study is a huge worldwide study. As you can see, the features of patients, the majority of patients are with tumors of abdominal. The average age is 63, the majority are males, and it's suitable for our Western population. Here on the screen you can see how it was comparable in terms of overall survivors. There were two groups, Neo-DCF first group and second Neo-CF. And the total overall survival, as we can see with the application of Neo-DCF, there is a 10% improvement if only CF was used. To compare it with the neoadjuvant chemotherapy, as you can see, there is no strict or global difference. However, we can sum up that the application of DCF, unfortunately, they didn't compare it with the chemoradiotherapy, but CF doesn't, if there is no significant difference, we can say that CF plus RT is partially better. Speaking about radiochemotherapy using DCF, we all remember about the adverse events such as febrile neutropenia. Yes, it's significantly higher in the DCF group. However, if we will consider other groups, then we can see dysphagia as adverse event. Such adverse event as dysphagia is much more significant in chemo-radio treatment in terms of surgical outcomes. We see that the patients where DCF treatment was used, the median operation time was lower. We can see that the residual tumor, there is no residual tumor in neoadjuvant chemotherapy, and it's higher as compared to other groups. But it's logical because there are two methods within this method, radiotherapy and chemotherapy. But if you will consider the previous slides, you might already notice that the total survival is better in DCF, and please do not forget that. And I would like to share a small clinical trial. A female gender, 54 years old, squamous cell carcinoma, second grade dysphagia, 3 courses of NAPCT. Here you can see the significant complications of this case. After 3 courses of DCF, the control study was conducted, and as a result, we see that the tumor got increased, and FEGD scan confirmed that. As a result, it was decided to conduct surgery, and it was successfully done. Esophagectomy was conducted, and as a result of the histology analysis, we see the 2 years after the surgery, there were no signs of metastasis or recurrence. I would also like to remind that in the nearest future, DCF, I hope that DCF will be a standard procedure for treatment of esophagus cancer. We can use the annual pumps for up to 5 days, and it helps to achieve significant result. To conclude, I would like to mention that neoadjuvant DCF is an effective option that is at least comparable to and possibly even better than neoadjuvant CRT. The DCF regime requires correction of febrile neutropenia, and it's tolerable and can be considered as one of the standard of therapy for esophageal squamous cell cancer. If you are concerned about the tolerance of your patient, then probably you need to conduct 4-6 courses, initial chemotherapy courses. We have a YouTube channel. Please join, subscribe it. Thank you very much for your attention. Thank you, Inara. Colleagues, questions, remarks, please. One small remark, please. Just one small question, please. In post-surgical period, did you estimate the conditions of the patients? You didn't recommend radiotherapy after the surgery in such case that you demonstrated? No, we didn't. Okay, in terms of the methyl we believe that all chemotherapists, the senior experts believe that it's applicable for high infusion. Usually we do not apply it at early stages because uracil is got degraded after the first 20 minutes. The problem is that it's always in active phase as a result of continuous treatment. Probably not all colleagues know that fluorouracil should not be applied. Generally, there are only some small cases when it's relevant. About 80-90 milligrams daily in very small cases, small number of cases. Okay, let's proceed. The next topic is the modern conception. We invite Vadim Gushin. The topic is he is oncological surgeon, director of gastrointestinal oncology at Mercy Hospital in Baltimore. Please, the floor is yours. Distinguished colleagues, thank you very much for inviting me. It's a great pleasure for me to see the city. The center of the city is beautiful. And I'm also very pleased to meet the hospitable, kind people of Kazakhstan. We cooperate for more than 2 years with our colleagues from Kazakhstan. I had a question to Miram Askarevich, why he assigned me to prepare the presentation on such an unusual topic for a surgeon. I'm a surgeon myself. It's just my daily routine in my week. Last week was successful. I conducted gastrostomy, and to be honest, I feel much better in surgical room when I do not need to talk with anybody. I'm introvert and I'm surgeon. That's why in terms of any discussions, it's very difficult for me to discuss something because it's much better for me to just be silent and to provide surgeries. 20 years ago when I graduated my studies in surgical studies education, when I came to my first workplace as a young specialist, they asked me to conduct impossible, to consider the NDT. NDT looked as follows. The surgeons came and showed their pictures or videos and told how good it all went. Surgery was successfully conducted, and chemotherapists, they enjoyed to discuss lymphoma. They were passionate about that, but for surgeons, it was not interested. That's why there were no successful discussion among them. And I was assigned to take several business courses in order to learn how to ensure productive discussions among medical specialists. By business courses, I mean that there are a lot of courses in any university, business courses, how to organize effective group discussions. And on the screen you can see a picture, our usual NDT, multidisciplinary team, MDT. And during such meetings, we show them results of microscope examinations, the scans of our patients. And today we are going to discuss the anatomy. How do we decide in our multidisciplinary team meetings what we decide, how we decide, and why we decide. And my goal is to prove that multidisciplinary conference is not something unusual in nature. It's not objective reality. It's something that we can ensure and it's possible to do. And it should serve a common goal. When patients are diagnosed with oncology, and these patients come to oncological centers. They're very weird thing. The tumor is divided into several small pieces. Surgical part, piece, oncological piece, they are undergone CT scan, MRI, and all. There are a lot of different pieces and different doctors. They consider their own pieces of this tumor. When I communicate with patients, there are a lot of cases when there is dispersion of the diagnosis, and patients are very concerned. They don't understand these pieces. Patients do not understand why what doctors are responsible for their treatment, and there is a philosophical approach. I have my own philosophical approach to MDT. MDT, I believe, collects all the pieces in one united tumor, in one clinical case. And as a result, there is coherence. As I mentioned, MDT means taking joint decision, group decision, joint decision, based on several principles. They are very different as compared to individual decisions. And there is a separate research area. If you have ever watched famous TV shows, for example, famous Russian show «Что, где, когда», if you watched it, you know. For me, it was particularly interesting to know large research, which was conducted on large population, and usually the population is unprepared. There are a lot of specialists in any area to answer the most complex question in this «Что, где, когда» TV show. 95-97% of people sitting in the audience in «Что, где, когда» TV show, they will eventually answer the question irrespectively of the difficulty of this question. However, there are certain rules for group decision making. Lots of people with different backgrounds should be provided. There should be a mechanism, existing mechanisms, how decisions are made. For example, there might be a lot of hypotheses, and on this slide you can see the basic principles of decision making. I need to mention, however, that people from different backgrounds doesn't mean that they are necessary should be surgeon, radiotherapist. There should be a radiotherapist, for example. We have business representatives in our multidisciplinary team. If we have decisions that require business approach. So our team includes very different stakeholders which have different visions for in oncology. We also have independent opinion of participants. But I don't think that it's very independent. We all depend on each other. Of course, some people like each other, some not. Nevertheless, we still might have small fights among each other. I believe that there is no completely independent views. We need to think jointly. And as a gift of our joint work is consensus. Consensus is a gift for us. Consensus is ensured as follows. First, all the participants of group decision making, they agree that we are going to do as we decided. However, it doesn't mean that all the participants agree with an opinion. They just agree that this opinion is honest, and even if I disagree with a certain view, I will still adhere to the procedures. What are the goals of multidisciplinary cases? The goal you decide yourself. Some cases I know in Kazakhstan, for example, almost all the diagnoses, all the patients must be diagnosed as a result of MDT discussions. For me, it's quite complicated. Why? Because it's a huge work, and honestly, I don't know how you do that.
So the analogy in my situation, all the patients with the sarcoma should be presented, and all the patients with the colon cancer should be presented more than one time, and this is the certification requirements, and we cannot do anything with that. So they are presenting the patients to demonstrate how I'm a cool surgeon and what kind of tough cases I had in my job and how did I deal with that, and there are lots of young specialists demonstrated their capabilities, their skills, and skills with the presentation of the patient. So it is always better to work individually or sometimes with a group if the workflow is set up in a proper manner. So then what kind of risks do we have in the group decisions? Like in the individual solutions, we have the certain bases in systematic errors. The one that is widespread is the group thinking. This is when for the certain decision they come up very quick and they have the same condition, so to speak. There are the dominance of individual thinkers that but in fact, this is again, so we don't have such a struggle, and from the side we can see that there are no discussion that way, that we have a common solution for everything. However, knowing about this could be very handy, and the escalation of the therapy is quite a frequent the basis of the group decision, and one person says, I did a HIPAC, I just replaced the liver, and one says I did something. And sometimes they do that too much. And I would say that the group decision making can't be done individually, and every person should know the cases, and everyone should be well prepared. So the main significance is given to the moderator, and this is the person who orchestrates the entire discussion. If you take a look at the picture, the discussion should be given laterally rather than vertically. So I shouldn't justify to the chairperson that my case and my solution is one of the best. And here, the discussion should be between the members of the MDT rather than vertically to the chairperson. So the role of the chairperson to give the floor to everyone and to sort out the important information about the patient, and also to prevent conflicts between the members. And first of all, the MDT is about the interaction between the colleagues, and there are nothing objective. I would say that if the one thing that I would like you to remember in the presentations, the MDT is about the relations rather than objective reality. I would skip this. How do we, what kind of approaches to invite the patient to the MDT. So there could be some sort of information. The first thing is how do we speak with the patient? We try to avoid without the constructive words, and we would tell that there will be the certain treatment. And when you are presenting the patient, I always advise to describe him or her with clear words, like a female of 20 years old, like instead use the young mom and show her profession, and which makes the person more natural or human. And that way, if you are presenting me as a patient and telling that it is important to me to proceed playing the musical instrument, and that will seriously play of the selection of the chemotherapy, for example. Mention about the preferences of the patient. For instance, he afraid of from the chemotherapy of certain type, or the special chemotherapy, or frightened from the surgery, or he wants to conduct the surgery, wants the high pack, and show that the preference of the patient. So this is how we showed the logic model to evaluate the MDT's process when there is a consultant and the person who conducts the certification of the center. This is how we determine what works and what doesn't work in MDT. Inputs are the input data, and if we have the wide range of the specialists, and if we have the place for conduction of the therapy, for where, or on a place where we have the projectors or the microphones, if there are any skills of the introduction to the MDT, whether the people get prepared to this conference, and these are very regular things. If the microphone doesn't work or computer, you can easily see how the entire discussion could be, and there could not be any outputs. What kind of problem? So also they take into account the opinions, whether they prepare that the participants get ready to the conference, or they're reading that by the last moment. The results will depend on what kind of objectives you are setting, or that's the changing of the plan or the prescription of the treatment. I have a goal to change the MDT, and usually it happens in 30% of my case, or it should be done as per the requirement of the certification center. So this is all. If it's only for educational purposes, the resident who presents the case, whether they follow the certain plan, and how they were professional, or that would be the work of the onconcentra, how it is, how the treatment is conducted, and in a gastric cancer, and how do they scan it, whether it is done timely, whether they conducted a new adjuvant therapy of the third and fourth stage of the cancer. And I think that here I will finalize my speech. The thing that I would like to say after this presentation, so you could remember, MDT is about the group decision making. It is still being studied. If you want to have effective MDTs, I truly advise you to review the literature on the group decision making. The MDT, first of everything, that's the discussion between the relations of the members. So what happens in MDT, that lays in the MDT, nothing go beyond of that group. in our study. Everything stays in secret, and we try to bring the patient to a certain type of descriptive or asking their preferences on MDT. This is what I wanted to tell, and if there are any questions, I will reply to you. I think you have to take the microphone and use the microphone, please. So in the beginning of your speech, you said that you are the introvert, which is very good. I have a question. Please open the secret. So it says that it's always better to work in a group. So they're not secret to disclosure. This is not from medical literature. How such decisions are taken. The individual decisions is related to only one person. When we're taking an appropriate decision in a group, then that usually are the important decisions, and they are mostly related to the large number of persons, and respectively, I don't remember what kind of the exact studies were conducted. However, the possibilities to impact to the on objective outcomes are not. So the possibilities to deviate to another side is kind of easier rather than if we look at the ceilings. So the part of this room will look at the ceilings. So by following the behavior or actions of that person, the same happens with the group decisions. So being a part of being in a group will lead to such kind of results if there are the incorrect MDT. So I would recommend then to invite a third-party specialist. I think that there are lots of cases in Kazakhstan. This is well developed in Kazakhstan. So it won't be difficult to map how the interaction is conducted between the people and what kind of outcomes it may lead. Vadim, thank you very much for your speech. I have a couple questions, if you let me ask. The first question. So the first question regarding the consensus is not always when I agree or when I'm following the actions of the group, and that's in the ethic code, and like us, for the physicians, we have to work on the best interests of the patient. It contradicts with the, for instance, when I'm reading the decision of the Supreme Court of the USA, that in your real practice in MDT, whether there is disagreements with the group decision, so if there is a disagreements, do you register them? So in US, such things happens in very unique way. So MDTs is conducted to take to some kind of consensus, and there are no any legal. We cannot hide behind the MDT, and personally I bring up the case to the MDT, and somebody can advise me something, and first of everything I'm interested in knowing the opinion of the counterpart, and if I'm interested in someone's opinion, and that way there would be less conflicts. So conflicts happens very rare, and mostly between the persons with the same major. So the big conflicts happens with my senior fellow partner, and we have the totally opposite opinions usually. However, we get energized with our ideas, and therefore I don't like to agree very easily and very quickly. I always like to know something which I didn't know before, and that way we argue to one another. As for your question, I usually take my decision, and every person who raises or delivers the cases, so they take the decisions themselves. So it is always different when there is a dissent. I'm not sure that whether I answered your question. Since there is a final decision, it's always individual, it is quite clear. The second is the participation of the patients, and this is my personal experience. So that usually when there is a concilium, it looks like it looks like it's like always like a verdict or sentence. Very good methods are provided or presented by the nurses. There were cases, and this is mostly humanize the person. This is the best way to describe the opinion in the MDT. Colleagues, are there any other questions? Yes, sure. Please go ahead.
The microphone, please.
I really appreciated your part about including patients in the MDT. And you mentioned that if we include the patients, we should take certain steps, such as not using medical jargon. What do you think are other steps that we should take to make sure that the patients feel comfortable and safe enough to participate in the MDT, to express their opinions?
Looks like I misspoke a little bit about talking about patients. They're not present typically in MDT, and the point is not to use the jargon, but to have kind of normal presentation, not like 40-year-old female. This is like you are talking about in the zoo. Right, they're real people with real professions, with their real social roles. Their mothers, and some just make them more humane, you know. That's what I meant by that. So those are the methods to talk about patients in a different way, not in biological way. It's not only about biology. We see a lot of options. We have a lot of options with different profiles of side effects and stuff like that. So that's what I meant.
Can I ask one more thing?
Yeah.
Do you think patients should be included in MDT so that they have full information about what is going on with their case?
I don't have this experience. I only saw it in former Soviet Union, and it looked awful.
Thank you.
I wouldn't want to be an MDT. Like as a patient.
Thank you.
Yeah. Any questions?
Yeah, just a comment, if I may. So thank you for your presentation. I definitely took something out of it. Going back to the previous point, in Germany, you have to reach a consensus. So we're not allowed to bring a patient to OR or surgery if there is no consensus, especially for peritoneal surface malignancies. Maybe for other things, sure, but for our group, we're not allowed to. So there is some sort of pressure to reach a consensus. We solve that by, so when we come to these conferences, we take our oncologists to surgical oncology conferences, and they take us to their conferences, so that we're all always speaking the same language. We try to travel as a team to the different conferences, so again, we're speaking the same language, and that makes the MDT boards a little bit better. And if we don't reach consensus, then we do have like a supervising board to help us. So there are some medical legal consequences if we do not reach consensus, just to give some extra force to your.
Yeah, it looks like it's country dependent. But I actually wanted to make a point that there are very few instances when we have disagreement. Tumor boards is not about solving disagreements. It's about expressing opinions and kind of asking for somebody's advice. So that's, and it works most of the time, like 95%. It's very rare where we have conflicts, very rarely.
Вадим, еще тоже вопрос все-таки.
Вадим,
I believe it also concerns emotions. It all depends on the conditions of a patient. For example, if a patient is old and he or she has children, it all gets very emotional. So how will you make decisions? For example, 42 years old woman, 5 children, very active, socially active patient. And now, for example, 40 years old man, very bold. So how do you make decisions? It's very difficult emotionally. It just unclear for me whether it's do you dwell on emotions in your MDT? It's just the first question. And the second remark, in accordance with our legislation, we conduct consumes, and sometimes we do not argue in front of patients. For example, we discuss something in his or her presence, then we ask them to go, to leave, and then we discuss something personally. Why it's relevant? Because sometimes when we use very simple terminology without jargons, explain something for our patients, in most of the cases they are satisfied. However, the relatives of a patient might be very concerned, very anxious about something. Okay, clear. Thank you very much. I wish I can make decisions nearby a patient. Honestly, it's difficult for me to make decisions when a patient is sitting nearby. In terms of emotions, I don't believe that I'm going to do HIPAC for a very emotional person. Not because he's bold, he's bad patient, no, because he doesn't have emotional support from family or from others. Me as a surgeon in Baltimore, every third patient is outrageous, is this kind of patients. And I believe it as a result, your decision is more detailed, and I don't believe that emotional aspect is bad. Thank you very much. 2 more remarks about emotional aspects. I believe it's necessary to be emotional because we decide a destiny of a person. 1 child or 5 children, it doesn't matter. In my experience, it helps. In 2019, I have a patient with kidneys cancer. Back then there were no target, no immunotherapy, kidneys cancer, and they answered that they are going to be undergoing therapy. And relatives of this woman came to me, of this patient came to me and asked, please do something so this patient can survive until her child will finish the first grade. So yeah, I fully agree that we need to take into account social status of a patient, because sometimes the results might be very bad after our expensive treatment methods. It might be ineffective if the social status of a patient is irrelevant in the context. And I would like to thank you very much. Honestly, I heard a lot about MTT, but no offenses. But sometimes when we include radiologists in our MDTs, we discuss something in the presence of patient, because in accordance to our legislation, patient have to know, they entitled to know everything related to their treatment. That's why we include them in MDT. And secondly, it also protects us, doctors, surgeons, because otherwise patients are entitled to file a suit in a court if they are not informed enough. Sometimes in our NDTs there might be several absolutely different viewpoints when a consensus is not possible, but sometimes the chairman of our MDT, sometimes he might be very active, sometimes they are passive. When the decision is just protocol, yeah, it's clear, the decision will be very quick. But when if it's not simple protocol decision, but a very comprehensive, difficult decision, then the situation is different. Each MDT member should be responsible for decision making based on their own professional perspective, and of course take into account the destiny of patient, because there is nothing more valuable than a destiny of our patients. Thank you. Okay, next speaker. And a concluding report, what is necessary to know for neoadjuvant pancreas cancer. Molskov Mikhail, Russia. Please, the floor is yours. Thank you very much, distinguished colleagues. Thank you for inviting me. Usually at the beginning of the lunchtime the hall is half empty. That's why, since we are far behind our schedule, I'll be very brief, so you will all be free to go to lunch. Me, as a chemotherapist, usually I don't have much conflicts. Sometimes I might have a conflict with Mr. Miran, because he assigned me to prepare the presentation on this topic, but it turned out when I prepared the presentation that it's quite boring. There is no interesting literature on this topic. So let's discuss, why do we need neoadjuvant therapy for pancreas cancer? Who need that? Why? What is the price? And so on and so forth. So traditional hypothesis in the existing research for neoadjuvant pancreas cancer. Thanks to neoadjuvant chemotherapy, we can achieve clearer resection. We can filter our patients, filter those patients who might probably do not need surgery because it will be ineffective for them. We can guarantee chemotherapy, which, as we know, might increase their survivability among these patients, and sometimes after surgery it's not that effective, so we can affect metastasis and do not waste time for post-surgeon procedures. So in terms of limitations, there are several bold, I would say, statements. I would say that all the previous research on these topics are not really good. Sometimes they didn't measure markers. and it's absolutely necessary. Sometimes these trials were conducted before the modern chemotherapy appeared, and I believe it will be very interesting to know the opinions of surgeons working here in ROC. How do you believe whether it's necessary in laparoscopy, whether it's necessary if metastases were not found in MRI or CT? So who do we discuss? There are only 1 out of 5 patients who have resectable type of cancer. So therefore the majority do not have. So there is the main question whether resectability contributes the general survivability. Here I answered no, because based on the meta-analysis data, the answer is no. Of course, there are different meta-analysis. Some studies say that it increase survivability a bit. Some say that no, it doesn't. So I highlight that we are talking about resectable cancer. So yeah, there are different analyses, and meta-analysis do not provide us a clear answer, especially when the data difficult to interpret. In terms of borderline resectable markers of pancreas cancer, there is a much better consensus in accordance with the existing data. Chemotherapy can prolong the life of patients, and it's quite logical, right? So the patients whom we can convert from when it's not clear whether the tumor is resectable or not, it seems like using chemotherapy there are more chances for longer life. So it seems like the surgery is the better option. There were no data that resectable patients can be cured without surgeon, just using chemotherapy. Of course, chemotherapy prolongs life. However, it cannot fully cure a patient. So we didn't yet prove that neoadjuvant chemoradiotherapy among a resectable patient prolongs their life or improves quality of their life. However, some people started to discuss what type of therapy is better. The conducted trials didn't provide an adequate answer to that question. Non-FOLFIRINOX, no abiraterone did not provided any significant benefits against each other. So the pictures on the screen, this picture is my own, not from the articles that I have read. Here I would like to show that even the study where I mentioned 1/5 of all the potential resectable patients existing, even when we start to study them, taking patient to 3, half of the potential patients are relevant. So some patients turn out to be relevant for this treatment since they're intolerant, and so this funnel is unclear. I believe marketing experts will be dissatisfied with this funnel. It seems like it's not that effective. When I considered this data, it was surprisingly for me that we do not fully understand the situation. There are a lot of contradictions in terms of the assessment. SWOG of 1505, there was a case when the scans, the resectability was analyzed in the concilium, and then there was an additional independent opinion of the external experts working in other medical centers, and they asked them whether this tumor is resectable or not, and 30% of all the cases were excluded. It was decided that it's not resectable. And in other studies, there were no central review. That's why there is a question. Those patients where there were no external specimens, to what extent they were resectable? Because in accordance to this analysis, there is a 30% contradiction in the radiologist's opinion. Okay, next study. I believe it's the most interesting one out of all the randomized studies. Here there was a question. Yes, probably surgeon should go first and then the rest of the treatment. It's an interesting question because the modern chemotherapy looks as follows. So the question was, no, there is no after neoadjuvant FOLFIRINOX, as a result, resectable survivability among resectable patients is not improved. There is a next funnel. It demonstrates that out of 500 patients, very small portion of patients were relevant, but I believe we already discussed that. One more interesting question, it was already discussed by my colleagues. Surgery after neoadjuvant treatment, to what extent it's difficult? Some surgeons say that after radiotherapy we will not provide surgery. Why? Because there will be a lot of post-surgery complications. It turned out that yes, after neoadjuvant radiochemotherapy there is a significant difference. There were significant post-surgery complications if the patient undergone neoadjuvant radiochemotherapy before the surgery. Next is the complexity of the sample. Of course, there might be false positive, false negative results, and the majority of the studies research studies, there is a lack of sample. In order to prove a hypothesis, you need a large sample size. As I mentioned in my funnel, a lot of patients are irrelevant as a result, and out of the 7 meta-analysis data, 4 of them were not relevant since there was a small sample size. There was a publication bias because a very, very small portion out of the studies are eventually get published. Probably we need an additional research which might provide a reliable, adequate answer. Okay, I already mentioned that after neoadjuvant radiochemotherapy there are much more risks if the surgery was conducted after this therapy. I already mentioned. The next question is whether it increases RO. Yes, it seems like in the majority of situation R0 resection provides more chances. However, please consider the distribution. R0 resections, the upper line, violet line, means the number of R0 in different studies in neoadjuvant, and the second line is in other cases, and now it's the resection rate itself. Sometimes we say that if we are going to do neoadjuvant, there is no R0 chance. Some people say that it's not that reliable. That's why we cannot provide adequate answers. So, now conclusion. I cannot say that NAPCT significantly improves survivability among resectable pancreas cancer patients. Non-NAPCT scheme is relevant enough. And I would recommend NAPCT only for borderline resectable after careful consideration of resectability. Sometimes when we consider other opinions of other experts, it means the resectability, opinions about resectability varies a lot. Okay, colleagues, do you have any questions, remarks? Good afternoon. Thank you very much, Mikhail, for your interesting report. For us, pancreas surgeons, this topic is quite common because the research on neoadjuvant chemotherapy is well known. I was in Pittsburgh back in 2015, and back then, existing research did not indicated any significant difference in survivability. Now all the pancreas surgeons widely discuss the speech of Buchler back in Istanbul when he mentioned that probably he meant resectability as general. Probably he didn't mean he meant that the tumor is a kink and the surgeon. Now I believe that neoadjuvant radiochemotherapy is a matter of selection.
I think that for the resectable is the way of the selection and the treatment. Okay, you? Thank you very much for your presentation. This is the first time when I see the medical oncologist that the chemical therapy is not efficient. Thank you for validating that. So just a short commentary regarding the resectable cancer of the pancreas, and the PAC trial has shown that perfectly that there are no any advantage. And however, we have to look at the trials that the median of the survivability. We are talking about 19.5 months or 20 months. If you agree with that, as for the borderline, you would agree that that the chemotherapy and the neoadjuvant chemotherapy, we have to look at not at the treatment or the prolongational type of the treatment. It's kind of test whether this patient will withstand the chemotherapy or. I do not agree with the biology. Biology is always a queen, and this is not a neoadjuvant. This is the biological test of this tumor. But my question, let's say that the neoadjuvant chemotherapy, but the patient, due to the toxicity, we know that the toxicity of the chlorofluoroxanox, we suspended the chemotherapy, but there are no any progress. That the borderline resectable or the artery 180 degrees, for instance. Would you propose this patient to the surgeons who, for instance, you stopped the chemotherapy on neoadjuvant due to the toxicity? Look, if the patient from this toxicity past this toxicity and the surgeon is ready to conduct the surgery, then I would let him. But to my case, I wouldn't take that. Thank you. I have as a follow-up question. If you, as Dr. Antanas tells, proposing the surgeon surgery, in what period you would advise that? I think that's it's more. So this is the question to the surgeon and how he evaluates the status or the condition of the patient. It is clear that if we realize that the disease is advancing in the patient, and we conducted lots of the CTs, and we revealed the advancement of the disease, if there are any timelines, let's say a month, then I think we can do that. This is the question, how the surgeon is ready to take such patient based on the condition of the patient. So nobody likes the chemotherapy. So what do you think about the regional injection of the chemicals, for instance, towards the pancreas? I do not recommend that. We don't have a good data. In my head, I don't have it. Therefore, we do not use this method. Colleagues, are there any questions? If no question, I think that we can, as a wrap up, I would like to say that as for the pancreas cancer, like Janat said, that this is a selection of the patients. So if the patient can pass the surgery, my point of view, and it doesn't matter what kind of pancreas cancer or the colon cancer, if the patient is ready to pass the surgery, we can do that. Otherwise, the half of the patients will be quite away from the treatment method. As for the neoadjuvant therapy, if the patient received that we take only the patients after 6-8 weeks of since he received lots of the treatments, and after that there will be more complications, and also it is also related to the hematological side effects, and that way the surgery will be very difficult to these patients. As for the question, as the regional chemotherapy, we're collecting the data, and we can tell that there are no good results, but this is a good way forward to review whether it is possible to conduct such regional injection. If there are any other speakers, and you can take the microphone. If not, we can finalize this session. Colleagues, once again, thank you everyone for your speeches and the presentations. I wish you success. This was very fruitful conference. I'm not the person who can interrupt this kind of lunch. I think we can take a break, and we handle this. Distinguished ladies and gentlemen, we will resume our session at 14:10. Thank you very much.
Уважаемые коллеги,
Distinguished colleagues, please be invited to our next session of the multidisciplinary treatment of the colorectal cancer, and the moderator of this session is Dr. Antanas Gulbins, the MG, PhD, the Klaipėdos University, the Klaipėda, Lithuania, the Ayupov Rustem Talgevich, oncologist surgeon, and the deputy oncology center of the Bashkortostan, Ufa. And Dr. Shpatayev Janat, the chirurg, the surgeon, transplantologist, the organs, and also National Oncology Center, Astana. Distinguished colleagues, good day. Let me introduce the first speaker. This is our friend, colleague, Mr. Professor Antanas Gulbinas. He is proud of our collaboration. We've been collaborating for 5 years, so this is a quite big effect of our collaboration. We had the pancreas center, and our collaboration led to we conducted a pancreas resection per year. Professor Antanas is a European scholar. He worked in Pucler, therefore we are truly happy to see you here. And today is our subject that we achieved some results from the pancreas surgery, and after that we got some results from the resection surgery, and currently GCK currently do not conduct the surgery. Adenocarcinoma is quite rare, and the main volume is from the colorectal cancers in the hepatorectal surgery. So why we don't have it? So it became a problem, and we started to investigate, and these are the two presentations. The first presentation about the colorectal cancer liver metastasis strategies and perspectives. Thank you, Janat. Thank you to my Kazakhstani friends for the invitation. I'm always happy to be here in Astana. I had worked for 2 years in Astana. This is like my hometown. Thank you to Mehram for giving me the chance to be the speaker here about the colorectal cancer liver. So my slides will be in English. I'm not good at the Cyrillic letters, so therefore the slides were prepared in English. So I will speak about the main methods of the treatment and the approaches of the colorectal metastasis, and how we changed our understanding on the resectability of the metastasis. If you remember, just recently, 20 years ago, when we saw that the resectability of only one metastasis, if there are more metastases, we started using the chemotherapy. We will discuss about the surgical tactics, and all about this from the perspective of the administrative perspective, how we should maintain these patients, or how to conduct the treatment. We all know that during the operation of the duodenum of the colorectal cancer, 1/4 of patients are changing the metastasis of the liver, and rest of the 50% develop after the surgery of the primary tumor. We know that this metastasis can be early, synchronous, or we have seen lots of videos today where there is a synchronous, the rectal resections, and the resections and the metachronic resections. And today I would like to talk about metachronic metastasis. As we know that most patients, and more than 50% after the resection of the colon, would have the metastasis in the liver, and when they will develop them and how we can find them. I think that we all understand that these patients, we are working for the patient, and the patient is the center of our work. However, there are the evidence after the initial surgery, the patient passes the examination in a regular manner in the same clinic. Then the survival rate of these patients reach better indicators, and that the metastases are identified earlier, so we are not losing the patient that way. We all understand that we can lose the patient after the first surgery. In Lithuania, this was conducted in a governmental volume. There is an order of the minister where they have the classifications of all the tumors, and also there is an obligation that these patients are checked with a certain time intervals, and we have this kind of tables, and we have to follow the minister's orders, and the patients after the surgery of the colon and after the resection, they have to, if it's even successful treatment, they have to be examined by the oncologist, the chemotherapist, and surgeon. And this is very important, and there are the majors who conducts this kind of examination. And currently we have the increased nurse practices, and we have to be examined by the nurses. And this is very clear that for the treatment of the colon rectal metastasis, so there are lots of methods, the chemotherapy, the local ablation. We have to look at this as one thing, and have to select the method which will be appropriate for the specific patient. As for the local ablation, I think that the best trial is that the collision trial has shown that during the multi-metastasis, the local ablation is not bad versus the surgical treatment. We have to take into account that the local ablation should be in our tool set in treatment of the metastases. As for the surgery, it is proved that the surgery type of the metastasis is beneficial and provides 5 years survival, and the survival rate increased to 65%. While the chemotherapy, the survival rate is only 14%, and the 24% of survival rate for the 10 years. However, we have to acknowledge that the surgical treatment is not used in the treatment of the patients with the colorectal metastasis of the liver. And why it is so? Because there are many reasons for that. We are losing the patient. The second, the surgeon have different approaches for the resection of this metastasis, or the patient are not referred to the surgeon, and resumes to take the chemotherapy, and then all the responsibility goes to lays on the oncologist chemotherapists. About 20% of the patients who are referred for preoperative systematic therapy could be operated on of the resection of the liver. To do so, we need to take into account one prerequisite. If we revealed the metastasis in the patient, the hepatobiliary surgeon should examine that patient. However, hepatobiliary surgeon is not the only person who has to decide about the resectability of and also select other types of the treatment. And the MDT team is the central system where they take a decision. I'm not going to talk about MDT too much. After the presentation of the Vadim Gushin, it is not necessary anymore. I would say that these kind of strategic decisions, like how to maintain the patient with the colorectal metastasis, we have to hold the multidisciplinary team for the further decision. So these teams could work in a progressive manner, and here again, I think that there should be the governmental approach. And here I would like to show you that in our country, in Lithuania, we have the orders of the minister who regulates the work of the MDT team, and in the hospitals and the clinics where the patients are lying in oncology departments with a 3 billion population. These are the two Astana cities. In Astana, we have in Lithuania we have 5 hospitals which belong to the oncology cluster. Only these hospitals are allowed to work with the patients with an oncology, since these hospitals have the MDT teams and the consiliums. And there is an order that they have to be consulted with the manager individual right from the beginning till the end of their treatment in a green corridor, so that the patients with the oncological diagnosis, they could go without any line, and they can get certain support from these hospitals. And there should be the scientific activities in these hospitals. Like I've said before, they should have the multidisciplinary consilium. So the resectability is taken, the decision on conducting of the resectability, they take a decision based on the factors of the patient, the status of the patient, the biology of the tumor, and also to the technical and surgical aspects. Since the resectability, like in cancer of the pancreas, is not only the surgical aspect, this is also the biological process. It's also this. If we talk about that, the surgical part, we have the R0, and we have to leave the remnants of the liver to provide the normal functioning in the future. So resection is conducted with the atypical and anatomical side, and atypical metastases are and they also reached the R0 with the atypical, and also they conducted a resection, and they are all efficient, like anatomical resections. The residual remaining part of the liver, upon the surgery of the colorectal cancer or liver, we have to save as much as we have to preserve the maximum amount of tissue in the liver. In the perspective to the future, maybe there will be additional resection of the liver. Maybe this metastasis can develop in this part of the liver which was left. So the resectability, we understand that there is a pancreas, there are the metastases which can be visible as a resectable, and there are the metastases which are not resectable, and in 6 segments of the liver, and more than 70% of the tissue is filled up with the metastases. However, if we conducted a marginal resection, which technically, like couldn't be removed technically with the R0 status, but in future they can be removed. The main slide in my presentation, this is the slide which shows the evidence or proof of this resectable metastasis is not more than 10-15%, and other amounts to 80-85%, which are not resectable, and that's the marginal resectable metastasis. What's the strategy for the surgeons? So I'm not going to tell about it in detail. There are the atypical, the parentypical, the preservable surgery. In the surgery of the metastatical liver, this is a 1-stage or 2-stage procedure, mostly depend on the patient, on the localization of the metastasis, and how they are big. The question is about the resectability of the metastasis, whether the patient should take the neoadjuvant chemotherapy. So the answer is in here, and it is proof that the resectable metastasis, this patient should pass the surgery, and the methods of the resection is the priority method is the atypical resection, in which the results of the survival rate is equal to the anatomical resection, but by doing so we preserve the tissue of the liver, and how it is possible.
Но есть вот этот пул пациентов.
But there is a pool of patients, and Miram kindly asked me to mention them, non-resectable metastasis, when if they are not within multidisciplinary team. I'm sorry, medical oncologists, but sometimes if their patients are treated by just oncologists, sometimes these patients might be dead until the resection. That's why it's proved that 10-15% out of these patients in future might undergone surgery, and their survivability will be increased. But for these patients, we need neoadjuvant chemotherapy or conversion therapy, so-called conversion therapy, when there are two main goals. The first goal is to reduce the tumor volume or to test a tumor on its biological resistance. And one more goal, when a liver remnant will be not enough to augment this remnant of the liver. Neoadjuvant chemotherapy, or with or without biological therapy, is not my competency. That's why I believe it's not my area of expertise. Medical oncologists, I believe, take these patients with borderline resectable patients, and they might cure up to 35% of such patients. However, we always need to think about this window for resection, necessary window for a surgery. What does it mean, window for surgery? It means that we should not prolong chemotherapy, not more than 6 chemotherapy courses. Why? Because such a patient will not survive until the surgery. And as a result, we will need to look for a needle in a field. However, after chemotherapy, we all understand that some time is needed for a patient. After chemotherapy, this time should be wisely used for 5 weeks, approximately up to 6 weeks, not more. And if the disease is stable, then this patient should undergo a surgery. If the disease is progressive, then it's another issue. We need to answer whether these metastases are resectable or not. As I already mentioned, it was proved that neoadjuvant chemotherapy is not recommended for primary resectable metastasis due to its toxicity. Toxicity for a liver, because the disease might be progressive, because metastasis might disappear, and as a result, the post-operative complications increase. If it's resectable, then such a patient should go to a surgeon and to undergo a surgery. Second important milestone is augmentation of the future remnant of a liver. There are several methods, for example, portal vein occlusion, PVE, PVL, hepatic veins deprivation, LVD. So the best results are usually when there is a deprivation of hepatic veins. However, using such an approach during resection, only 75% of patients are able to undergo such surgery, because this remnant liver will not be enough for a resection. Dr. Amtanus, I'm so sorry to interrupt. Just 1 minute left because we are behind our schedule. Okay, just 3 more slides. non-resectable metastasis. This work is usually conducted by medical oncologists. However, there are issues of transplantation of the liver, and it's still not included in Lithuania. There are no guidelines about the transplantation of liver in case of colorectal metastasis. And to conclude, the final message is that yes, there are multiple treatment methods, and each patient which have liver metastasis, each patient should be carefully considered by the hepatobiliary surgeons, and the resection should be provided if it's relevant for a particular patient, and the decisions should be provided by MTT, multidisciplinary teams, as I mentioned. Such decisions should not be made by a single doctor. It's a multidisciplinary approach. Thank you very much. That's it. Thank you, Dr. Antanos. I believe you persuaded that we need to do resection of liver in case of metastasis, that it generally increases the survivability of patients. Thank you very much. Okay, shall we postpone Q&A session after all the presentations will be delivered? Okay, next. Okay, we came to conclusion that resection is necessary. So what happens in our country? There are very few cases of resection of in case of colorectal cancer, and we decided to figure out. Our center conducted a study. We established our own register of colorectal cases, and that's why we came to a conclusion, came to a picture to understand why majority of patients are not undergo this resection. We have only 2 BHP centers in Kazakhstan. It's difficult to ensure resection, and we have a separate report about that, but unfortunately we need to postpone because this presentation will be delivered by Saule, but Saule left us because she has a very urgent surgery. She will come a bit later. That's why we are going to have Jakipov Murat. He is the head of the Department of Radiology in NROC. We believe this topic is crucially important. We always say that there should be a feedback among radiologists and oncologists. That's why we surgeons should respect radiologists, and if you ask them to estimate resectability, then you need to give them results for the analysis, what you do, histology of previous surgeries, and so on and so forth. And this feedback is beneficial for both surgeons and radiologists, and Murat Jakipov will tell us about that. Good afternoon, distinguished colleagues, distinguished moderators. Within our MDT, I would like to present my report on the topic of rectal cancer diagnosis and treatment approaches. It's not a secret that watch and wait program becomes more and more relevant for patients with locally advanced rectal cancer after neoadjuvant therapy, and MRI plays a key role to sample candidates and to monitor response of treatment. The goal of my report is to estimate TNM of rectal cancer, to discuss the criteria of MRI for the estimation of neoadjuvant chemotherapy, to discuss the key features of full, unfull, and partially full response, and also to discuss the role of MRI in early recidive or early recurrence identification. So the methodology of MRI studies, I believe this slide is relevant for radiologists. I would just want to highlight last two bullet points. It should not, the cuts should not be more than 3-4 millimeters. If it's higher, it will lead to a fact that there will be small harmed lymphomes. Next point, contrast, introduction of contrast liquids. We use Godavis. Generally, it's relevant. The MRI methodology, next slide here, I would like to highlight that the violation of methodology will lead to wrong stenosis, and I would like to pay your attention about the cuts. If we want high quality cut, here on the screen I highlighted how it should be provided. If we want to have coronal cut, then it should be perpendicular. So what answers should radiologists answer? First is localization of a tumor, upper, middle, or lower, stages of tumor, and stage, and these stages should be compulsory included in the treatment protocols. Of course, we need to indicate whether there are metastases and so on and so forth. T stage is when only the mucosa, there is a lesion of mucosa. It means that there is a signal please pay attention to this part. If there is a hyperintensive signal, when there is a short difference among layers, it means that there is a T stage. In terms of T2, a tumor for muscularis propria. In terms of the T3 stage, there are sub-stages. It all depends on to what extent the tumor is expanded. T3 means that all the layers are involved. Unfortunately, in MRI, we cannot see them. Cannot see the full picture. That's why we need to indicate CRM plus or minus, depending on the type of tumor, because sometimes the tumor may be so increased that it if the tumor is less than 1 millimeter, then we need to indicate that it's CRM plus. If it's less than 1 millimeter, then CRM minus. Here on the screen, interesting example. The first example is C2 stage. Unfortunately, sometimes we overestimate these two stages. It's difficult for us to distinguish the difference. There are several criteria. The first is the first indicator is thin spicula. They might be more intense, more thicker, and they might resemble a tumor, and it indicates, it helps us to suggest that it's rather T3 stage. In terms of T4A, of course this tumor is expanded to abdomen, and there is an invasion, and of course that's why it becomes T4A. In terms of T4B, the tumor is proliferated to other organs. In this case, you can see example of a male, and as a result, this tumor was increased and approached the testiculus. There are satellites as well, and we need to pay attention. For such patients, the frequency of metastasis in the liver much more increased. In terms of end stage, we need to estimate regional lymphoma nodes, mesorectal, upper rectal, pelvis, both ileum and other layers. After that, we identify the status. Radiologists usually consider the size of the tumor. However, it's not relevant because there are additional criteria which must also be taken into consideration. The issue is not always in the amount, in the length of tumor. Sometimes we also need to consider not only the length, the volume, but also the form, the contour, structure, and so on and so forth. Here on the screen you can see a classic example. We see all the criteria: unclear contour, uneven structure, changed form, and as a result there is a loss of fat forms. Okay, next the restaging. We use Mandart MRI to estimate tumor regression grade. It consists out of 5 stages. The first is full response. TRG2 is a good response, third is a moderate response, fourth is a minimal response, and fifth is a no response at all, when there is a no progression, no changes, and no progression at all. Here I would also like to highlight that the control MRI scan should not be provided earlier than 4-6 weeks after chemotherapy. Ideally, it should be 8-12 weeks to avoid false positive results. Mr. Murat, just 1 minute left. Okay, I will speak faster. The full response means when the tumor is more than 70%, it means that it's MR TG1, limited diffusion, and one more future. One more feature is separation of tissue. It should not be more than 4 millimeters, as you can see on the screen. After restaging, we see that the lymphoma nodes got increased to 5 millimeters. It means that the tumor metastasis disappeared. It also got confirmed after half a year. Okay, next about the almost full response, TRG2. It means fibrosis and minimal residual signal. There are slight changes in DVI weighted pictures. Next is on full or bad response. It's TG from 3 to 5. There is slight decrease in terms of the tumor. There are limited diffusion. Some lymphoma nodes were not changed, or about 5 millimeters, and they are automatically considered as the lesion lymphoma. In terms of early identification of early recurrence, there was one very good study in 2022. This study analyzed how fibrosis changes if tumor got back. It turned out that 21 degree, if the fibrosis changed by 21 degree, it leads to the fact that tumor was back. One more criterion, if it's more than 10 millimeter, and the specificity of these two features is 94 and 98% respectively. it got increased to 134 degrees, 10.2 millimeters.
And also, I would like to show my personal experience. There was the invasion of the vessels with the average caliber, and we wanted to conduct the MRI inspection of the liver, and we revealed one metastasis in a distant segment in T2 images, as you can see. So here is the tumor, and the metastasis at the T2 images are visible very clear. And also in our tool set, we have a hypothesis specific for the liver. And by applying that, we truly astonished that there is the small node in simple scans that didn't manifest itself. And we recommend if there is the tool for identification of the small metastasis. Our experience is we revealed from the 18 last patients, and we revealed that by the TRG, and there is an upgrade in 5 cases and downgrade 3 cases. As for the T stage and the N stage, there are 7 matches, and then which is showing the 5 case with a 28%, and also that the 50% of the match in up stage, it's 41%. In the down stage, only 1 case with the 6%. I would like to say that the MRI is a very valuable tool to the visualization of the metastasis in the colon, and also during the assigning the stages of the early diagnosis of the recurrence. Thank you for this opportunity. Thank you so much. The questions will be raised later, but let's give the floor to another speaker. Our next speaker is a change. We are inviting Artyom Borisovich Gogol, the morphologist of National Oncology Center, Astana, Kazakhstan. The floor is yours. The presentation about the interaction with the surgeon, oncologist, and pathologist. Since the pathomorphologist, such profession doesn't exist here. Distinguished colleagues, good day. Today's our presentation will be about to those things that we don't pay attention, but they are very important for the high quality interaction and quality and spotted diagnosis in molecular diagnostics. Before starting working with microscope, the biological material, the surgical material to be studied, they passed the long pass with a large number of complex, sensitive, and stages of distortion. First, as a delivery of the biological material to the pathomorphological laboratory, and then and the multi-component process which help us to assign the stage, and we determine the histological type of we get the sample of the material, and then we start processing, during of which, after the registering them, we send it to the biochemical block, and we get the cuts of it. In the context of the colorectal pathology, how the workflow is organized in our center and studying of the material. First, the entire material that we receive from abdominal surgery, they are delivered in a pathomorphological laboratory in a fresh and condition like in other centers and laboratories does. There are the main aspects. They marking the resected parts. That's the important stage for the pathomorphological study and evaluation of the condition of the thin resection. Without this marking, it is quite frequent that there are the questions how we accurately measure the distance, so either that is more than 1 millimeter or less than 1 millimeter, or it is located at the edge of the resection. Under the impact of the formalin, there we can find that the material either it becomes more tight or more dense or more porous, and they are changing its color or get shrinked. And in the intestines, it significantly shrinked, not in fresh material, but in a fixed shape. We cannot measure the accurate distance. So they should be measured on a fresh material. It is also important to assign a stage. When we assign the stage T4A, that's the invasion of the cirrhosis layer. That's the reaching of the material to the surface, which is also important to work on a fresh material. This is how it looks on a histological material. This can be the singular part from TCT glasses. Then we reassign another stage instead of T1, T4. And also one of the important moments for this Q&A and QC, the factor analysis, that's the analysis of the TMA and SMA. That's the total mesorectum and the total mesocolic. It is done only on a fresh material without the formalin. On the right side of the slide, you can see the differences of the surface of the mesorectal face that we are evaluating on a fresh material. This is an important factor which is evaluated. It is smooth and has no any defects. On the right side, we can see that the material that was exposed by the formalin, we can see that structure is changed under the exposure of this material. It gets deformed and losing the shape. The surface part becomes more deteriorated, and it's not subject for the accurate evaluation. And this factor is well studied and also was included into the tool set of all the centers, and the quality of the TMA is conducted based on the scale of the TMA. It's good if there are no defects not deeper than 5 millimeters, and also satisfactory the defectors higher than 5 millimeters, which do not reach to the muscular part, and the walls of the intestine is not reached, and also the bad results, the defects reach to the muscular part. It is extrapolated by the criteria for the quality of the resection of the qualitative manner. This slide shows interesting study. Data from 2 large randomized trials analyzed the differences from the frequency of the local recurrences and the dependencies from this 3-component evaluation of the TMA quality. We can see that there is a direct relationship. So In the graph below, the data broken down by years from the patients who participated in this trial. When the surgeon receives the feedback from the morphologist regarding the TME parameter, we can see that the TME edges, so to speak, the quality of this surgery is increased by the factor of the feedback. And the main moments that I would like to tell, this is the stage from the intersecting of the vessels until the delivery of the material to the pathomorphology laboratory, because not all the laboratory of this kind of fresh delivery is organized. So this stage is called pre-analytical stage, and during the studies, 90% of 70% of the errors occurs in this stage because the factors that affects to the pre-analytical stage, that's the time for the cold ischemia, that the insufficient data given by the surgeon who will be escorting this material, and also defects and the cuts of the material by the pathomorphologist. So the time for the cold ischemia should not exceed 60 minutes, and for the material that would be molecular genetic testing, like PDL-L1 or MSI, shouldn't exceed 30 minutes. We can increase that process only by chilling the material. That way we can increase the time if your pathomorphology laboratory where is located in a distant location, then we have to chill it down. The direction for the histological study should be full, should contain exact dates of the localization, the clinical diagnosis and stage, volume of the surgery, parts to be marked, brief analysis, and also the previous histological studies to be included, such as the pre-operational biopsy. For the pre-analytical stage, the following are important. That's the decrease of the number of the errors. That's the preparation of the fixation or the macro substance of the resection. So this material should be fixated, like penetration of the formalin into the material is 1 millimeter per hour. When the formalin penetrates to the depths of the 1 centimeter, it decreased to 0. The access for the fixing agent shouldn't be more than that's the bare organs, like they should. Its orifice should be open, and the fluids and the contents of the colon part should be removed. To destroy further immunohistochemistry and the genetical studies. And also ratio is important of the volume of the material with the volume of the formalin. It should be by the standard. We cannot put the big material into the small container, and such fixation is not sufficient, or locking is not sufficient. These are the cases that I've seen in my practice. So this is a micro substance, takes the form of the container which it was filled, and an inner part of the walls becomes more tight and it doesn't let the formalin gets into inside, and the other part, and we are losing the histological and molecular studies. What to do if we have, what if it is impossible to deliver the material under the smooth interaction of the patholomorphologists and surgeons can easily prepare this material with a lockup so they can resect the colon and fill up with the required amount of the agent. It should be resected through the surface so they could evaluate the edge of the resection. In order to evaluate the TME, we need a photo of the area that was resected and send these photos to the pathomorphologist who will be working with this material. The main concept that I wanted to tell with this presentation, our interaction should be coordinated and proactive to improve the life of improve the quality of our studies. There are a whole bunch of studies and literature where you can find all the parameters where our patholomorphologists use during the preparation of the material for the lockup. And surgeons may find it very useful, these sources. And one more thing, when there is a mismatch of the work schedule with the laboratory, it is quite often when due to the harm factor and the time of the work is decreased, that the surgeons can work from the morning till the night, and also we should have a time for the delivery of the material in a fresh shape to the patholomorphologist. We can keep this material in the fridge up to 24 hours without any biodegradation in a protein structure. And one more, I'm going to finish, thank you. And another thing of our interaction, that's the work of the MDT. But we discussed a lot about it, and I'm not going in detail about it. Thank you. Thank you very much. Artem Borisovich, we will try to ask our question, and we will direct to you a bit later. Thank you. We have to continue our program. I see our next guest, Timur Mitin, oncologist from University of the Health and Radiation, Oregon, Portland, USA. Why every second patient with localized rectal cancer should be treated with a proton therapy? Thank you very much for inviting.
Distinguished audience, who already understood what does it mean that every second patient with localized rectal cancer should be treated with proton therapy? How do you think? Why do I mean? We need the results of prospective randomized studies to understand whether protons ensure better results or better results only for specific groups of patients. There are no doubts that it's effective. Large amount of patients undergo therapy with protons. Some some people even conducted an analysis, and they showed that small protons on the paper always look better. So so radiation will be less for bladder if the protons are used, and quality of life will be improved. Each therapist will prefer the doses, less doses if the case is not critical, and the famous radiologists indicated based on randomized studies that sometimes protons are not necessary and even unethical. Moreover, I can argue if we will cure every second patient with protons, but not randomized, but only based on the patient's preferences, or maybe based on the financial preferences, we will always see that the results which will wrongly proved better survivability in case of the usage of protons to cure rectal cancer. Patients who prefer protons compared to those patients who have never heard about protons, patients who are ready to pay a huge amount of money to travel to another country and undergo treatment, patients who are healthy, do exercises, their survivability indicators will always be higher. Now let's consider other retrospective analysis. It's from national databases from the US, and it showed that the patients who undergo proton therapy for lung cancer had better survivability. This curve is enough to, for patients to look in for proton-based therapy, because they do not want to be under the first curve. So what to do if the prescribed doses are equal? Maybe in terms of the further complication, proton-based therapy is better. One more retrospective study from MD Anderson Center demonstrated that the frequency of esophagitis and pneumonia was significantly lower among patients from MD Anderson centers who undergo proton treatment as compared to the results from other centers published the results after proton treatment. Anderson Center doctors conducted randomized study. There were different groups, and this slide demonstrates what happened when protons undergo test within a randomized study. There were no significant differences in local control, in overall survival, in radiation pneumonitis. As a result, protons do not increase adverse effect and do not lead to better oncological results among patients with non-small cell lung diseases of third stage. One more example, esophageal cancer. There are several studies and calculations with beautiful pictures. Looking at these pictures, there are no concerns that protons significantly better for patients with esophageal cancer. One more retrospective study from MD Anderson Center. It says that it demonstrates no significant difference. Even in retrospective, the results are better if we compare it with the patients that undergo proton-based therapy. But what can we do if, what can we say about the randomized phase? Research was conducted, randomized based to be trial on proton beam therapy. Proton beam therapy won. Even in case of larger doses, did it depend on overall survival? The answer is no. Did it help to improve survivability without further disease progression? No. Whether protons provided better, less toxicity? Answer is no. One more question, whether protons demonstrated better assessment of quality of life. The answer was also no. It's all quite sad. However, last year ASCR annual meeting, there was a report about protons and photons in terms of local control and cancer-specific survivability. There was no significant difference in two groups. However, please pay attention to the overall survivability. Probably among the patients who have very good survivability index, and we are talking about squamous carcinoma with tumor of neck and head, the decrease of doses on the less critical organs can potentially use to more healthy conditions among patients. The rectal cancer also have significant indicators of survivability, especially at the early stages. That's why I hope and hypothesize that some patients with rectal cancer, protons might really lead to better indicators of survivability or better indicators for quality of life. I can suggest for whom proton therapy will be beneficial. Young women with rectal cancer who would like to preserve the ovarian functions. One more interesting example, as you can see on the screen, factors associated with premature ovarian insufficiency in young women with locality advanced rectal cancer treated with pelvic radiation therapy. It showed that the fertility was preserved and it was higher as compared to patients which undergo transposition. Only 25% of women after transposition demonstrated these results. Now the experiment on mouses, anti-malarial hormone and the amount of molecules demonstrates better results. That's why I suggest that protons therapy will most likely improve quality of life. Probably there will be more groups of patients where proton will lead to better results of treatment. However, I'd like to warn that the treatment procedures when we use protons is much more difficult. We need to take into account a lot of factors such as the air in the intestine, many factors. That's why it will take a lot of time to ensure that protons will not harm patients due to wrong planning procedures. Okay, your center, I believe your center has a brilliant opportunity to impact world clinical practice if you will integrate in your procedures prescribed protocols of randomized studies. Each patient should be provided with the opportunity to undergo proton therapy. Only carefully designed randomized prospective trial with thoughtful satisfaction will determine a subgroup of patients who will derive benefits and who will harm by proton therapy. And if your doctors will successfully implement these procedures, then your doctors will be on the presidiums of the world well-known conferences. Thank you very much, Timur, for very positive forecasts. We have 1 more minute for a very short question. Yes, please. Thank you very much for your interesting presentation. No questions. The next presentation of Hamzina Saulia Sansesbaevna. I mentioned that the first report of Professor Antanas was about the general strategy and principles that we use to cure rectal metastasis, and this report is a continuation, a strategic plan to cure rectal metastasis cancer. Saulia, very short presentation, please, because we are lack of time. Thank you very much. Unfortunately, I was not present during the presentation of Mr. Antanas. That's why some presentation will be repetitive, but I will be very brief. This report, as was mentioned, should be provided by my other colleague, by Ablay Hamzanovich, but at the moment he's doing his PhD abroad. That's why 99% of this presentation was developed by him, and my contribution is only 1%. Before, it was believed that hepatic reaction from metastasis. In 1989, there was a published article, when it was mentioned that according to retrospective analysis, this analysis showed that patients with metastasis rectal cancer which undergo surgery, their survivability got increased by 30-20%. There is a data, please pay attention. Pay attention to the very last line. It's a famous René Adam, famous doctor. It's international register developed by him, and the amount of patients is about 25,000, and they demonstrated 5-year increase in survivability. About liver mets survey, latest data as of December 2024, it's a huge register which includes the information about the patients with metastasis rectal cancer. It encompasses more than 29,000 patients, more than 300 centers, and more than 60 countries. Unfortunately, Kazakhstan is not a part of this register. In accordance to this register, 42% of patients demonstrate a 5-year decrease in survivability. This slide demonstrates the figures based on our center. A blood exam which provided this information up to 2024. 216 different resections were provided. However, we excluded donors' resections. In terms of metastasis of colorectal cancer of liver, 21 resections were provided in 12 more in other departments. And as a result, 33 resections totally were provided. In contradiction, there is information from Switzerland. Their amount of resection, 150 resections per year, 15% out of them is rectal cancer resection. Now, once again, about Kazakhstan data, we only have information about the mortality and morbidity of rectal cancer, metastatic cancer. However, we don't have a specific register which will reflect the information about the metastasis, liver metastasis. We had a strategy used by NROC, and in accordance to this strategy, they provide expert consultancies for the patients with metastasis, colorectal cancer, and they get consulted in our center. The strategic goal is as follows: first, to increase the number of surgeries, consultations, amount of double resection, two-stage resections, to register not only those who are provided with surgeries, but to register those who just have ever visited NROC. The final goal is to publish dissertations, PhD dissertations, and so on and so forth. The key indicators up to 100 consultants per year, 10-20 surgeries per year, to introduce two-stage resections, and in 2 years to do LTX or rapid. That's our whole strategy. It was very briefly, shortly about our strategy in terms of the cure of rectal cancer, HBP, surgery, our center, radiology center, center named after Sysganov, also works in this area. I will not name all of them. You can see them on the screens. Please do not get offended if your center was not mentioned in this slide. Now let's consider who might potentially fulfill this strategic plan. We tried to analyze it based on the SWOT strategy. We highlighted weaknesses and advantages and disadvantages. Advantages are that we have highly experienced radiologists, oncologists. We have departments of chemotherapy, intervention, which includes HPHR and other departments of intensive care. who works 24/7, are very strong experts. However, sometimes there are such disadvantages in terms of intervention. We have we don't have microwave ablation, we have other equipments, however, they are just being developed. What are the chances are to be published, to participate in grant programs. We need to create main register to cure colorectal metastasis and to improve intervention. The threat is that it can be suspended at any time because it takes a lot of efforts, and this strategy is mainly based on enthusiasm. It's all based on the teamwork. That's why it requires constant contacts, including contacts with patients. A bit later, I will mention the specific figures. That's why we decided to follow 3-stage plans. First step within this plan is to create multidisciplinary liver tumor board, as was proposed by Rene Adam. It's not just multidisciplinary, it means expert MDT, as was mentioned by Rene Adam. The other expert, John Nicholas Wanty, also mentioned, I will skip this his video, he just briefly mentioned how this MTD should look like. These are the key questions that we need to ask our NDT, ask our team when discussing these patients. I will not dwell on them. Next, we need to follow patient-centralized MDT. What strategies we need to follow? What are the options of treatment? It's a cycle process. And in terms of cycle, you can see this screen. Patients come, we tell them that they need to visit other hospitals. Then we invite them to be present in our MDTs. Then we decide their treatment course. So it's all a cycle, the whole cycle process. That's how we envision that. Here you can see the MDLTB model. It includes ABHTB, rectal cancers, colon cancers, pathologists, and others. It's a huge team. It's all cycle process. It takes a lot of efforts, a lot of specialists. And how do we envision that? Here we even indicate the specific surnames of our experts in our center. We even included the roles and the role additional members, hepatologists, anesthesiologists, cardiologists, and other specialists. I will not dwell on that. To what extent it's important to follow expert MDT. A lot of previous studies indicated the importance of high-quality MDT. In 2012, it was published. Radiological studies demonstrated that about 53 patients out of 100 were potentially resectable. However, these patients were didn't undergo MTD.
And also how we change the trend of the survivability based on the MDT decisions. This one is one of the interesting slides, how it is disparities, inequalities of the patients based on medical services, from how distant that patient from the expert center. This is also applied to our country since we got a large territory, and also we have to take that into account. And the next thing, that's the coherence with the regions. And we propose to give this kind of note to all the oncological centers, like we have to tell that some regions are too distant from the capital, and we are not inviting their patients to the consultant their center, and we are asking them to provide the video and also the data of the studies and the research, and also the we tell that how we see that the workflow, doctors sending the videos to our of the patient, and we provide them our contact details, and and we also explain them how they can conduct the radiological studies, and we use the Microsoft Drive or Microsoft Cloud. We got our own index where we show all the demographic data and also show the contradictions for the resection of the liver, and also classify them by A and B, and technical, and the B is oncological. These all are reflected. We do not register them, those who are going to pass the surgery on a colorectal cancer. Let me return this, and these are our long-term goals, so to have this kind of possibilities to be in this kind of index, to be there, also med survey, and by developing our index and centralize it by providing this medical service. So what kind of plans do we have? We would like to conduct the analysis of commerciality of the patient's treatment with the colorectal cancer, and also implement and also improve the medical centers. Thank you so much. I will be happy to receive your questions. Thank you, Saule. I would like to say that you are the main bridge between the Kazakhstan and the Lithuania. The Saule is the name, which means the sun, the light. And it's a great honor to me to present our great friend and one of the progressive surgeon of our country, Miram Askarevich. Miram, the floor is yours. TNT new standards of the treatment. Thank you. I would like to greet everyone for attending this conference, and welcome to our new center. I would like to ask everyone about the predictors of the TNT responder. If someone knows about it, please respond about it. So I think this strategy is well known to others. It's not a standard in our country. I would like to clarify whether it is standard procedure for the treatment. Maybe we should treat it with some sort of concern, and in some cases we have to avoid it, and also reflect the questions that related to the efficiency of the oncological and also the toxicity, and whether we can use the other types of the treatment. Starting from 2022, the advanced cancer got changed its paradigm of the metastasis with the replacement of the neoadjuvant chemotherapy and with the total neoadjuvant therapy, which stipulated usage of the chemotherapy with the irradiation. This happened because there are the retrospective studies, and the 3 significant clinical trials have established the assignation of this treatment. This could help with the metastasis advancement, and also can help that the patient was eager to take the treatment and get some biological effects. And the first data from these studies have shown that they achieved this initial results, but without waiting for the results on the survival rates. And this type of treatment got into the several states standards of the United States. But in the beginning, TNT was a part or solution for the reduction of the remote metastasis. For nowadays, we have several types of the trials, which are the rapid trial, priority trial, and the OPERA trial. Rapid trial is a irradiation or radiation therapy. So the comparative group was the group who were taking the chemotherapy, and also they proposed intensified induction of the irradiation. And the most ideal trial, in my opinion, is the OPERA trial, where they had an option which one wait when the tumor got disappeared from the colon, and they were proposed to take another strategy. I would like to ask, is that strategy is considered the over-treated, but they haven't shown the difference with the historical group, and there are some statistical increase of this data, but it is known that whether they have received this increase by the passing of the excessive toxicity from this treatment. However, there is a meta-analysis and review which says that these three TNT protocols advance the total therapy. I would like to make it clear as a morphologist when I'm studying the substance and drug. These patients passed a very successful treatment, and they all underwent the surgery. All of them had the optimum post-surgery results, and this review says that this data recognize or shows that the assignation of the TNT. However, the main question is how this protocol is universal, and can everyone assign it to others? And there are two groups of the patients who responded to the survey, and there are the 30-40% of the patients and who were able to preserve their organs, and also 67% non-responders. They didn't wait for the results, and it's unclear to conduct such a long treatment and whether there is efficiency. So they are in the group where they get extra treatment. They could have taken the surgery and couldn't get the better oncological results. And today's my presentation will be about there is a dilemma between those who took this treatment and what kind of results can be seen in future, and can we provide the personal treatment to the patients, and what kind of results did we get for the who didn't respond to the neoadjuvant therapy. And overall survival got decreased, and they got a bad recurrent survivability. And so therefore there are several questions. I think they are critical, and when we're ask ourselves whether the TNT is worse than the chemotherapy, I think we need additional studies. There are no studies which will benchmark them. However, there is a predictional scales with which we can select these patients, but they do not include the T invasion, the muscular invasion, and the lymph nodes, and the size of the tumors and their location in the colon. As a surgeon, I always was concerned about the total therapy. This is a long therapy. Being a surgeon, my therapy will be much complicated. Either that would be conducted on week 8 or 9, and here's a review which shows that there are no statistical difference in a circular part of the resection. There are no difference in how that was radical, and their complication risks are the same, and that the frequency is the same. And these studies have shown that the higher the risks of the principles of the total treatment, and the higher the risks of this procedure for those who had the TNT rather than usual. Separately, I would like to tell about the phenomenon like address. This phenomenon says that the patients who took the total neoadjuvant therapy in the studies of the rapid, this phenomenon was studied. It showed that the patients who received at the development of the metastasis versus to the group who didn't receive the TNT, they were living 8 months shorter. There are no posted data where we were comparing the overall. What's the address mechanism? This is where when the patient take the neoadjuvant therapy, we hope that the micrometastasis will be destroyed. And if this effect didn't happen, then we can increase that by adding the new adjuvant chemotherapy for the chemoresistivity of the tumor. Once the chemotherapy is finished, the tumor may be more aggressive, that the chemotherapy for the newly appeared metastasis may be less effective. So the rescue therapy will be less efficient for those who already passed the chemotherapy. And oxaliplatin in a new therapy may restrict its during the treatment, during the return of the tumor. So during the trial of the Rapido, we can observe that there was an 8% decrease of the frequency of the distant metastasis after the TNT. And the patients had more neurotoxicity, and they had a higher grade of the acute toxicity. The duration of their treatment was longer, 19 weeks instead of 6 weeks. And during the rapid trial, the negative part was these patients had a local recurrence, and there is an expert's opinion which is related to the poor quality of the surgery. This address phenomenon can be explained with the mismatch of the and the lack of the total survival after the TNT. There are insufficient data to say that the TNT is a standard way of treatment and use them as is due to the extreme risk of treatment. We have to strive to avoid that better way of treatment and search for the better candidates or appropriate candidates for the TNT, so we could make it more precision and use the special biomarkers for that. If we're talking about the watch and wait, where the tumor gets disappear, we can propose to the patient not to pass the surgery. And we still got issues with the safety here. We need to select the relevant patient for the scheduled strategy to get the response. Otherwise, the patient would have to get the additional treatment, and we need to study the biomarkers here. Another thing about the study called the Prospect, it is just chemotherapy without the radiation therapy, which had also the oncological result without the irradiation. It says that sometimes we can, with escalation of the treatment, we can get the same data from the oncological, from the resistivity survival. So it is all included in the protocol. We can use that if the tumor is decreased by 20%. If we are talking about the role of the precision medicine, the forecasting of response for the treatment plays a role. So it helps to avoid unnecessary chemical therapy. Identification of the patient with the chemical therapy will not be beneficial, and helps him to avoid the side effects. And so we can propose him an alternative treatment, and also know his oncological profile. And also, for the present, we are discussing artificial intelligence, and for they can forecast the results of the treatment to the patient with the colon rectal cancer, and this data like a TRG. That way, being critical to this kind of treatment, we have to follow the golden standards. So the TNT is related to the with pathological consequences, but it still require the precision approaches. Since it can be universal approach to all the patients, we don't have the data on the survival rate increase, and the individual approach will be based on a precision medicine by combination of the artificial intelligence and certain tools. I would like to show one case. This is the female, 49 years old, with adenocarcinoma with a metastasis in the pelvic lateral lymph nodes. And in all MDTs that took place in Kazakhstan, they could have proposed the standard course of the chemical and the radiation therapy. So after that, she could pass the surgery. There is also opinion, and this opinion belonged to the lawyer. But today, if we knew that the lawyer says that if the patient could have taken the chemotherapy and the irradiation, that way he could have avoided the surgery and preserved his organ. That way we have to tell him that ahead of time. Now we try to tell to our patients that saying that it's not a standard of the treatment. Here we proposed him. Here you can see the tumor on the ampular part of the organ. And we can see that the lymph nodes, problems with the video. Okay, we suggested the patient the total neoadjuvant therapy with the chemical therapy. She received the radiotherapy in Turkey and the chemical therapy in Astana in a private clinic. After 8 weeks, she received the full response, and now she's being monitored by the watch and wait. After our MDT, this is the MRI, which was done after 28 weeks. This is how it looks in the form of the black scar. There are two compared images. Now we are looking for the common sense, and this patients can take the watch and wait strategy. So the common sense is that either we can improve the oncological result or quality of life, and this protocol for us is one of the justified way of treatment. We have a prospective evaluation in our center. We would like to collect the patients and pass them through this protocol with the consolidating therapy, and we also selected some points on the preservation of the organ and the survival rate. And also we would like to try to determine those people who can show better results and additional data which could be the predictors for this. And also we got an idea on evaluation of these patients in the middle of the treatment we will conduct during using the MRI. So overall we need more studies where we can compare the patients after the CRT to compare with the non-responders. We need more data so our medical base could be more precise in terms of the long-term results, so that since we don't know that the indicators of the total survivability, we need the data like machine learning and also artificial intelligence. I think I managed the time here. I would like to present that at 4 p.m. we got a lecture from the person who doesn't ask that question. He determines this strategy. That's the Julio Garcia Aguilar. He is the chief scholar, scientist in preservation of the organ preservation in the colon cancer. There is a consolidated therapy and induction therapy, and with the patients that he can monitor. With a great honor, I would like to tell that we will have an opportunity to listen to his lecture on the TNT during the colon cancer. Thank you.
Thank you very much, Miram. We have 5 more minutes for a Q&A session, and after that I'm going to kindly ask my colleague to say concluding words before we'll proceed to the next speaker. Okay, questions, remarks, comments, please, colleagues. Yes, and those who are really interested in the presentation of Professor Garcia Aguilar, please take headsets so you can listen interpretation, simultaneous interpretation from English to Russian if you do not speak English. For what patients it's relevant to consider watching week and for whom it's less relevant? Thank you very much for your question. For us, if we focus on the study that we're going to conduct, and if you want to repeat the experience of open trial, we believe that it's a brilliant exemplary study. And in their study, when there is a 70% of all the patients were provided with full medical response, these are patients in the lower ampular section, the 3 and 0 and or and plus. So we will sample patients for whom it's possible, so the patients with up to 6 millimeter tumor with local advanced tokens. Speaking about retrospective data, we believe that we'll sample TFO tumor patients with lymphomuscular tumor with a lot of nodes and low tumor volumes. Okay, thank you very much. Colleagues, I have two short questions. The first is addressed to Murat. Murat, you mentioned about the cooperation of radiologists and oncologists. I believe that a very good surgeon should spend a lot of time in radiology department. How do you think? Does it work vice versa? Should a radiologist go to surgery department? Thank you very much, Professor Antanas. I believe that it should be mutual desire. That's why in our practice we very often visit colorectal surgeries to understand the anatomy first of all, and to understand the typical mistakes that we did in a certain case. Our surgeons before the surgery, they often visit us and we work jointly. Already visit you? Yes, they already visit us. Good. Yes, please. Then, taking this opportunity, I will ask one more question. In the diagnosis and when deciding the strategy to cure rectal cancer, MRI is one of the key directions, and you demonstrated the specific figures. You analyzed, as far as I remember, in N category 55% specificity, right? If I'm not mistaken. On M category, yes. In some categories it's plus minus, not 60-70%. I believe that it's a huge problem. Sometimes we over-treat our patients. That's why I would like to know, taking into account the cooperation of surgeons, pathologists, radiologists, probably we should add cooperation of diagnostics, pathologists and other experts. So the question is, how often do you conduct analysis? In accordance to your figures, it's quite low, 7-10 patients, right? Do you have a specific established system of an analysis of your results, of your studies, MRA plus, but practically? Yeah, I got you, okay. There was a comparison when there was a small sample, but we already started to do that. Sometimes, as I mentioned in my slides, it's difficult to estimate T2 with the edema T3A. Sometimes we overestimate results of MRI. There are also lymphomes less than 3 millimeters, and unfortunately they are not visible in MRI, but pathologists see them very good. That's why our figures are very different. We work on that. Now, in retrospective, we already started to consider it, and we are guests to other departments. We take into account their expertise, and we try to figure what notes there is a lesion in some notes, and we try to identify our figures. Yes, the sample is small, as I mentioned. There are a lot of room for improvement, but jointly we try to do that. Thank you. May I add, please, to the answer of Mr. Murat? Yes, we compare their results with the morphologist's report, and the figures that were mentioned, these are those figures that we received, and we always work on further improvement. Based on unpublished data, the MRI exact precision is only 50%. So small portion of patients will be overtreated, but we might apply other strategies for these patients. Boss, comment and question. Just 2 weeks, 2 minutes left. I want just to add, in terms of morphology, Murat Abdurkhanovich and me, we provided a comparison, real-time comparison. We took a sample, we cut it, and then we analyzed the lymphoma nodes, compared their the results with the results of MRI. So I believe it's a very valuable experience to clarify MRI diagnosis. And I have a very short question, please. You mentioned micro preparation. The leading pathologists, pathomorphologists, Caroline Verbeek and other experts, they say about the pancreas medications, and they try to color them using different colors, and they do it themselves. There might be even 7 different colors. So what's your opinion? Who should done that, surgeon or you? In the context of colorectal cancer, here I believe that it's enough to color only from our side, because it's pancreas pathology, and take into account its pathological features. There is a lack of certain capsule. That's why we color them, and we can certainly see the microscopic structure. So pictures and the high quality coloring on the fresh material is enough for high quality study. Thank you. Thank you very much. Now, distinguished colleagues, I believe this section was very useful and interesting. We answered questions. We talk about the diagnosis, pathomorphological diagnosis, and the strategies for the future for metastatic treatment. Treatment of metastatic cancer, and the further perspectives of colorectal surgery, radiology, and chemotherapy. I believe this session was successful. Thank you very much, all the participants, all the speakers. Now 5 minutes break, and after the break we will proceed. Distinguished speakers, please, let's make a group photo.
Через примерно 5 минут, даже 3 минуты начнется лекция.
In 5 minutes we are going to start the next session, next lecture in online format.
Коллеги, я прошу занять свои места, потому что у нас уже на связи не...
Please take your seats because we already have our online participants, highly respected, famous professor allocated his precious time to visit our conference in online format. So please, distinguished participants, take your seat. We are about to start.
Dear colleagues, dear ladies and gentlemen, let us introduce our next speaker, one of the most distinguished figures in the field of colorectal surgery, Dr. Julio Garcia Aguilar, who joins us online today from New York City. Dr. Garcia Aguilar is the colorectal surgeon currently serving as the chief of colorectal service in the Department of Surgery at Memorial Sloan Kettering Cancer Center. He's also the pioneer and the primary investigator in OPERA trial, as our speaker, Dr. Miriam Mamlin, already mentioned. This trial is a groundbreaking randomized clinical trial that has redefined the management of locally advanced rectal cancer and demonstrated that organ preservation is achievable in rectal cancer patients after total neoadjuvant therapy treatment. So, dear Dr. Garcia Aguilar, it is an honor and the greatest privilege for us to have you today. We'd like to extend our deepest gratitude for sharing not only your valuable time with us today, but also your profound knowledge and experience. Please welcome, and the stage is yours. Thank you.
Thank you so much for your kind presentation. I'm sorry I cannot be there in person. It's a beautiful country, and I hope to have the opportunity to visit. I want to thank Dr. Manlin for the invitation. I don't know if you are seeing my slides correctly. Let me see if I can put it in presentation mode.
Yes, yes, we can see it.
Okay, can you see that well now?
Not fully, but yeah, we can see the main page.
Let me just see how I can do the... I see... but the presentation, let me just...
Maybe you can you press F5? Do you have something?
Which one, F?
F5. Yeah? Hopefully it works. No?
Can you see the move now?
No, no, no. Still.
Let me just... okay, why is that not being seen? Can I close it and open it again, maybe?
Sorry?
Can you see, I think I can see my slides on the screen. Can you?
No, we see it like it's still rolling. We have some sidebar on the side, yeah. But it's not on the presentation mode, unfortunately.
Oh, let me just try to open it again, okay?
Okay, yeah, no problem.
Sorry. Oh. Can you see my slides now?
Unfortunately, yeah. Now it works. Yeah.
Okay, let me just then. Okay. So can you see now perfectly the slide?
Yes, yes.
Okay. So well, again, thank you for inviting me to participate in this meeting. I can see from the previous presentation that you have already talked about total neoadjuvant therapy. So I'm not so sure what new information I will be able to provide, because I think it was Dr. Manlin talking about all these trials. So what I will try to cover in my presentation today is, a number of topics. We're going to talk about total neoadjuvant therapy. We're going to talk about organ preservation. We are going to talk about neoadjuvant systemic therapy alone in rectal cancer. We are covering the PROSPECT trial. And also briefly, we're going to talk about immune checkpoint blockade as the only treatment for MMR deficient rectal cancer. So I will start by saying that for many years, the standard treatment of rectal cancer consisted on chemoradiation, total mesorectal excision, and postoperative adjuvant chemotherapy. This was established by a number of trials that they were conducted in the 90s and 2000s. And that treatment was very good in providing local tumor control. The problem is that with this treatment, there was significant morbidity, organ dysfunction, particularly low anterior resection syndrome, and impairment of the quality of life of the patient. The patient had many problems after treatment. Another problem that persisted was the issue of distal metastasis, which at the end of the day was what killed patients. As surgeons, we were very concerned about local recurrence, but most patients with rectal cancer still die from distal metastasis. So this treatment has significant gaps. The remaining challenges with that treatment was to improve the quality of life and the survival, improving the quality of life by eliminating potentially unnecessary interventions, and improving the survival by reducing the risk of distal metastasis. So, one of the issues to reduce the risk of distal metastasis was to increase the compliance with the chemotherapy regimens, because patients didn't tolerate very well chemotherapy after chemoradiation and surgery. So these were the remaining challenges that we faced a decade ago. And, that's the reason why we address these with new trials and new approaches to rectal cancer. So of the three components of the treatment of rectal cancer, the chemoradiation, the TME surgery, and chemotherapy was the most controversial. There were no prospective, well-powered trials comparing chemotherapy with no chemotherapy in rectal cancer patients treated with chemoradiation and total mesorectal excision. What we did was extrapolate the results of clinical trials in colon cancer to rectal cancer. So sort of we say, if chemotherapy in the adjuvant setting works in colon cancer, it must work also in rectal cancer. So that was the main argument that we used. But kind of full analysis of a number of clinical trials, this study was conducted by a group in the Netherlands, questioned the value of systemic chemotherapy in patients with locally advanced rectal cancer who had already received chemotherapy and radiation. So this full analysis failed to show a survival advantage with chemotherapy after chemoradiation and total mesorectal excision. That's the reason why in Europe, surgeons and medical oncologists were reluctant to use postoperative adjuvant chemotherapy in these patients. So the response to this problem was to address the issue of giving the chemotherapy before doing the surgery. As I mentioned before, compliance with systemic chemotherapy was very low in the adjuvant setting. Only half of the patients got the systemic chemotherapy. So because they were tired after the surgery, they had morbidity from the surgery, so they were not candidates for the chemotherapy. So the thought was, why not giving the chemotherapy before the surgery in the neoadjuvant setting? That probably will increase the compliance with the treatment and increase the efficacy by giving the chemotherapy upfront. So the hypothetical benefits of giving the chemotherapy in the neoadjuvant setting will be increasing the treatment compliance, and that way make it more effective. Treat the micrometastasis early on, because if you give chemotherapy after surgery, patients had already started treatment 4 months before. So if you give the chemotherapy first, you will be addressing the micrometastasis early on. Again, micrometastasis is probably the main cause of death in patients with rectal cancer. There is also the added benefit of enhancing the response of the primary tumor and reducing the time of having the ileostomy, okay? So, when we look at chemotherapy, there are two potential ways of delivering the neoadjuvant chemotherapy. You can do chemotherapy first and then give the radiation and the surgery, or you can do the chemoradiation first, then do the chemotherapy, and finally the surgery. And I think the medical oncologists are the ones who push the idea of chemotherapy first, with the idea of treating the micrometastasis earlier and also improve the symptoms of patients with very advanced disease. We surgeons were more in the idea of increasing the tumor response and starting with chemoradiation first and then chemotherapy. As I mentioned, the medical oncologists were interested in starting with chemotherapy, and a decade and a half ago, they conducted a number of phase 2 trials that they started with 2 to 4 cycles of chemotherapy, depending on the size of the study, and then do the chemoradiation and the surgery. What they showed was a slightly increase in the rate of response. Of course, there were no improvement in survival because these were small phase 2 trials, but they proved the concept that giving chemotherapy upfront was feasible. And one thing that they learned from this experience was that patients had a significant improvement in symptoms control with giving chemotherapy early on. So they justified it that way. Let me just... So at MSK, at our institution, we conducted a retrospective review of our experience with the neoadjuvant chemotherapy in patients with locally advanced rectal cancer. We gave the patients 4 months of FOLFOX or KPOX, followed by chemoradiation and surgery. And what we found was that the compliance with the chemotherapy was excellent. Almost 96% of the patients were able to get the full dose of chemotherapy. 90% got the full dose of oxaliplatin. The response rate was higher than when we use chemoradiation, surgery, and adjuvant chemotherapy. And of course, we shortened the days that the patient had to have the ileostomy. So these were very promising, but this was not a prospective randomized study. What we found, though, was that even though compliance improved significantly, there was not a big difference in terms of disease-free survival or overall survival, which was a little bit of a surprise. Because again, the idea of giving chemotherapy before chemoradiation and before surgery was to increase compliance. That kind of didn't come to some degree as a surprise, or shouldn't have come, because a small clinical trial conducted in Spain comparing the same thing that we did at MSK, chemoradiation, TME, and adjuvant chemotherapy with chemotherapy, chemoradiation, and surgery showed no difference in survival. I must say that it was a small study, probably unpowered to show differences in survival, but they were very significant that the survival curves overlap completely. I think you have mentioned the Beach 23 trial. This trial did not compare what we will consider total neoadjuvant therapy with the standard treatment, because in the PRODIS trial, patients received chemotherapy before chemoradiation and surgery and after. And in addition to that, the experimental arm include also irinotecan. So this was not a real head-to-head comparison. What this trial showed was that the response rate were higher with the combined treatment of chemotherapy before and after, plus irinotecan, and there was some difference in disease-free survival and potentially even in overall survival. But I think it's important to see that the survival curves separate very early on, and not throughout the course of the follow-up, as you will expect, if the effect was done mostly to the difference in chemotherapy. When you look at the events that influence the separation of the curves, there were a number of surgical deaths in the standard arm that they were not in the experimental arm. So it's very difficult to interpret really whether this difference in the survival curves in the PRODIGE 23 trial were in reality due to the effect of chemotherapy on metastases or some other factor that might have separated the curves very early on. So, a further analysis of this data using cancer-specific survival in the intention to treat analysis still show the difference, but what you can see is that the separation of the curve occurs almost during treatment rather than during follow-up, where you normally see separations of the curve later on, where the number of metastatic events decrease in one group versus the other. So I think the results of this trial will need to be replicated in other ones. What is clear is that the addition of more chemotherapy to the treatment arm results in greater toxicity. I think Dr. Manlin was asking before whether this total neoadjuvant therapy represents over-treatment, and I think that's a very good question that probably there is some degree of truth about that. So I think it's something to keep in mind. So what the evidence shows in induction chemotherapy and chemoradiation before surgery is that the chemotherapy upfront improves treatment compliance. The treatment is easier to tolerate for the patient, increases the rate of tumor response compared to chemoradiation alone, probably reduces the risk of distant metastasis, but that is when you use a sandwich of chemo before and chemo after, plus you also add irinotecan. I would say that probably for now, we should be a little bit skeptical about the effect of this treatment in overall survival. Now, what about the other alternative, which is chemoradiation first? You probably heard about this trial that we conducted a number of years ago. The idea here was to give chemotherapy after chemoradiation and before surgery with the goal of lengthening the interval from chemoradiation to TME surgery and letting the tumor more time for response. And you see the results in here. When we use chemoradiation and 6 cycles of FOLFOX before TME, the rate of
Excuse me,
response...
Dr. Aguilar? I'm very sorry. Could you please change the slides? It looks like the slides are not changing.
Oh, really?
Yes, because we gave you like opportunity to change the slides yourself.
Oh, okay, sorry. So have you been able to follow me so far?
Yes, so now we see that you are changing the slides.
Okay, sorry, I don't know what changed. Okay. Can you see now?
Yes, so they're changing now.
Okay, so I was talking about chemoradiation and followed by consolidation chemotherapy with a rate of response of 38 in patients treated with chemoradiation, 6 cycles of FOLFOX, then followed by TME. So similar to our study with conventional chemoradiation, a number of groups have used short-course radiation followed by consolidation chemotherapy versus the standard. They also show increase in the rate of response in the group receiving the short-course radiation and chemotherapy, but not significant difference in survival. This is the group from Dr. Bukko in Poland. Another group in China did the same approach as Dr. Bukko, short-course radiation chemotherapy, greater response, but no difference in survival. So this approach of radiation and consolidation chemo was also followed by the Rapido trial. This is very similar design to Dr. Bukko's trial and the Chinese trial. They compare the conventional treatment, chemoradiation, surgery, and postoperative adjuvant chemotherapy with a total neoadjuvant therapy approach, short-course radiation, 5 days of radiation, followed by K-POX or FOLFOX before surgery. Similar to the other studies, the response rate was up because of the length of the treatment compared to the standard practice. It's important to emphasize that in the standard group, only half of the patients received chemotherapy. So there was a very significant difference in the amount of chemotherapy in one arm versus the other. And what they showed was a better disease-related treatment failure in the experimental arm, but no change in overall survival. And you have to notice also, similar to what I was talking about, the PRODIGE 23, and this is something that we observe in these clinical trials, is that it was the main difference between groups occurred very early on, almost before the patient had the opportunity to complete the treatment. After that, the survival curves for disease-related treatment failure ran very parallel. So we don't know why that thing happened, but that doesn't impact overall survival. Again, toxicity higher when you use total neoadjuvant therapy because the patient received twice as much chemotherapy in the experimental arm. And I think there is something that we have learned from the analysis of the patterns of local regional failure and distant metastases in the Rapido trial. Surprisingly, the local recurrent rate was higher in the experimental arm. We don't know if that was because of the short-course radiation is not as effective as the long-course radiation, but there is some difference in local recurrence. The survival after local regional recurrence is similar in both groups. The rate of distant metastasis was higher in the standard arm, so the experimental arm was a little bit better, but survival after distant metastasis was short in the experimental arm, which is surprising. So that's the reason why probably the difference in overall survival disappeared, because once the patient developed distant metastasis, patients in the experimental arm, they live shorter. And that probably has to do with the fact that those patients have already received a lot of chemotherapy before the chemoradiation and the surgery. So at the end of the day, there were no difference in overall survival. So what we have learned from the Rapido trial, which is probably the largest trial on consolidation chemotherapy, is that there is a greater response in the experimental arm, but also greater recurrent rate. And also it might be some difference in the development of distant metastases. The survival is worse once the patients develop metastasis in the experimental arm. This is something that has been called a trace phenomenon. So maybe we select more aggressive cells by starting with chemotherapy so early. So I think this is something that we need to keep in mind, that neoadjuvant therapy, total neoadjuvant therapy increases the rate of response, but the effect in survival is still debatable. So the group in Germany, they have done a study comparing both induction chemotherapy and chemoradiation with chemoradiation and then consolidation chemotherapy. They show that the response rate was higher for the group that started with chemoradiation, followed by consolidation chemotherapy, compared to the other arm, but the survival was the same. In our institution, it has been mentioned before, we conducted phase 2 trial. We wanted to test the hypothesis that introducing watch and wait in the context of total neoadjuvant therapy will lead to organ preservation in a significant number of patients without affecting survival. So introducing watch and wait won't have any negative effect in terms of survival, but it will save the rectum in some patients. So because of the difficulty with a randomization between surgery or no surgery, we had to use historical control. And what we did also was introduce a randomization. We wanted to see which one of these two arms, chemoradiation first versus chemotherapy first, will have a greater impact on organ preservation. So in these studies, we use, again, the total neoadjuvant therapy, one type or another, and then we waited approximately 8 weeks. We restaged the tumor. Patients who had incomplete response, the tumor was still in the rectum, we did TME. The patient who had the tumor gone or almost gone, we offered the opportunity to do watch and wait. Again, important that we waited approximately 8 weeks from the end of TNT, and this was the design. Incomplete response, surgery, complete or near complete response, watch and wait. The chemotherapy that we used was 4 months of K-POX and FOLFOX in both arms. In one case, that was the first part of the treatment. In another patient, they were the second part. Radiation, also very standard, with sensitizing chemotherapy during the radiation that we gave for 25 days. We developed a regression schema because this was a multi-institutional study, and all the surgeons participating had to agree what patient will be offered watch and wait. And this gives you an idea. Patient with a clinical complete response had a complete signs of the tumor gone away by endoscopy and radiology, MRI, on T2W sequences and DWI. Patient with near complete response, they were allowed to have a small superficial area that we thought that was still healing, and again that had some characteristics on TW sequences and DWI. All these things is published already, and of course when they were residual tumor they were called incomplete response. Very important in the watch and wait is a close surveillance of the patient. You have to see the patients often because otherwise they can come out with regrowth and then be in big trouble. So we see the patients at the beginning at least 3 times a year, sometimes more in patients with near complete response. We see them with endoscopy, we see them with MRI. We need to do also CT scans because these patients are at risk of distant metastasis. And we follow them for a minimum of 5 years. Even after 5 years, we like to see these patients in our clinic once a year because we don't know if tumor can come back beyond the 5-year mark. And these were the patients in our study. We have more than 300 patients. These were patients, most of them had positive lymph nodes, and they were very distal tumors. Of course, organ preservation is useful for patients who normally will require an APR or a coloanal anastomosis. I don't think it's necessary to do organ preservation for tumors in the upper rectum that they are 8, 10, 12 centimeters from the anal verge. As I say, this is a treatment that is more beneficial to patients with distal rectal cancer. So when we finish the treatment, at the end of the TNT, 6 to 8 weeks later, we examined the rectum and we found that 76% of the patients were put in observations in watch and wait. And then what happened during follow-up is that some of them developed tumor regrowth. The tumor came back again in the bowel wall. Now the premise is that we can always do the same surgery that we would have done at baseline if the tumor shows up. We found differences. Patients who had radiation first were less likely to have tumor regrowth compared to patients who had chemotherapy first. At the end of the day, more than half of the patients treated with radiation and chemotherapy preserved the rectum compared to those that started with chemotherapy and then chemoradiation. So there was a difference in organ preservation that was similar to what Dr. Focas and the German groups had found when they compared the induction chemotherapy, consolidation chemotherapy in patients that they all had total mesorectal excision. So this was not surprising because this confirms that chemoradiation first seems to lead to a little bit greater probability of organ preservation. What we found, and it was similar to what Dr. Focas found, it was that disease-free survival and overall survival was the same for both groups. Induction chemotherapy, consolidation, they both had the same effect in metastasis and overall survival. Local recurrence, no difference also. So it sounds like the main benefit is organ preservation rather than any impact in survival. Now, again, our was a study, phase 2, compared with kind of other trials and historical controls. Both arms, at the beginning, the DFS at 3 years was 76%. It's a little bit lower at 5 years because metastases continue to occur, but it was not different compared to other studies. Now, very recently, we had the opportunity to compare head-to-head our results with the results of the German trial, the AIO 12 trial, because similar to ours, they have 2 groups, one with induction, one with consolidation. In their study, all patients had TME. In our study, half of the patients had TME, half of the patients had watch and wait. As you can see, the disease-free survival and the overall survival were the same in both trials, suggesting that what you do with the primary tumor, just doing watch and wait for patients with a clinical complete response doesn't impact survival that much. Half of the patients preserve the rectum, but survival is the same. Now, as I mentioned, there are some patients that require surgery early on because they had incomplete response. Some patients had surgery later on. Here we have the patients that they have surgery. There were some patients that they had transanal excision, which was a protocol violation, but we counted those patients in terms of organ preservation as having TME. But still, we have some cases that they have a pathological complete response, even though we did watch and wait in many patients. When we took the patients to the operating room, there were still some patients that, thinking that they have cancer cell, went to the operating room, but then they didn't. We compare then also the survival of patients who had surgery upfront with patients that had surgery during follow-up because they developed tumor regrowth. Those, the survival for those two groups is very similar. So even though the groups are not maybe exactly the same, because the patient who had surgery upfront, they have less of a response than the one that they had surgery later, but give us a little bit of a peace of mind that maybe the regrowth, it doesn't impact survival that much compared to having surgery upfront. What we found, and this is a very important concept that is sometimes difficult to grasp, in our trial, only half of the patients had TME surgery. So the patient who got the best response, they never had surgery. So the surgery is concentrated in a group of patients that probably they are more aggressive because they did not respond to chemotherapy. So you have to expect that if you do watch and wait and eliminate the good tumors, and you just do surgery in the bad tumors, your outcomes are not going to be as good as if you do surgery in the entire group. When you look at the entire group, the results are the same that in the German study, but in the group of patients who got surgery, results are not as good, both in terms of local recurrence and distal metastasis. So to some degree, with the watch and wait, we select for surgery bad biology, because the good biology, they never require surgery. So this is an important concept to keep in mind, okay? One of the things that we look at in the trial was, remember at the beginning, we had 3 different type of response. The incomplete responders, the more aggressive, we recommend TME. And then we have the complete, near complete response, which is the one that we recommended watch and wait. What we found was that if you have a complete response, the probability of regrowth is less, and the probability of preserving the rectum is higher. For patients with a perfect response, the probability of achieving long-term organ preservation that we measure as, TME-free survival is over 75%. If you have a near complete response, the probability of preserving the organ is going to be around 50%, maybe a little less, because some of them they're going to have regrowth during follow-up. So that is important to keep in mind. What we also found is that the response, the clinical response, 6 or 8 weeks after completion of the neoadjuvant therapy, has important prognostic implications. The patient who had the complete response, the one that they have less surgery, they did the best in terms of DFS. The near complete responders, they did intermediate. And the incomplete responders, all of them had surgery, are the one that they do the worst, because we are selecting bad biology to take those patients to the operating room, and that's an important concept to understand. That shouldn't be surprising, because when we stratify tumor response in patients who had TME by pathology, whether the T stage or the tumor regression grade, we can also stratify outcomes between the pathological complete response, intermediate response, and worse pathological response. So what we see in pathology after TME, we see with clinical response before TME, and that's important, because that's what allows us to decide, for example, de-escalate and not do surgery in the best responders, or potentially intensify the treatment in the one that they have incomplete response and they do the worst. And when we compare the results with the German trial, the AIO 12, again, in this trial, all of them had surgery. We can compare clinical response with pathological response. For good responders, intermediate responders, and poor responders, the survival curves are very similar, suggesting that clinical response is a very important prognostic marker in patients with rectal cancer treated with total neoadjuvant therapy. So what have we learned from the OPRA trial? What we have learned is that the rate of response is higher than anticipated if you give the patients some time for the tumor to respond. If you put patients in watch and wait, you are going to have some tumor regrowths. That's the reason why this patient needs to follow very closely. You cannot do watch and wait in somebody who is not going to be compliant with the surveillance protocol. Salvage TME for patients who develop regrowth is feasible and effective, again, as long as the patients come to the appointments and they are seen regularly. Half of the patients can preserve the rectum. Half of the patients with the stage 2 or stage 3 with total neoadjuvant therapy can preserve the rectum. Giving the radiation before the chemotherapy seems to be better than giving the chemotherapy and then the radiation, but both groups, they have a significant proportion of organ preservation. And again, survival seems to be equivalent in treatment protocols that incorporate watch and wait versus the one that mandate TME for every patient. But I think we have to keep in mind that there is more than organ preservation. Organ preservation cannot be the only goal of the treatment of patients with rectal cancer. There are other goals. Some patients are very symptomatic when they come, and we have to give them symptom relief. We have to take into consideration the effect of chemoradiation, particularly in young females in years of childbearing age when they want to have families. We also have to keep in mind the toxicity of the chemotherapy, particularly the neurotoxicity. So there are a number of issues that we need to take into consideration when selecting the treatment for the patient. Not every patient is the same. One of the issues in rectal cancer is, well, we use radiation, and with the combination of radiation and chemo, we can achieve organ preservation. But do we need radiation in every patient? And this question has been addressed in a number of clinical trials. One of the early on, was the forward trial. It was done in China. Compared, they had 3 arms, 2 of them with chemoradiation and chemo, only with chemo alone. Again, the rate of response was higher when you use the radiation with the chemo, lower when you had the chemo alone, but survival was the same. So somebody can argue that for a tumor that is in the mid or upper rectum, when preserving the rectum is not as important, you might just go with systemic chemotherapy. This same question was also addressed by the Prospect trial. It was the leading investigator was Dr. Schrack, who is here also at MSK. And in this case, they were tumor intermediate stage, and they were located higher up in the rectum. These were average distance from the anal verge was 8 centimeters. You have the tumor characteristics here. Only 50% had, 60% had positive nodes, and the distance from the anal verge was 8 centimeters. Much higher than the tumors in the OPERA trial that they were in the upper rectum. But this trial showed very good results with both chemotherapy or chemoradiation. So for tumors in the upper rectum, probably chemotherapy is all they need. You can avoid the side effects of the chemoradiation in those patients with the expectation that the result will be the same. And that's also, in this case, true for the disease-free survival and for overall survival. It was a non-inferiority trial that was positive in the sense that the treatment in both arms was similar. The local recurrent, it was excellent. There was absolutely no difference, and the local recurrent was less than 3% in both arms, which is outstanding. So, some author has questioned, well, did this patient need any chemotherapy or any chemoradiation at all? And I think that is a valid question, and I think that probably is a study that will need to be done in the future. For this tumor with these characteristics and this location, do we need any treatment other than surgery? And probably not, but I think that needs to be studied. Adverse events, the more chemo you use, the more side effects you're going to have. We know that. So we have to be mindful. As I say, tumors of these characteristics in this location, if you do surgery alone and decide the chemo based on pathology, you might save a lot of chemotherapy to some of the patients that might get unnecessary. So this is something to keep into consideration. And again, this is something that probably will be studied in the next few years. So I'm going to show you a case. A patient of mine, 21-year-old. We see rectal cancer in younger and younger patients. This patient, had an adenocarcinoma located in the lower rectum. And the question was, how do we treat this patient? We elected to do 4 cycles of FOLFOX. We check the tumor response. It's very good. We give another 4 cycles of FOLFOX. The tumor seems to be completely gone. in this patient, radiation will affect her fertility forever. So we elected not to do radiation, but we are not used to do watch and wait with chemotherapy alone. So we took the patients to the operating room. The final pathology was YPT2N0. The patient did fine. She's now more than 6 years from the time of the surgery. Her bowel function is excellent, and she's having a perfect life. So that's the reason why I say organ preservation might not be for everyone. You have to take into consideration the characteristics of the tumor, the location, the size, the stage, whether the tumor has, extramural vascular invasion, and of course the molecular profile. You also have to take into consideration the age of the patient, gender, whether the patient has other comorbidities, and also the wishes or desires of the patient. Some patients have a very strong opinion against surgery. Some other patients have a very strong opinion against radiation. So this is something that needs to be taken into consideration. Now, a few words about the MSI tumors, the MMR deficient. In the past, we treated all the rectal cancer the same. This landmark study conducted at our institution, based on the experience that we had with metastatic disease a few years ago, we decided to treat patients with MSI tumors, MMR deficients, with immune checkpoint blockade, with the idea of assessing the tumor response after 6 months of immune checkpoint blockade, and then deciding whether they needed radiation or not. To our surprising, all the patients had a complete response at the end of the immune checkpoint blockade. So none of the patients required radiation or surgery. So all of them, potentially, we can say that they are cured with the immune checkpoint blockade alone. And this is now our preferred treatment for patients who had MSI rectal cancer. I must say that the number of patients is small. It's only 4 or 5%. But these 4 or 5% of patients, they can be cured with immune checkpoint blockade, without chemotherapy, without radiation, and without surgery. Now we are looking if there is any other subset of MSS, MMR proficient rectal cancer that could potentially benefit from immune checkpoint blockade, but this is still work in progress and we don't have any data to show yet. But this has been a significant change for these patients. So nowadays, we don't start the treatment of any rectal cancer without knowing whether the MMR proteins are expressed or not. Because if the tumor is MSI or MMR deficient, we're going to give them immune checkpoint blockade rather than chemotherapy or radiation. So again, this is a very good experience. We have now treated probably 50 patients. We have observed not grade 3, 4 adverse events. None of the patients required radiation, chemotherapy, or surgery. The tumor has not recurred either locally or in the liver or in the lungs. And I think, we still need to follow this patient for a longer period of time. But we are now, some of the patients have now almost 5 years since we started the treatment. And I think now the MMR testing is essential before starting the treatment of any patient with rectal cancer. So I think in conclusion, the treatment of rectal cancer has changed significantly. Neoadjuvant therapy results in higher rate of tumor response and allows the possibility of organ preservation. It might also reduce the risk of distal metastasis. I think this is debatable. I don't think that we have conclusive evidence that they improves overall survival. There is a signal in the PRODIS 23, but that hasn't been confirmed in the other trials. So we need to, have more data in the future. There is a lot of debate. Giving total neoadjuvant therapy represents treatment escalation, and in some patients, if we don't do something beneficial to the patient, such as organ preservation, the benefit of TNT for every patient is still debatable. So I think we have to have an open mind. I think today we cannot say that there is one standard for the treatment of rectal cancer. I think there are several standards. For MSI tumor, the standard is immune checkpoint blockade. For MSS tumors, it's going to depend on the location, the stage of the tumor, and also the characteristics of the patient. Some of them, the goal should be organ preservation. In other patients, the goal should be avoiding toxicity from radiation. And again, in some other patients, like upper rectal cancer with intermediate stage, the goal might be avoid any neoadjuvant therapy to avoid the radiation, the chemotherapy effects, okay? So the treatment should be individualized based on all these characteristics and just applying our knowledge. I think probably future efforts should be focused on, similar to what happened with the MSI tumor, identified other molecular subgroups that might be treated with effective targeted or immunotherapy. So I think I'm going to leave it there. Just acknowledge all the group at MSK, surgeons, medical oncologists, radiation oncologists, radiologists, everyone who participated in our tumor board, our research fellows who collect a lot of the data and makes all these presentations possible. And of course, in my particular case, with the timing trial, with the OPERA trial, a number of investigators throughout the country in different institutions who has contributed significantly to accrue patients. And of course, thanks to our patients that they are always willing to participate in clinical trials. Thank you so much.
Thank you. Thank you, Dr. Garcia Aguilar. So we have a few questions that prepared from our audience. And the first question is the planned watch and wait strategy reasonable for patients with tumors that localize higher than 7 or 8 centimeters?
Can you repeat the question again, sorry?
Is the planned watch and wait strategy is reasonable for patients with tumors that with the localization higher than 7, 8 centimeters?
Well, as I say, the patients who benefit the most from watch and wait are patients who will require an abdominoperineal excision of the rectum or a very, very low connections, because those are being the ones that, they will have more symptoms after. I think the benefit of watch and wait is lower for tumors in the upper rectum, about 8, 9, 10 centimeters. I think that the benefit is significantly less. You might have a patient who might be a bad candidate for surgery because the patient is morbidly obese or other conditions that you might still want to attempt watch and wait for a higher tumor. But remember, only half of the patients that get TNT at the end of the day have watch and wait and organ preservation. So there is always the possibility that you will radiate the patient and with the chemotherapy and the tumor will not go away. So you have to keep that in mind. I think organ preservation is better for lower rectal cancer, where the alternative would be total mesorectal excision with a colostomy.
Okay, thank you. Another question is when it is better to stop watch and wait strategy in near complete response?
Well, I think that's a very good question. The near complete response is a concept that is a temporary situation. We knew from previous experience that the response of the tumor to radiation and chemotherapy takes a long time, and the rectum needs time to heal. So when we finish the treatment and we look at the rectum 6 weeks later, and we see that there is still a superficial ulceration, we ask the patient to come back approximately 6 weeks later. And what we want to see 6 weeks later is that superficial ulcer is healing. As long as we see improvement, we can continue with observation. If after 4 months we see that there is not healing or that the ulcer gets a little bit worse, it's time to go to the operating room. It's better to do surgery and find that there are no cancer cells that allow the tumor to grow back significantly again. Even in the OPERA trial, we had 9% of the patients that we brought to the operating room because they thought that the tumor was still there. They had no tumor left. I think that's better than waiting for too long and let the tumor grow out of control. So if you see patients with near complete response, you should see them at 6, 8 weeks, once, twice, 3 times, as long as the situation is improving. But I wouldn't go indefinitely in that situation because it can be risky.
Okay. Another question is, it's more about patient communication. So usually when you for the first time see a patient who was diagnosed with rectal cancer, how do you usually approach them, especially when talking and discussing about watch and wait strategy and all the possibilities of relapse and etc.?
Yeah, I think that's a very good point. I think, at the beginning, people were not very savvy about all these details in the treatment of rectal cancer. Most patients, at least in our institution, when they come to see us, they have read everything and they are up to date with the literature. So we kind of are forced to discuss everything. Because at the beginning, the most important decision is how to start the treatment. If we see a patient with a rectal cancer that can be a potential candidate to watch and wait, we tell them, and you know, there is not any other reason why not to do radiation first. We tell the patient, well, I think if we start with radiation and then give chemotherapy, there is, you know, there is similar survival that if you start with chemotherapy, that maybe you have a better possibility of achieving a complete response. We cannot guarantee that the tumor will respond, but with radiation and chemo, there is some possibility, or you know, and then we can offer the watch and wait. You have to tell the patient that, well, there is this possibility, but don't assure them, because we don't have a good way to predict who is going to respond and who is not. On the other hand, if you have a patient with an upper rectal cancer, you can tell them, well, you know, we have data that, you know, giving chemotherapy and potentially giving radiation might be as good, but we can give you chemotherapy and then see how the tumor responds. Because the treatment now also has to be kind of adapted to the response. We know that response is important to predict what is going to happen to the patient. So you have a patient with an upper rectal cancer that has several lymph nodes on MRI. You can decide, well, I'm going to start chemotherapy. I'm going to bring the patient back after the chemotherapy alone. I'm going to look at the rectum. If the tumor has responded very well, that patient might not need chemotherapy, and you can follow the treatment plan of the prospect trial. So you have to have a very good discussion about all these things that, you know, I was talking about with the patient, the time that you see them, and you know what the stage is, where the location of the tumor is, what are the characteristics of the patient, and also ask them. You have to ask them why. What is what they want? What is the most important thing for them? Is the most important thing avoiding a colostomy? Is the most important thing, for example, in a young female, fertility issues? I think these are all the things that you need to discuss from the beginning and just have a very honest and frank discussion. So it's something that we do, and it takes time, but I think you have to discuss with the patient, because at least in our environment, the patients are very well informed.
Yeah, as usually, patient comes first, yeah. And our last question, so what are your thoughts about the duration of chemotherapy and possibility of developing much more aggressive and resistant types of tumors?
Yeah, I think that is a very good point. You know, as you know, in colon cancer, we started using 1 year of adjuvant therapy. Then we went to 6 months. And then the IDEA trial went down to 3 months for many patients with colon cancer and adjuvant chemotherapy. In rectal cancer, we have been doing 4 months. I personally believe that that might be too much, but that's what we use in most of the trials. Now, when we compare the results of our trial, the OPRA trial, with the German AIO12, the survival rate is the same. But if you look at it, they only use 3 cycles of FOLFOX. We use 8. Okay? So I think we are using too much chemotherapy in the context of TNT. I think 3 months, like we do now in colon cancer, will be more than enough. And I think, you know, one of the main side effects that my patients have nowadays in the OPRA trial, for example, is neurotoxicity. So I think we probably need to start thinking in the future of cutting down the amount of systemic chemotherapy that we are using. Now, there is this debate between de-escalation, reduce the amount of treatment to avoid toxicity, and at the same time, escalation. Like the PRODIS 23, they added irinotecan. There is one study now in the United States comparing chemoradiation and FOLFOX versus chemoradiation and FOLFIRINOX. We don't know what is going to happen. I'm more in the idea of de-escalate rather than escalate the treatment. Because I think the effect of the chemotherapy happens very early on treatment. But I think all these things needs to be studied appropriately before we reach any definitive conclusion.
Well, thank you once again. I think it concludes the end of our Q&A session and our meeting today. We'd like to thank you once again for your presence, for your very informative presentation, and for giving us maybe new valuable perspectives on TNT, and we hope that we will be able to establish it as a standard of care here in Kazakhstan as well. And we hope and we'll be more than happy to see you one day here in person in Kazakhstan, in Astana. Yeah, thank you again.
Thank you so much. It's been a pleasure. Thank you.
Yeah, we're gonna... Oh, sorry. У нас будет кофе-брейк, да. Спасибо.
We are going to have coffee break. Thank you.
Coffee break?
Oh, no coffee, just break, okay.
Уважаемые коллеги, приглашаем вас на нашу завершающую сессию под названием «Образование в онкологии. Ключевые компоненты, компетенции и учебные программы». И для модерации данной сессии приглашаются доктор Гущин Вадим, хирург-онколог, директор программы HIPEC и отделения гастроинтестинальной онкологии Mercy Medical Center, Балтимор, штат Мэриленд, США. Доктор Алиханов Тасполаталпс Бесулу, доктор медицинских наук, профессор, главный консультант по онкологии Национального научного онкологического центра, город Астана, Казахстан. И доктора Сазонова Виталия Геннадьевича, ассистент профессора школы медицины Назарбаев университета, анестезиолог, реаниматолог, отделение детской анестезиологии, реанимации и интенсивной терапии, UMC, Астана, Казахстан. Спасибо.
Уважаемые коллеги, для нас большая честь. Вы знаете, как в фильме «17 мгновений весны», когда Штирлиц заходил с каким-то вопросом, и он говорил, запоминается всегда первая часть и последняя. И поэтому, когда мы будем сейчас говорить в последней части о чем-то, мы надеемся, что эта часть запомнится лучше всего. И для нас большая честь, что эту серию откроет доктор Вадим Гущин, хирург-онколог, клиника Mercy, Балтимор, Мэриленд, США. Добро пожаловать. Вадим, вам
Спасибо
слово.
большое. Спасибо. Меня надо слушать на эту тему по нескольким причинам. Во-первых, потому что я закончил резидентуру и fellowship по хирургической онкологии в США и работаю хирургическим онкологом уже почти без малого 20 лет. Во-вторых, я разными судьбами в последнее время много стал уделять внимание обучению и принимал участие в открытии высшей школы онкологии в России и IPSM в Казахстане. И третья причина, по которой мне можно послушать, это я приобрел недавно вторую профессию образования в медицине, закончил Masters of Education and Health Professions в институте Джонса Хопкинса. И, в общем, это, как оказалось, совсем другая профессия, чем просто быть хирургом-онкологом и учить других. Поэтому вот у меня сегодня презентация «Кто такой хирургический онколог» как раз с точки зрения образования. То есть, когда мы начинаем кого-то учить, у нас есть образ, кого мы хотим получить на выходе, правда ведь? И нет такой биологической данности, объективной реальности, как хирург-онколог. То есть Карл Линней никого не описал, что вот в лесу бегает человек, он явно хирургический онколог вот по таким-то принципам. Хирургический онколог – это конструкт. Да? Это мы наделяем его качествами, профессиональными качествами, которые должен иметь хирург-онколог, и именно к этому мы стремимся. И вот с этой точки зрения я сегодня сделаю небольшую презентацию, но я сделаю презентацию на своем примере в том числе. Итак, чтобы описать конструкт, кто такой хирургический онколог, мы используем в последнее время, с 1999 года, подход компетенции, основных компетенций. Если этот подход для вас известен, мы его применяем, например, в описании человека. У нас, когда к нам приходит человек, мы его разделяем на систему центральную нервную систему, желудочно-кишечную систему, дыхательную систему, сердечно-сосудистую систему. Правда ведь? Их не существует в природе. Это наш конструкт, и он удачный конструкт. Поэтому у нас есть пульмонологи, есть неврологи и так далее. То есть мы явно можем человека разложить на несколько систем, и при этом мы не говорим, что посмотри, пошла какая красивая центральная нервная система, правда ведь? То есть нельзя отдать приоритет одной системе сказать, что вот эта система самая главная, а другие системы не главные. Более того, невозможно понять, где одна система начинается, а другая заканчивается, где начинается сердечно-сосудистая система, а где дыхательная система. Вот именно с этой точки зрения American ACGME, American Commission of Graduate Medical Education, придумала вот этот подход системы компетенций, core competencies. И все выделила 6 таких основных компетенций. Это лечение пациентов, и для хирургов это будут операции на онкологических пациентов. Это медицинские знания. В основном это знания об онкологических процессах. Это постоянное самообучение, основанное на потребности практики. Да, я закончил fellowship 20 лет назад и думал, что ничего серьезно не изменится. Оказывается, каждый раз меняется все настолько, что ты теряешь ориентацию иногда на конференциях. Это использование ресурсов, доступных тебе, потому что медицина, например, в крупном городе и в сельской местности будет разной, доступность исследований будет разная и так далее. Профессионализм. Профессионализм – это, как мы считаем, должен вести себя хирург-онколог, и коммуникация с пациентом и коммуникация с коллегами. Ну, я думаю, что хирурги, несмотря на все мое введение, хирурги всегда скажут, что ну, самое главное, это надо уметь оперировать. И я, может быть, даже соглашусь, но отвечу вот такими вещами. Прежде всего, хирург-онколог – это общий хирург. Для меня общий хирург – это тот, который, ну, как человек, который вырос профессионально в системе американской медицины, это человек, который закончил резидентуру по хирургической онкологии, в течение 5 лет оперировал и учился оперировать на органах желудочно-кишечного тракта, живота и брюшной стенки, эндокринной системы. Проходил хирургию травмы. В мое время это еще была сосудистая хирургия и трансплантология, и обязательно интенсивная терапия. Эти все данные и характеристики общего хирурга взяты с веб-сайта American Boards of Surgeons. То есть это то, что надо сделать, чтобы быть общим хирургом. За эти 5 лет ты должен сделать 850 собственных операций. 200 из них это делается в последний год резидентуры. И делается 35 операций в качестве хирурга-ассистента, когда ты ассистируешь обучающим хирургам младших резидентов. Кроме всего прочего, ты заканчиваешь курс по основам лапароскопической хирургии и Advanced Trauma Life Support. Это курс по хирургии травмы. Дальше ты проходишь 96 недель специализации по хирургической онкологии. И это таблица, опять же, с того же самого веб-сайта, сколько пациентов надо прооперировать. 170 за эти 96 недель. И сколько пациентов надо доложить на мультидисциплинарные комиссии. То есть это считается обязательным для того, чтобы быть допущенным к экзаменам по хирургической онкологии. И вот, проведя это 20 лет назад, я мог выполнять вот такие операции. Это 15 лет назад, по-моему, я оперировал, наверное, на 2-м или 3-м году после окончания fellowship. Это пациент с параплегией, пролежнями крестцовой области, и пролежни осложнились плоскоклеточным раком. Вы знаете, этот рак обычно инвазивный, и в этом случае он поражал кости таза. Пациент, поскольку был параплегик уже много лет, согласился на гемикорпоректомию, которая выглядела вот так. И, в принципе, моих хирургических способностей было достаточно, чтобы вдвоем с нейрохирургом, ортопедом сделать эту операцию. Это что касается хирургии, хирургических навыков. Я думаю, что я достаточно себя чувствовал уверенно, чтобы после резидентуры и фellowship, чтобы, в общем, решать любые проблемы онкологических пациентов, которые ко мне приходили и приходят. Далее, к вопросу о совершенствовании своей хирургической практики. Это наша недавняя статья, наш 25-летний отчет из нашего центра по лечению пациентов с перитонеальным карциноматозом. В этой статье приведены все наши данные по годам, какая у нас была осложнение, смертность, исходы по лечению, онкологические исходы по лечению пациентов по каждой нозологии. И благодаря нашей научной работе, которую мы ведем уже 15 лет, мы знаем, что работает, что не работает, как и наши пациенты выздоравливают совершенно по-другому, чем это было 20 лет назад. Это следующая компетенция, да, улучшение своей профессиональной деятельности, того, что ты делаешь. Это следующая компетенция, как выглядит, это пациент по-моему, с меланомой или с Меркл селл карциномой, которая неоперабельна, как вы видите, который пришел ко мне, и у меня для него была подготовлена система лечения изолированной инфузии конечности, ILI. Хирургически это совершенно неинтересная процедура, потому что ты ничего хирургически не делаешь, ты только интервенционные онкологи ставят катетеры, ты берешь в операционную под анестезией, делаешь ишемическую инфузию в течение 30 минут. Ты просто работаешь менеджером и делаешь так, что все системы госпиталя работают на тебя и на пациента, которым все должно идти просто как часы. Если температурный режим будет не тот или концентрация химиопрепарата будет не та, или соскочит турникет, то у пациента будут большие проблемы. Это так утилизируется. Да, и причем до того, как мы пришли в этот госпиталь, это достаточно небольшой госпиталь, совершенно не университетский, это не университетская клиника. Все делали своими руками, в смысле разговаривали с анестезиологами, какие проблемы могут быть у таких пациентов, разговаривали с интервенционными радиологами. То есть никакого протокола до нас не было, и мы должны утилизировать были системы, имеющиеся системы в этом госпитале, чтобы лечить эффективно этих пациентов, как видите, с достаточно интересным эффектом. Как выглядит профессионализм? Профессионализм имеет достаточно понятные формы. Это я на прошлой неделе в отделении патологии. Мы исследуем края резекции рака желудка, который проходил рак желудка Месай-Хай. И края резекции были очень сложно оценить, потому что из-за почти полного патоморфоза опухоли. Я приношу на frozen section, приношу желудок прямо из операционной. Патолог видит мое вовлечение в это, она знает от меня все детали этого кейса, и, в общем, у нас продуктивный профессиональный диалог, и пациент только выигрывает, что не удалось избежать тотальной гастроктомии. Это статья нашей кооперации с гинекологическими онкологами. Как вы, наверное, знаете, очень часто гинекологические онкологи и хирургические онкологи конкурируют друг с другом, отношения у них так себе. И это наша статья, как профессионально мы взаимодействуем во время операции с гинекологическими онкологами во время операции по поводу рака яичника. В этой статье, эта статья совсем не о том, кто где оперирует, это вообще скучно, можно научить любого гинекологического онколога оперировать, удалить селезенку, а можно хирурга-онколога удалить матку с придатками. Это, в общем, не очень интересно. Интересно за другое. Как философия подхода хирургического онколога, который оперирует на перитонеальном карциноматозе, и которого цель ни шагу назад, пленных не берем, вся опухоль должна быть удалена, и отношение гинеколога, который больше знает о биологии опухоли рака яичника и знает, где остановить нас вовремя. Вот это отношение баланса этих сил во время операции. И это гораздо интереснее. И на самом деле именно так происходит это взаимоотношение. Часто общение с пациентом и общение с коллегами оценивается как soft skill. Soft skill – это то, что, в общем, не очень обязательно, факультативно. И, естественно, когда есть выбор между тем, что учиться hard skills или soft skills, конечно, естественно, тем более для хирурга, надо что делать? Быть hard skills, учить hard skills. Но на деле, когда ты работаешь в той системе, в которой я работаю, если ты не умеешь разговаривать с пациентом, если у пациента есть всегда выбор, у него есть выбор делать операции или ехать, скажем, в Мексику для лечения внутривенными инъекциями растворов кактуса и так далее. В общем, тебе надо уметь встать на точку зрения пациента и общаться с ним, общаться не запугивая и зная проблемы. Это вот наша недавняя статья по финансовой токсичности циторедуктивной операции хайпека у наших пациентов. И она нам дает понять, что примерно треть наших пациентов страдает достаточно серьезно от стоимости этого лечения. И, соответственно, это дает возможность встать на точку зрения пациента и аргументированно и эмпатично общаться с этим пациентом. И мы знаем, что я вполне могу сказать, что вот через 1-2 года после операции чувство финансовой токсичности будет снижаться, и это дает мне совершенно другое вооружение для общения с пациентами. Это еще одна из наших статей, недавних статей, как принимаются решения по циторедуктивным операциям в нашей системе. Это компетенция, основная компетенция, как использовать нашу очень несовершенную систему онкологической помощи в Соединенных Штатах при это river plot этот говорит о том, как после диагноза перитонеального карциноматоза только 1/3 пациентов консультируются с перитонеальным хирургом, у которого есть опыт по лечению таких пациентов. И в основном мы смотрим на втором столбике, видно, как мы смотрим, или на третьем, где он тут, когда к нам направляют этих пациентов. И очень может быть, это ведет к тому, что только 1/3 пациентов, которые... Это ведет к тому, что большинство пациентов, которым циторедукция не поможет и не назначается, в основном это пациенты, которые приходят к нам самостоятельно. Опять же, это исследование говорит о том, как мы можем использовать систему, нашу несовершенную систему здравоохранения, где нам надо обратить внимание, чтобы что-то подкрутить. Я не помню уже, честно говоря, к чему я этот слайд вчера сделал. Но это, кстати, пациент, который скоро будет эта статья. Это одна из первых моих статей, где я выкладываю в журнал видео, как мы делали циторедукцию в верхнем отделе живота с резекцией печени. Если видите, она почти полностью окутана опухолью. Ну, в общем, у меня все. Вот такое мое многостороннее вид с многих сторон, что такое хирург-онколог в США. Если будут вопросы, пожалуйста.
Доктор Гущин, спасибо большое за такой откровенный разговор. Вот скажите, если бы у вас была возможность вернуться на 20 лет назад и дать какой-то совет самому себе, молодому, на что стоит обратить внимание, а может быть, на что-то не стоит вообще тратить время, какой бы это был вот piece of advice?
Ну, честно говоря, я так себе завидую, что, то есть, вот как я представлял, вот так оно и случилось, даже лучше. Поэтому я не могу ничего себе по-другому посоветовать.
Может, у коллег в зале есть вопросы? Коллеги, есть?
У меня несколько вопросов. Один из них по системе. Скажите, пожалуйста, как, то есть вот получается, мы говорим о том, что есть отдельная специальность хирургический онколог, а есть куча специальностей, например, там уролог, гинеколог, там еще что-то, да? Вот, или, например, там хирург, которые в США имеют право, и они оперируют большую часть онкологии. Где вот эта вот грань? Когда пациент идет к хирургическому онкологу, а когда он идет, например, там, к гинекологу?
Это отличный вопрос. На самом деле все меняется. 20 лет назад, когда нас выпускали, выпускается хирургов-онкологов на весь США где-то 50 в год, достаточно мало. И идея была такая, что подавляющее большинство онкологических операций должно было быть сделаны общими хирургами. И это leadership такой, позиция, специальность leadership, то есть нас учили давать, там, делать лекции, обучать хирургов, вести МДТ, чтобы своим примером рассказывать, как устроена современная помощь онкологическим пациентам. То есть ни в коем случае это не было движением, что вот им можно делать, а вот эти операции можно делать, а эти операции нельзя, никак не законодательно это не было. И что я увидел, придя в госпиталь наш, в котором делалось где-то 4 ПДР в год, 2 из них погибало. Первое, что нам отдали, это ПДР и резекция печени, потому что, в общем, никто не хотел этим заморачиваться. И из года в год все больше и больше пациентов ко мне шло, которых раньше оперировали общие хирурги, например, со саркомой, так случилось с саркомой, с меланомами. И сейчас, поверьте, я даже не могу себе поверить, все первичные раки толстой кишки ко мне идут. Хотя наши хирурги, общие хирурги очень хорошие и также могут удалить кишку, как и я. В общем, ничего в этом нет. Но вот эта вся морока с МДТ, общение с онкологами, они просто это отнимают очень много времени, и я это с удовольствием занимаюсь. И роль поменялась. То есть, в принципе, это происходит, специализация и поток пациентов направляются, но это происходит через leadership. Это не законодательно. Я ответил на вопрос?
Да. Еще у меня несколько вопросов есть касательно, ну, всем кажется, во всяком случае в мире так говорят о том, что вот если ты делаешь, например, там, не знаю, там 500 желудков, ты их будешь делать хорошо. Вот, если ты делаешь, например, там, не знаю, там 300 кишок или там, 500 кишок, ты будешь делать это хорошо, и, в общем-то, это укладывается в какие-то законы диалектики. Вот. А тут получается специалист, который делает все. Вот, причем в больших объемах. И как это сочетать? То есть как уметь делать хорошо все?
Ну, я думаю, что вы правы. Я просто в такой ситуации, где невозможна такая серьезная специализация. Ну, это можно себе позволить в большом академическом центре, в большом городе. Если ты в private practice, к тебе приходят пациенты, должен решать его проблемы. И да, некоторых пациентов я отправляю, особенно на клинические исследования, в другие госпиталя. Если он не хочет менять систему, ему комфортно, то, в общем, я считаю, что по показателям есть quality control показатели, там, что кишка должна быть там 12 там, лимфоузлов, там, края резекции, что отправляешь ты на адъювантную терапию в течение, там, я не знаю, сколько там, 4 недели и так далее. Если ты выполняешь это, я считаю, что ты вполне можешь это делать. Предела совершенствования нет. Действительно, кривая обучения, в общем, практически бесконечно идет вверх под меньшим наклоном. Но вот, может быть, когда-нибудь это поменяется, да.
То есть я правильно понимаю ваш ответ, что все оперировать хорошо можно?
Ну, очень много можно хорошо оперировать, да.
Даже на малых потоках?
Ну, относительно малых, ну да. Но если ты прошел, скажем, как у меня случилось с ПДРом, у меня не получилось сделать большого потока ПДРов. Я делаю, ну, где-то 5-7 в год, наверное. Я посчитал, что это у меня большой провал. В свое время поехал учиться в University of Heidelberg, чтобы делать, ну, нормальные сосудистые резекции, головку, сохраняющую резекции поджелудочной железы. Это дало мне, в общем, уверенности и понимание, что я действительно могу это делать. И мы смотрим по данным, по онкологическим данным, мы смотрим, какая смертность. Смертности нет уже давно, но и не было никогда, Бог миловал пока. И там края резекции допустимые, да, положительные края резекции лимфуза. То есть вот по таким показателям, если мне кто-то скажет, что тебе это не надо делать, я, наверное, послушаю.
Очень не хочется прерывать ваш разговор. Мы, к сожалению, ограничены во времени. Я думаю, что если остались какие-то вопросы, вы можете обсудить чуть позже, потому что мы должны идти дальше.
Уважаемые коллеги, Тогда мы продолжим данную дискуссию. Может быть, те вопросы, которые вы задавали, ответы найдут там. Кто такой хирургический онколог, продолжит свою точку зрения Гацадзе Илья Давыдович, МД, PhD, руководитель отделения хирургической онкологии American Hospital Тбилиси. Пожалуйста.
Спасибо большое. Ну, после Вадима трудно выступать по двум причинам. Во-первых, выступать после человека с глубочайшим академическим образованием, прошедшим резидентуру и фэллоушип в лучшей системе подготовки врачей в мире и самых оцененных врачей в мире, сложно, во-первых. Во-вторых, после термина «финансовая токсичность» мне выступать еще сложнее, потому что я финансово токсичен для моих работодателей. То есть мы находимся в тех условиях, когда вот вы в Америке изучаете, вы являетесь ли финансово токсичным для пациента, а мы находимся в условиях, когда нам постоянно говорят: сэкономьте, ваша работа фактически по большому счету не нужна, потому что вот есть бариатрические разные хирурги и разные другие более счастливые в хирургии реализованные люди. Вот. Но, в принципе, я тоже собрал какую-то свою часть мнений, и мое мнение вообще, что такое хирургический онколог, постараюсь с вами им поделиться. Ну, в первую очередь поговорим очень кратко об эволюции онкохирургии, и я могу сказать, что отчасти она происходила на моих глазах. Значит, ну вот этой части эволюции я не увидел, но я про нее читал. Это были сумасшедшие большие операции, травматичные операции. И вообще про Михаил Иванович Давыдов, мой вдохновитель в онкохирургии, первый вдохновитель, первый учитель, рассказывал про то, как он реально ссорился с профессором Блохиным Николаем Николаевичем на тему, а вообще выполнима ли операция при раке пищевода, потому что все умирают. Да? То есть нам рассказывали эти истории, показывали определенные документации. Но, в общем, это важный был этап, когда просто формировалась наша специальность, потому что она отличается от многих других специальностей. Мы оперируем фактически в онкохирургии, так как опухоль бывает фактически везде, соответственно, на фоне развития анестезиологии, вернее, ее сначала недоразвития, а потом во многом хирургии же и воины делали анестезиологию более серьезной специальностью. Плюс вот вырезание тканей, отсутствие возможности остановить кровотечение. Все это, естественно, делало онкохирургию до безумия травматичной специальностью, но тем не менее наши коллеги, наши предшественники прошли это, и я застал уже период такого сверхрадикализма. То есть я помню конференции, я помню приезжающего к нам на руки Сасака, это лидеры онкохирургии Японии. Я видел конференции, где они показывали абсолютно сумасшедшие лимфодиссекции. Например, при раке легкого удаление контралатеральных лимфоузлов. Это третья, сейчас уже С-стадия. И это не хирургическое показание, да, но тем не менее все эти вычищения лимфоузлов, пневмонэктомия с циркулярной резекцией, лимфодиссекция D26, то есть от диафрагмы до малого таза. Эти постоянные споры насчет того, какой ты лимфоузел удалил, и демонстрации анатомических картинок, на которых было изображено просто, фактически это был атлас Сидельникова, но изолированный такой, и даже иногда лучше, но в виде фотографий. То есть хирургические онкологи, онкохирурги друг с другом хвастались перед другими хирургами, что они это могут, и это был определенный критерий отбора. То есть, если ты D2 делаешь или D3 делаешь, значит, ты с явным онкохирургическим тестостероном, а если нет, то с эстрогеном. То есть, я видел эту эпоху, но надо сказать, что эта эпоха была, все-таки это было веяние больше азиатской школы, потому что от них это все шло. То есть, эти вычищения. Там потом еще я был на лекции Алторки, который показывал трехзональные лимфодиссекции при раке пищевода и вычищенную анатомию. От лимфоузлов вычищалось все в животе, все в средостении, все на шее. Выглядело классно, больные умирали, но тем не менее, если ты это делаешь, то значит у тебя вот такой вот хирургический, хотел сказать это слово, но не буду. И, безусловно, вот такие вот эти операции, экзентерация органа малого таза, я видел это своими глазами, потому что мой отец был онкоурологом, и он умер в 2008 году, но он сделал много экзентераций на тот момент. И это все происходило во времена, когда не было даже не то что гармоника с лигашу, там с коагуляцией были проблемы. И, в общем, это кровотечение, это смерти, это инвалидизированные люди с огромным количеством стом. Но через это люди должны были пройти. Совсем недавно я был в Стамбуле и видел профессора Бюхлера. И когда он вышел и рассказал про триангл хирургию, вот первый вот этот слайд, в общем, он говорит, что вот если вот этого люди достигают в хирургии поджелудочной железы, вот если этот треугольник виден, то значит вы правильно оперируете. И человек говорит, десятизначные проценты выживания пациентов при раке поджелудочной железы. Я подумал, ну, либо я сейчас должен получить моральную травму, либо выкрикнуть, что вы говорите неправду. Но это же профессор Бюхлер говорит, он очень вообще-то серьезный парень. И, в общем, вот эти все анатомические, вот это все надо было пройти с моей точки зрения. Потому что, так или иначе, агрессивная хирургия, в чем ее плюс? Плюс заключается в том, что хирурги, онкологи отработали на этих несчастных онкологических пациентов фантастические мануальные навыки. И большие операции были отработаны. И кому-то из пациентов они по-настоящему помогли. Ну, может быть, не при раке поджелудочной железы, но при какой-нибудь сложной псевдопапиллярной опухоли или какой-нибудь страшной саркоме, врастающей во все, но у которой неплохая биология, когда нужно сделать большую операцию с резекциями. Кому-то эти все-таки большая хирургия все-таки помогла. Но, к сожалению, много пациентов пострадали от этого. И уже я был, вот мы с Вадимом когда познакомились, он пытался, он вообще первый человек, кто нас как бы приучил к Journal Club определенному, я не знал, что это такое. И мы статьи вместе анализировали, и я-то был там учеником Михаила Ивановича, и, естественно, с этой риторикой приходил на все эти Journal Club. Но вот, наверное, первым человеком, который впервые меня постарался как-то разумно сбалансировать мои идеи, был Вадим. И мы проходили различные статьи, в которых оказалось, что люди прошли через сверхрадикализм и постарались все-таки прийти к тому и задали себе вопрос, а может быть мы делаем что-то лишнее, может быть не всех надо оперировать, может быть нужно чуть-чуть уменьшить это все. И на моих глазах буквально произошло смена декларирования, что D2, D3 нужно, на абсолютно спокойное воспринимание того, что D1 плюс при раке желудка – это вообще нормальный объем. И никто не умрет от какого-нибудь пропущенного лимфоузла. Люди на самом деле умирают абсолютно от других причин. Канцероматоз, метастазы и так далее и тому подобное. И период переосмысления и поиска разумного баланса в эволюции онкохирургии как бы продолжается и сейчас. Но естественно, в разных регионах, в разных хирургических культурах и в странах с разным экономическим развитием это происходит по-разному. Именно сейчас мы, если мы обсуждаем только онкохирургию, мы можем абсолютно спокойно говорить, что лапароскопическая или роботическая хирургия – это стандарт. Хотя всего-навсего 10-12 лет назад мы активно спорили, а может ли быть выполнена онкологическая операция скопическим путем, и до сих пор ко мне приходят пациенты. Я оперирую не только в Грузии, но и некоторых других странах и регионах бывшего Советского Союза. До сих пор многие не то что пациенты, врачи мне доказывают, что вы, оперируя скопически, вы там что-то пропустите, хотя скопически все в 10-15 раз лучше видно на самом деле. И сейчас мы в каком-то, с моей точки зрения, в новом периоде находимся. Это период синхронизации прогресса и технологий, которые неминуемо идут вперед, и понимание, что каждая опухоль индивидуальна, каждый пациент индивидуален, и как мы отличаемся друг от друга по сетчатке глаза, мочке уха и отпечатку пальца, точно так же отличаются все опухоли друг от друга. И синхронизировать усилия клинических онкологов, радиотерапевтов, хирургов и еще и вот эту данность, что все индивидуально, наверное, это и есть такой проспект на ближайшие годы. Что меняет хирургию в наших глазах? Ну, в общем, мы уже поняли, что с ножом за этим заболеванием мы не угонимся и адекватно стали относиться вообще к понятию радикальности хирургии. Тренд на органосохранение. Если 10 лет назад у меня большинство моих пациентов, это были пациенты, я говорю о раке желудка, например, на гастроэктомию, то сейчас на той неделе мы сделали лапароскопическую клиновидную резекцию желудка, потому что на эндосонографии мы увидели, что опухоль Т1А, между Т1А и Т1Б, все объяснили пациенту, но наш специалист, который занимается эндорезекциями, в принципе, можно было сделать хорошую эндоскопическую диссекцию, но он просто сказал, что моя компетенция не такова. Маленькую кривую обучения он прошел, недавно начал, и мы решили просто сделать клиновидную резекцию. Безусловно, я сел пациенту, все ему объяснил, я сказал, что это не совсем стандарт, но просто выполнять вам дистальную резекцию желудка, с моей точки зрения, не нужно. Поэтому мы вам просто клиновидно эндоскопически вырежем. И он меня понял. Сказать мне об этом лет 10-15 назад, ну, я бы, наверное, все-таки сделал бы Д25 с гастроэктомиями и так далее. То же самое у нас после хорошего облучения рака прямой кишки. У нас есть пациенты, которым мы трансанально удаляем рубец. Не только у нас, во всем мире они есть. Но сказать об этом кому-то 10-15 лет назад тоже это было бы большой проблемой. Безусловно, более точная диагностика меняет все. Внедрение рутинной диагностической лапароскопии у пациентов с Т4, Т3 раком желудка, ПЭТ, когда мы там, ну, вот с одной стороны, как бы кто-то это внедряет, с другой стороны, в бывшем Советском Союзе есть регионы, в которых, не буду называть, чтобы никого не обидеть, есть регионы, в которых я был на обходе в одном из городов, и я вижу, что просто все компьютерные томографии распечатаны, и пациентам не делают исследования КТ с внутривенным контрастом. Я говорю, а почему, а зачем? Ну, типа, откроем живот и посмотрим. И как бы, с одной стороны, вот есть интернет, есть чат GPT, есть в Ютубе огромное количество информации. С другой стороны, коллегам, ну, не нужно это по их каким-то причинам. Но, в общем, на самом деле, отселектировать и правильно стадировать пациентов сейчас возможностей намного больше, чем раньше. Главное желание и, ну, хотя бы натренировать хорошо как минимум радиологов. Но, к сожалению, это не всегда работает. Но это влияет на онкохирургию. Мы стали оперировать в эпоху неоадъювантного лечения. Мы стали оперировать, на самом деле, я по себе это ощущаю. Но у нас меньше advanced пациентов практически по всем патологиям. меньше стало пациентов раком желудка, которым мы делаем гастроэктомию. Я уже забыл, когда я последний раз сделал комбинированную резекцию желудка, там с дистальной панкреатоктомией, например. Новые технологии, безусловно, делают хирургию более пациентоориентированной. И если я начал оперировать скопически 10 лет назад, и сейчас скопические операции это где-то 70% моих операций. И мне не хочется эту лапаротомию уже делать, потому что от скопии я получаю больше удовольствия, и пациент более радостен. То есть он быстрее выписывается, и он, самое главное, очень мотивирован. Если раньше пациентов как бы надо было упрашивать 10 лет назад, а можно я на вас потренируюсь и сделаю вам переднюю резекцию, то сейчас он сам просит меня, чтобы я на нем еще больше свои скиллы как бы усилил. Ну, естественно, это слово МДТ, которое меня немножко пугает всегда, потому что оно, я чуть позже об этом поговорю, но это, конечно, враг старого такого доброго онкохирургического героизма, когда клинические онкологи, которым постоянно, а это же лобби, это же секта, да, во всем мире, когда эти ребята сядут и начнут разговаривать о каких-то трайлах и так далее и тому подобное, они тоже нашу хирургическую эрекцию, естественно, постоянно хотят понизить. Тем, что они найдут какой-нибудь метастазик, я немножко утрирую, естественно, или там они скажут, что вышел такой-то вот трайл, а зачем? И реально становится операций меньше, в том числе из-за этого, и это тоже влияет на развитие онкохирургии. Я не говорю, что в плохую сторону, но просто это меняет ландшафт. Глобальная доступность знаний. Есть YouTube, есть огромное количество платформ. Во время ковид-пандемии вообще все увидели, кто как оперирует. И, безусловно, в основном онкохирургия меняется из-за более глубинного понимания того, что любой рак индивидуален, что мутации заранее непредсказуемы и что их нужно изучить у данного конкретного пациента. И я уверен, что в будущем по мутациям будут ставиться хирургические показания. Мы будем оперировать каких-то пациентов, которых мы сейчас, может быть, не оперируем. Например, там множественные метастазы рака желудка в печени, но у пациента с такой мутацией, допустим, да, откроется какой-нибудь MCI-25, у которого можно удалением опухоли, правда, продлится жизнь, потому что существует какая-то кейтруда 25-го поколения, например. Что будет дальше? Я спросил у чата GPT, он вот, посмотрите, много умных слов написал. Безусловно, будут внедряться различные технологии, искусственный интеллект. Кроме этого, он говорит, что будет меняться система оплаты этих пациентов, оплаты за труд, будут гибрид 2.0 операционные и так далее и тому подобное. Все это, естественно, будет, но где-то на другой планете, потому что до нас все это будет доходить очень-очень долго. Наша реальность немножко другая. Я никогда в жизни не думал, что я вот этот слайд включу в хирургическую презентацию. На самом деле мозаицизм – это генетические разнообразия. И это, с моей точки зрения, неотъемлемая часть, оказывается, эволюции. И наше развитие вообще онкохирургии в нашем регионе, давайте не будем какую-то географию говорить, наверное, во всех развивающихся странах мира, просто я не во всех был, но оно очень-очень мозаично. Во-первых, во многих учреждениях материально-техническая база не отвечает даже минимальным абсолютно требованиям. Эго боссов его никто не отменял, и я постоянно это ощущаю, что многие люди, которые не очень хотят, давайте так, препятствуют развитию современного мышления, они просто мешают всему коллективу развиваться. Процесс эволюции, в том числе естественный отбор и возраст их постепенно с арены убирает, так это жизнь, но тем не менее они все-таки свой след и отпечаток в головах наших коллег многих оставляют. В том числе онкохирургия, к сожалению, она затратна. Вообще система, если бы у нас не было бы финансовых преград, мы бы развивались бы намного быстрее. А если бы нам еще платили бы деньги хорошие за наше развитие, мы вообще были бы фантастическими ребятами. Но, как правило, все наоборот. Как правило, мы должны рестерилизовывать, искать дешевую опцию. Это даже и в Америке, и в Японии, наверное, та же самая картина. Но у нас она намного выраженнее, и нам намного сложнее имплементировать что-то новое. Кроме этого, есть проблема привилегированности в онкохирургии. Некий непотизм, кого-то подпускают к столу, кого-то нет. Вадим рассказал, что хирургический резидент должен сделать 850 там какое-то количество операций. Я 850 раз не был намыт в операционной за всю свою ординатуру, аспирантуру, зато 8500 историй болезни написал. А в них написал 85 тысяч знаков препинания и так далее и тому подобное. Это была наша жизнь. И это продолжается. Я знаю очень мало людей, кто воспитывает молодежь, стоит и помогает ассистенту, стоит, помогает молодому человеку, молодому специалисту. Это большая проблема. То есть, если бы нас еще и натренировали всех, мы бы, наверное, были бы Криштиану Роналду в хирургии все, а мы вот без тренировок, абсолютно вопреки, пытаемся что-то внедрить. МДТ-борд и командная работа. Это, конечно, очень классно, когда об этом говорят. Но когда ты садишься с людьми, которые ничего не читают, мало что понимают, ошибаются, не тренируются, то этот МДТ-борд превращается очень часто не то чтобы в пустую трату времени, а может там еще и когда, если голосовать, и если немножечко не включить свой тестостерон, то многие люди Вот, допустим, наши клинические онкологи, с некоторыми, с которыми я работал, они просто читают заключение. А тут написано вот так, и этому верят. А я всегда перепроверяю. То есть компетентность людей, которые садятся с тобой в так называемый NDT-борд, это огромное значение имеет. Но она должна быть высокой. В перспективе люди должны развиваться вместе. Наверное, это и есть идея всего этого MDT-борда. Но происходит ли это в реальной жизни? В моей нет. То есть нам понадобилось много-много времени, чтобы селектировать из всех тех людей, с которыми я занимаюсь онкохирургией и вообще онкологией, селектировать несколько людей-энтузиастов, которые поверили в то, что нужно развиваться. Потому что развиваться люди в целом не очень любят. Еще одна проблема нашего региона – это то, что профорганизации очень часто бывают неэффективны, и во главе этих организаций стоят конъюнктурные люди, которые мешают развитию. И кроме этого, прозрачность и открытость коллег – это самая большая проблема. Если спросить хирургов нашего региона, что вы оперируете, ответ – все. Что вы умеете, ответ – все. Если у вас осложнения, их, как правило, нет. Вы оперируете ли вы, допустим, лапароскопически? Да, но потом ты узнаешь, что там просто в том учреждении нет стойки. Но лапароскопически они где-то как-то оперируют. И, наверное, это вообще то, о чем я поговорил, это сценарий развивающихся стран. Что делать? Ну, учиться надо. Как учиться? Сейчас вот я нашел пару энтузиастов у себя в Тбилиси, и мы учимся, сначала мы начали коммуницировать друг с другом. Следующим этапом должен быть обязательно аудит собственных результатов. Мне об этом говорил раньше Вадим. Я воспринимал это с болью, потому что, когда мы посчитали свои результаты, они очень далеки оказались от вообще тех результатов, которые я думал, если все честно посчитать. То есть, оказывается, у нас намного больше осложнений, чем должно быть, чем хотелось бы и чем мы думали. Но потом я попросил сделать такой же аудит моих коллег. И только 1 из 5. У нас на всю Грузию 5 онкохирургов, которые занимаются только онкохирургией. И которые оперируют хотя бы больше 10-15 кейсов в месяц, именно онкохирургических. Никто не хочет считать, но один посчитал и что-то в глаза мне напрямую не смотрит, когда я спрашиваю, покажи результаты, пришли. То есть на самом деле, если мы не научимся делать аудит себя, анализировать это и про это говорить прозрачно, перспектива развиваться крайне туманная. И дальше в моих идеях, когда я коммуницирую с этими людьми, я говорю, давайте пойдем именно с данными наших аудитов к работодателям, в министерства, в разные ведомства, страховые компании, и им скажем о том, что смотрите, у нас результаты такие, а они могут быть лучше, если и так далее. То есть на самом деле я учился, когда нам говорили, что мануальные навыки – это самое главное. Потом, сейчас онлайн-образование – это тоже очень важно. Стажировки, конгрессы, копи-пейст учителей и все общепринятые вещи, которые нужны для воспитания хирурга-онколога, это правда важно. Но коммуникация друг с другом и аудит, сейчас я занимаюсь тоже, как Вадим, смотря с какого, если с ординатуры, то я уже больше 20 лет в онкохирургии. Если после получения лицензии, то 18. И я сейчас только понял, как важно коммуницировать и как важно проводить аудит, и как важно быть прозрачным и честным. И не только с коллегами, но и с пациентами. Не предлагать им операции, на которых ты будешь оттачивать свои какие-то хирургические вещи. Или я могу открыто сказать, что я оперирую Клацкинов мало, и я вам делаю трисекционэктомию. Но эта трисекционэктомия у меня 1 раз в 2 года. Это сложно сказать на самом деле пациенту, но я думаю, что это надо делать. Или отправить его куда-нибудь туда, где это делают чаще. Может, он выберет и доверится вам, тогда хотя бы вы честны. То есть честная коммуникация, честный аудит, честно с коллегами, честные данные. С моей точки зрения сейчас для нашего будущего, пока до нас дойдут все роботы, гибридные операционные и интегрированные различные ламинарные потоки воздуха в наш интеллект, пройдет время. Но считать и быть прозрачными мы можем и сейчас. Эволюция – это когда какая-то мутация закрепляется, закрепляется в геноме и меняет какой-то признак. Меняться мы не любим, учиться мы тоже не очень любим, но самая главная мутация, которая для дальнейшего развития онкохирургов должна в нас, вот я за себя говорю, не за вас, за себя, это мутация прозрачности и честности. Это самое главное. Вот на сегодняшний момент уже для тех людей, кто чуть-чуть вот устоялся в профессии, понюхал порох, может сделать там какие-то стандартные операции, аудит и честность – это самое важное. Есть, конечно, и хорошие новости. Мы привыкли работать с ограниченными ресурсами, импровизировать. Без страсти в онкохирургии в нашем регионе оставаться сложно, потому что каждый пластический хирург и пересадчик волос намного более оценен и реализован. И кроме этого, мы умеем адаптироваться к сложным ситуациям. Задренировать без дренажа, например. Или соперировать пациента, когда у тебя ломаются все девайсы. Или, допустим, сшивать ткани степлером, срок годности которого закончился полгода назад и так далее. Это, безусловно, в нас развивает какие-то особенные навыки. Они не очень хорошие, но, с другой стороны, они позволяют нам хоть как-то продвигаться вперед. И у машин, конечно, таких навыков никогда не будет. Не будет искусственного интеллекта, который сможет сшивать теми аппаратами, которые в принципе не работают. Таким образом, онкохирургия будет еще глубже пациент-ориентированной, более технологичной. Хирург-онколог будет больше интегрироваться в науку и исследования. Это, оказывается, тоже очень-очень важно. И кроме этого, безусловно, новые знания о молекулярной биологии опухоли, о индивидуальности биологического устранения будут менять ландшафт нашей специальности. Таким образом, кто такой онкохирург? Да? Мировой тренд, он более или менее ясен. Но выбор за каждым из нас. Каждый из нас должен, вот сам, как мы выбирали когда-то профессию, как мы выбирали когда-то путь, где мы будем работать, каждый из нас в условиях, когда нет какой-то ярко выраженной системы, нет хорошего финансирования, нет нормальной оценки труда. И очень часто многие хирурги в регионе все равно думают о том, как бы заработать леваками и так далее и тому подобное. В этой системе говорить о высоких материях сложновато. Но выбор все равно остается за каждым из нас. Но нужно помнить, что эволюция, прогресс – это абсолютно неизбежная вещь. Мы, несмотря на то, что мы далеки от супер хороших там технологий, они заходят, но с опозданием. И идеология наша меняется с опозданием. Тем не менее, все равно рано или поздно весна придет, а за ней придет лето, а за ней придет осень. Какой бы там микроклимат ни менялся, все равно эволюция не закончится. Поэтому нам нужно стараться, несмотря на все сложности, стараться соответствовать тем мировым стандартам, которые формируются в тех странах, которых считают даже финансовую токсичность. Спасибо.
Илья Давидович, спасибо большое за ваш такой честный взгляд на эту профессию. У нас, к сожалению, нет много времени для вопросов. Я хочу просто для наших коллег оставить право подойти к вам и спросить какие-то вопросы. Если к концу нашей сессии останутся время, чтобы обсудить, тоже можем. Спасибо большое. Продолжим.
Я приглашаю на сцену Константина Зирова. Я с ним знаком много лет с программы Высшей школы онкологии. Сейчас он возглавляет одну из ветвей программы школы онкологии ИПСМ, которая действует уже второй год в Казахстане. Константин, пожалуйста.
Так, всем здравствуйте. Спасибо за представление. Спасибо всем, что вы остались в столь поздний час. как сказал Илья, сложно выступать после Вадима. Мне теперь еще стало сложнее выступать после больших хирургов и в прямом, и в переносном смысле. Но я постараюсь, чтобы вам было не скучно. Так, это слайд о конфликте интересов. Ну, я, пожалуй, начну сдалека. За годы независимости в Республике Казахстан был пройден свой уникальный длительный путь. Появилось множество образовательных инициатив в виде таких, как программа «Балшак», система образования интегрировалась в Болонский процесс. Как мы видим, даже на конференции множество специалистов из различных стран. Налажена коммуникация, то есть республика интегрировалась в международное пространство, международное научное сообщество, формируется нормативно-правовая база, появились различные высокие технологии, как трансплантации, радионуклидная диагностика. И все вместе это, по сути, стало платформой и почвой для того, чтобы на это могли зарождаться, появляться и возникать запрос на дополнительные образовательные инициативы. IPSM – это международный некоммерческий проект, дополняющий стандартное образование студентов резидентур медицинских вузов в Республике Казахстан. Он стартовал в мае 2023 года, когда мы начали прием заявок. За это время у нас сформировался уже пул резидентов, их 29, они по различным направлениям, и сейчас у нас продолжается открыт новый набор. Это был достаточно сложный период со своими достижениями и со своими проблемами, о которых я поведаю чуть позже. Любая образовательная инициатива, которая делается не по наитию, не из общих соображений, подразумевает, что она делается исходя из каких-то запросов, исходя из чьих-то ожиданий. Для того, чтобы их оценить и узнать о них, мы провели ряд исследований. Например, это были глубинные интервью, выполненные с социальным антропологом. Мы получили представление о том, как те или иные представители различных групп, будь то пациенты, медицинское сообщество в виде экспертов, клинических кураторов, сами резиденты Министерства здравоохранения, как они в своей голове представляют и что они ожидают от современного клинического онколога. Почему эта работа была проделана? Потому что, на наш взгляд, невозможно прийти в какое-то место и просто вот воспроизвести. Нельзя перенести Джон Хопкинс сюда, нельзя увезти отсюда какую-то крутую вещь в другую страну и просто воспроизвести, потому что существует всегда свой социально-культурный ландшафт, существуют свои ожидания и представления о том, как это должно быть, и оно не должно быть одинаково там, в Соединенных Штатах либо в Республике Казахстан. На текущий момент программа представлена 3 направлениями. Это солидная онкология, гематология и патоморфология. Все программы стартуют одинаково. У нас есть общий семестр, где мы позволяем сформироваться некоторой среде, чтобы резиденты начали между собой коммуницировать. Это обязательная часть. И тем самым позволяет сохранять эту связь уже спустя время, как спустя годы, несмотря на то, что они будут находиться там, заниматься различными нозологиями, решать различные проблемы, не знаю, сидеть в различных учреждениях, но тем самым возможность построить большую социальную сеть, которая, на наш взгляд, очень важна в любой специальности, но в нашей, может быть, чуть больше. Прежде чем резиденты попадают к нам в программу, они проходят отбор. Этот отбор представлен многоэтапным процессом. Естественно, есть такие базовые, как заполнение заявки, прохождение онлайн-тестирования и по общей медицине, написание мотивационного письма. Дальше их ждут онлайн-собеседования. Это одна из самых интересных частей, потому что к нам иногда на ней сами резиденты или участники, участвующие в процессе, студенты выражают свои протесты, недовольство и так далее. Объясню почему. Кроме проверки знаний и знания английского языка, часто мы подвергаем участвующих в отборе тестированию ценностным и этическим вопросам, что это для нас значит. Раньше мы больше обращали внимание на то, какие имеют медицинские знания резиденты, как они там классно разобрались, какие они молодцы там и так далее. Но спустя время становится понятно, что их подготовленность, их ожидания, их мотивация к тому, чтобы быть онкологом, медицинским онкологом, хирургическим онкологом, без разницы, патоморфологом или гематологом, оно оказывает большее влияние на то, как они успешно будут проходить программу, потому что пробелы в медицинских знаниях заполнить возможно и сильно проще, чем решить вопросы с мотивацией, ценностными или там, этическими представлениями того или иного человека. Вот такой схемой можно представить, как происходит у нас образовательный процесс там, на примере одного из занятий. Например, что такое потребность? Ну вот мы узнали в результате нашего исследования, что пациенты ожидают, что их больше будут включать в принятие решений. Это в Казахстане, это казахстанские пациенты, чтобы им не отказывали в экспертности, чтобы они были услышаны, или чтобы им могли просто донести там, то, о чем доктора говорят, для чего они делают и так далее. Соответственно, ну, допустим, мы там, на примере рака молочной железы, там, непонятно для чего там адъювантная терапия, этому нужна пациенту, доктор разговаривает какими-то там непонятными словами, там, конечные точки, безрецидивная выживаемость, общая выживаемость, вообще, ну, иногда онкологам самим непонятно, пациентам тем более. Вот. Тем самым мы выбираем, что нужно резидентам попробовать на занятии, разобрать, что это на самом деле, научить их и доносить эти слова до пациентов простым, понятным языком, но при этом сохранить профессиональный язык для своих коллег. Образовательные технологии – это то, как мы выбираем, как их этому можно научить. Существуют различные форматы. Далее происходит само занятие, и после занятия мы собираем фидбэк и оцениваем образовательный эффект. Если это сработало, здорово, двигаемся дальше. Если нет, мы анализируем, что у нас не получилось, что пошло не так, очередная итерация, и мы пытаемся улучшить там, от занятия к занятию, от темы к теме. Какие форматы у нас есть? Ну, всем знакомые, уже надоевшие, может быть, но тем не менее, журнальные клубы, клинические разборы, семинары по темам. Глобально на них у нас нет никакого уникального знания, мы не можем взять, переложить, и я выступаю против этого, чтобы перекладывать кому-то в голову стрелочки в NCCN, просто пересказывать слайды об одном исследовании там, с результатами общей выживаемости, дизайн. Мы хотим научить резидентов, чтобы они могли сами знать, что за каждой этой стрелочкой стоит, почему так или иначе формируются эти стрелочки, а воспроизводимы ли они в тех реалиях, в которых они существуют. И даже если да, то как бы, чтобы все эти знания помещались в тот контекст, в котором находится пациент, что пациент не находится там в отрыве от своей работы, от своей семьи, что ему нужно ездить на лечение куда-то, и насколько это актуально для этого пациента, потому что, возможно, там 1% к прибавке там, к общей выживаемости для американского пациента, не знаю, там, для европейского пациента это что-то важно, а для пациентов в Казахстане, может быть, важнее будет меньше времени провести в больнице, меньше видеть доктора и провести там больше времени со своей семьей. У нас есть клинические базы, университеты, партнеры. На самом деле это самая важная часть программы. Одной из таких баз является Национальный научно-онкологический центр, многопрофильная больница номер 3 и многие другие центры гематологии. Это то место, где происходит на самом деле становление врачей и резидентов. Как я уже сказал, что мы дополняющая все-таки образовательная инициатива. Мы убеждены, что невозможно стать врачом вне клинической практики, вне постели больного, вне операционной. Никто никогда врачом не становился и никогда не станет. Вот. Для нас клинические базы университета – это не просто инфраструктура, там, стены, в которые ходят резиденты. Это пространство, и благодаря нашим клиническим кураторам создается та образовательная среда, где они могут приземлять свои знания, где они их могут получать на них фидбэк, где клинические кураторы либо их коллеги вокруг могут проводить их по, вот, скажем так, траектории доверия, когда там от статуса там, ничего нельзя доверить, можно доверить под наблюдением, либо можно доверить делать самостоятельно. За время существования проекта IPSM мы привлекли более 40 специалистов из различных стран, континентов к образовательной деятельности. Я вам скажу, этот процесс достаточно трудоемкий, болезненный, и это не зависит от того, откуда преподаватели, будь то они там условно из восточных стран, либо это западные страны. И даже если человек вырос и получил образование в западной системе, это не гарантирует, что он будет спокойно там воспринимать наши запросы, они у нас постоянно высокие и постоянно растут, мы постоянно пытаемся напрягать все наших преподавателей больше, но спустя время у нас потихонечку выкристаллизовывается динамическая группа там преподавателей, которые готовы активно участвовать в образовательном проекте, выступать на стороне резидентов, что является для нас одним из важнейших критериев. Что у нас для этого есть? У нас есть система сбора фидбэков от преподавателей, в том числе от преподавателей на резидентов, но и от резидентов на преподавателей. Если мы видим, что нет образовательного эффекта, если нет интереса, то как бы тогда наша коммуникация может на этом завершиться. Бывает так, что у нас есть образовательный эффект, но резидентам не нравится в такой ситуации. Мы понимаем, что мы же занятия и делаем не для того, чтобы они просто нравились и не были скучными, а для того, чтобы они оказывали какой-то эффект, мы двигаемся дальше. Но пытаемся как-то улучшить какую-то антуражную составляющую в таком случае. Как мы понимаем, что у нас что-то получается или не получается, это, наверное, самый сложный, самый болезненный этап, потому что это, может быть, все классно, мы там целый блок прошли, тебе кажется, что вот, резиденты должны были точно что-то отсюда вынести и освоить. У нас есть такое мероприятие, как так называемая аттестация. Каждый блок или пару блоков студенты ее проходят. Мы этот инструмент используем с целью проверки усвоения материала и обнаружения пробелов в знаниях. Аттестация состоит из нескольких этапов. Это тестирование и практическая часть. Для нас аттестация – это не способ того, чтобы сказать, кто-то хороший, кто-то плохой, кто-то может быть хорошим доктором, кто-то не может быть хорошим доктором. Мы не можем ответить на этот вопрос. Для нас это платформа или место, где мы можем обнаружить слабые места, где мы можем подсветить слабые места как там, у индивидуального резидента, так и в том, где мы могли допустить проблемы в образовательном процессе и возможность как бы двигаться дальше и расти. За это время мы уже провели множество аттестаций, это всегда уникальный процесс. Я, когда был студентом, не думал, что вообще экзамены могут быть какими-то полезными или интересными. Но теперь, как человек, который принимает этот экзамен, я каждый раз для себя отмечаю, что там резиденты могут озвучить какую-то мысль или что-то сказать, что для меня в том числе несет там образовательную пользу. Я думаю, что для резидентов это тоже так. Тот фидбэк, который я получаю, что это, наверное, одно из важнейших мест, где происходит рост наших резидентов. Естественно, за время существования программы у нас возникло множество проблем и сложностей, как бы без них нигде не бывает. Наверное, самые маленькие из них это были организационные проблемы. Когда просто программа стартовала, нужно было решить вопросы, где, как будут проходить занятия, наладить там техническую часть, Zoom, звук, камера. Естественно, все это как бы тоже является барьерами для образования. Чем меньше барьеров, тем как бы больше времени будет затрачено на образовательную часть, и тем больше будет с людей спроса, как бы. Вот. Естественно, стипендии – это огромная проблема. Мы, к сожалению, на текущий момент не имеем возможности выплачивать стипендии, но я считаю, что, несмотря на то, что данных о том, что внедрение стипендий на качество обучения или на результаты в обучении особо нет, точнее, они не подтверждают это. Тем не менее, я считаю, что как бы будет в идеале мы двигаться должны к тому, чтобы это было безусловно частью любой резидентуры, любой программы, для того, чтобы там, у человека не стоял выбор между там, выживанием и образовательной частью. У нас у резидентов, естественно, были разные ожидания от образовательного проекта. У них разный бэкграунд, образовательный, социальный. И это, естественно, накладывало свои отпечатки и сложности, потому что иногда люди представляют, что придя в какое-то учреждение, у них остается опыт студенчества, что им сейчас передадут какое-то уникальное знание, что им сейчас вот вручат этот свиток дракона, и внезапно они будут разбираться, не знаю, там, уметь лечить все и сразу, и все будет классно. К сожалению, в жизни так не происходит. В любом случае, ты должен будешь пройти через боль, страдания, время, которое должно быть затрачено на этот процесс. Мы стараемся сделать его чуть-чуть менее болезненным, но тем не менее это там необходимая часть. Несогласованность образовательного плана и клинической практики. Что я имею в виду? Допустим, у нас резиденты проходят блок по раку молочной железы, либо там, по колоректальному раку. В этот момент они все, естественно, ротируются в разных местах, видят разных пациентов, и не всегда им удается одномоментно приземлять этот опыт вот здесь и сейчас там на практику. Возможно, они встретят этих пациентов чуть позже, кто-то встретил их чуть раньше. Я не считаю, что это большая сложность. Я убежден, что ни в одной клинике мира, там университетской, не будет так, что ты будешь видеть пациентов, которых тебе вот вчера лекцию прочитали, или вы вчера разобрали там мозаик трейл, завтра пошли и посмотрели пациентов на адъювантные, для адъюванта там у пациентов с колоректальным раком. Так не бывает, потому что у клинической базы всегда есть тоже свои потребности, которые должны быть услышаны, увидены, ну, и приняты, и поняты. Уровни мотивации, ну, это все вместе, это тоже приводит к сложностям в уровне мотивации. Мы все разные, естественно, у кого-то там больше мотивации учиться, у кого-то больше мотивации зарабатывать, у кого-то там иные какие-то мотивации есть. К сожалению, не так множество инструментов есть у меня, как у программного директора, для того, чтобы там влиять на эти мотивации, кроме как там поддержки там, на тех этапах, когда они проходят там, по кривой обучения, либо там, по уровню осознания своей компетентности или некомпетентности. Планы на будущее. Наверное, самое главное, что наши резиденты должны будут перейти из статуса обучающихся в статус обучающих. Совместные научно-исследовательские работы, в которых потихонечку наши резиденты начинают принимать участие там, и помогать клинической базе в продолжении развития этих элементов. Также интеграция в систему образования Республики Казахстан. Ну и налаживание международных связей между программой клинической базы и клиническими базами наших преподавателей из других стран. Это то, что позволит, мне кажется, сделать программу более стабильной, более чувствовать себя уверенно. Ну и по итогу ожидается, что получится сообщество выпускников как залог независимой и автономной системы воспроизводства образования. Естественно, что на это потребуется время, но с тем, что потребуется время, мы делать ничего не можем. Вот. Спасибо всем за внимание. Если будут вопросы, постараюсь в рамках своих компетенций на них ответить.
Можно короткий вопрос? Я правильно понял, что это высшая школа онкологии, но в Казахстане?
Мне на этот вопрос всегда сложно отвечать, я, честно говоря, не знаю. Я выпускник высшей школы онкологии. Безусловно, огромная часть вещей, которые сегодня делается в IPSM, это в том числе воспроизведение опыта высшей школы онкологии, но тем не менее это образовательный проект со своими особенностями. Вот. Я не знаю, на этот вопрос, может быть, может ответить Вадим или Илья как-то. Мне сложно ответить на этот вопрос.
Во-первых, Кость, отличная презентация, мне даже понравилось, что такая получилась школа. Это во-первых. Во-вторых, да, это совершенно другое, уже она строилась изначально как не на коленке, что называется, и не из общих соображений, а по тому, как строятся все другие образовательные проекты, которые имеют шанс на долгосрочность. Как вы видели, был проведен настоящий needs assessment, то есть это настоящая исследовательская работа. То есть все процессы мы стараемся воспроизвести, которые вот под капотом любого университета. Мы не просто садимся в машину и едем, а мы знаем, как прикручены колеса, работает двигатель и так далее. Ну вот, то есть это совершенно, когда мы делали ВШО, во всяком случае, я это делал из общих соображений, я не знаю, как само случилось, но такого не должно быть, мне так кажется. Если есть гораздо лучший способ делать все осознанно, то это надо делать именно так.
Спасибо, Вадим. Вопросов нет? Всем? Да. Нет, это дополнительная образовательная инициатива. Мы не являемся резидентурой автономной. Наши резиденты поступают в те резидентуры, которые есть в Казахстане. Чаще всего это либо медицинская, ну, либо онкология, либо это резиденты хирургических специальностей, находящихся на различных этапах обучения. Вот.
Я думаю, что у нас подошло время к самому интересному. Во всяком случае, для меня очень интересна эта тема, роль симуляционных технологий в обучении резидентов. Виталий Сазонов сделает этот доклад. Просим.
Спасибо большое. Когда это в продолжении разговора то, о чем начал говорить Константин, то есть чему мы учим и как учим. И вот симуляционные технологии — это всего лишь инструмент в обучении. Причем здесь первая вот строчка, да, премиум non-nocere, потому что когда мы говорим о симуляции, симуляция всегда подразумевает под собой, что мы стараемся не навредить. В первую очередь мы стараемся не навредить пациенту, потому что симуляция не подразумевает под собой прямой контакт с настоящими пациентами. То есть это либо стандартизированные пациенты, которые научены быть пациентом, да, они знают, это роль просто, они актеры. Либо же это какие-то манекены, либо таск-тренеры и так далее. И что для меня очень важно, что когда мы говорим о симуляции, мы также стараемся в симуляции не навредить студентам, потому что если в реальности они что-то сделают не так и навредят живому человеку, пациенту, то это может нанести какую-то психологическую или, может быть, какую-то другую травму. Поэтому симуляция — это всегда о безопасности пациента и о безопасности студента. Когда мы только начинаем говорить про симуляцию, кажется, что это какие-то высокие технологии, космические корабли и так далее, но на самом деле не так. Если вот среди наших коллег есть те, кто учился в мое время или, может быть, даже раньше, и вы помните, что мы много времени тратили на то, чтобы решать какие-то клинические задачи в подвальных помещениях, так вот тогда клинические задачи — это и были те самые симуляционные технологии, которые немножко сейчас переросли, и сейчас мы эти же самые клинические задачи решаем, может быть, немножко на другом уровне. Всегда было так, что симуляция — это было что-то, что касалось каких-то life support courses, да, то есть basic life support, advanced life support и так далее, то есть что-то такое очень экстренное и ургентное. И когда надо было отработать какой-то навык до автоматизма, и вот кажется, что в онкологии не о чем разговаривать. На самом деле, если смотреть те тренды, которые опубликованы, и статьи, которые уже сейчас есть, и мы можем их использовать, то с каждым годом этих статей становится все больше и больше именно про симуляцию в онкологии. И обратите внимание, что вот на этих трендах есть два таких небольших пика. Да? Один пик пришелся на тот момент, когда симуляция была признана золотым стандартом и обязательным в медицинском образовании, и второй пик пришелся на момент пандемии. Да? И потом чуть пошел спад, но тем не менее все равно еще есть такое периодическое опубликование статей, которые касаются симуляции именно в онкологии и использования. Очень много используется в виртуальной реальности и каких-то других. Итак, несколько практических вопросов. Что симулировать? Да, то есть мы говорим, что мы можем симулировать клинические навыки, это в том числе вот эти самые клинические задачи, расшифровка клинических данных. Вот ребята, которые здесь, наши выпускники, сейчас резиденты, которыми я безумно горжусь, вы точно можете сказать, что когда у нас проходит самый страшный экзамен, который называется ОСКИ, обязательно одна из станций посвящена тому, что вам нужно что-то интерпретировать. Лабораторные данные, данные КТ, МРТ и так далее. И в том числе в эти же навыки входит взаимодействие междисциплинарное такое. Процедурные навыки — это вот конкретно вот на этих фотографиях вы видите, что эта сессия посвящена игольной биопсии щитовидной железы. Это студенты второго курса у нас делают. Время курса эндокринологии, если я не ошибаюсь. Досик вот очень хорошо показывает. Какие-то другие процедурные навыки тоже. Ну и, конечно, очень много уделяется внимания коммуникационным навыкам, потому что в онкологии сообщить пациенту, то, что называется breaking bad news, да, сообщить пациенту о том, что у него рак, это тоже в некоторой степени должно быть сделано правильным путем. Ну и, конечно, все неотложные ситуации, которые могут касаться онкологии и не только онкологии, да, то есть это тумор-лазис синдром, какие-то другие сепсис и так далее, тоже мы можем отработать в симуляционном центре, закрепить этот навык, и когда ребята уже приходят в клинику, техническая часть уже отработана. И то, что уже было упомянуто, да, то есть ОСКИ — это самый страшный экзамен, но перед этим есть много этапов, которые тоже можно оценить, и вот симуляция — это то, что позволяет нам объективно подойти к оценке студентов. Ну, по крайней мере, мы так думаем. 3 основных столпа симуляции, которые могут быть использованы как в решении простых клинических задач, так и высокотехнологических симуляций. То есть это пребрифинг, то есть объяснение, чего мы хотим от вас во время симуляции или симуляционной сессии. Это сама симуляция, то есть это моделирование, это клиническая задача какая-то. И в конце, когда все уже закончилось, мы должны провести разбор полетов, да, дебрифинг. То есть мы обсуждаем, есть специальная система, что мы можем обсуждать во время дебрифинга. То есть мы спрашиваем, что было эмоционально составляющая, да, что было сделано классно и что можно в следующий раз улучшить. То есть мы, когда делаем дебрифинг, мы никогда не говорим, что вот это вы сделали прям совсем плохо, ребята, ну как вы так могли, да? То есть мы такое не делаем. Есть специальная система, когда мы это делаем. Да, и почему симуляция важна в онкологии? Это как раз таки связано с тем, что онкология – это такая вот специальность, которая всегда на грани и связана с жизнью, и связана со смертью. Да. И я очень благодарен онкологам персонально, потому что благодаря работе онкологов Караганды, скажем, да, моя мама до сих пор жива. И вот симуляция помогает вот все эти пункты преодолеть, то есть эмоциональную нагрузку, да, какие-то этические моменты оговорить, отработать, какие-то междисциплинарные моменты тоже отработать в симуляции. То есть когда дело дойдет до реальности, техническая часть, да, какой-то алгоритм уже будет уложен в голове и будет гораздо проще решать. Ну и вместо заключения пару коротких таких моментов, что симуляция, несмотря на то, что это звучит очень просто, на самом деле этому нужно обучаться. То есть это тоже такой момент в медицинском образовании, который, ну, надо тоже образовываться. Симуляционное обучение должно быть доступно. То есть это не так, что у нас есть какие-то хорошие манекены, у нас какие-то тест-тренеры, и вот они лежат под тряпочкой, и мы их показываем только тогда, как к нам кто-то в гости приходит. На самом деле наши манекены, и я радуюсь, когда наши манекены уже испорчены, и их нужно заменять. Есть ряд публикаций, которые говорят о том, что нет большой необходимости в использовании high-fidelity манекенов, то есть высокотехнологических манекенов. То есть хоть какие вы манекены используете, это все равно в конечном этапе приведет к одинаковому результату, к одинаково хорошему результату. Но и последний момент, что симуляционное обучение может улучшить знания и навыки резидентов, однако не так много доказательств того, что симуляционное обучение улучшает результаты лечения пациентов. Таким образом, есть возможность использовать симуляцию, используйте. Нет возможности, ну, придумайте, как использовать ее. Спасибо большое. У меня все.
Спасибо большое. Отличный доклад. Мне очень понравилось. Как говорил мой профессор по симуляции, когда крокодил плачет, слезы не настоящие, но крокодил-то настоящий. То есть должно быть ощущение, вот fidelity, это вот ощущение того, что что-то настоящее. Очень правильные слова, спасибо.
Спасибо большое, классный пример, я его тоже буду использовать теперь.
Так, коллеги, у нас будут вопросы или мы будем завершать уже как бы по времени? Ну тогда, коллеги, мне разрешите наших спикеров поблагодарить. Доктора Вадима, доктора Сазонова, поблагодарить наших слушателей замечательных за команду молодежи. У нас там далеко находится Илья, тоже огромная благодарность. И всех, кого не назвал. Есть что добавить?
Не, по-моему, очень здорово получилось. Спасибо большое, да.
Спасибо, было приятно.
Спасибо всем, у кого остались силы, чтобы поприсутствовать на заключительной сессии. Я благодарю всех, кто сегодня принял участие в этой конференции, техперсонал, модераторов и докладчиков. Я думаю, что наши идеи, которые и цели, которые были заложены на этой сессии, реализовались. Вот. И какие-то ауткамсы, которые будут, мы их обязательно где-то постараемся отразить. Спасибо.